Good morning and welcome to SAMHSA, the Substance Abuse and Mental Health Service Administration's first ever virtual behavioral health and criminal justice symposium. Wherever you may be across the nation, we are pleased you have joined us for this important event. I'm Dr. Lark Wong. I direct the Office of Behavioral Health Equity and Justice and coordinate the Behavioral Health and Criminal Justice portfolio of work at SAMHSA. The disproportionate number of individuals with mental and substance use disorders who enter the criminal justice system is a key concern and priority of our agency and of our Assistant Secretary, Dr. Eleanor McCants-Katz. Unfortunately, Dr. McCants-Katz was called away to a meeting with the Deputy Secretary, so she's unable to kick off our symposium today and sends her regrets. However, I will share with you some of her remarks. So I want to begin with, why are we convening this symposium? Every year, approximately 2 million individuals with mental and substance use disorders cycle in and out of local jails. We know that a brief incarceration results in disruptions in treatment, disruptions to housing, health care, employment, and it severely impacts the families and the children of those incarcerated. We also know that certain population groups, especially populations of color, have unequal access to high-quality treatment and experience overrepresentation in our criminal and juvenile justice systems. Once in the criminal justice system, individuals with mental and substance use disorders stay in jails longer and have an increased risk for self-harm. For individuals already receiving medications and treatment in the community, these services may be interrupted during incarceration, creating lapses in treatment and difficulties in resuming treatment upon release and reentry to the community. And in the midst of the opioid crisis we now face, individuals with opioid use disorders are at significant risk of death by overdose in the first 2 weeks after reentry. So it's vital that we pay attention to these issues. All of us on SAMHSA's criminal justice team have worked at some point with criminal or juvenile justice systems. We have seen individuals and young people, youth, cycle through hospitals, to jails, to detention centers, to crisis services, and back again. This was and continues to be and is unacceptable. The criminal justice system, the juvenile justice system, is not an evidence-based practice for treating mental illness and substance use disorders. Outcomes from SAMHSA's early diversion and drug treatment court program and the Justice and Mental Health Collaboration Grant Program at the Bureau of Justice Assistance in the Department of Justice show that collaborations between behavioral health providers and criminal justice professionals are critical if we want to make sure people get the treatment they need and not go to jail. Behavioral health providers and law enforcement working together can divert people with mental illness or substance use disorders into treatment before they even touch the criminal justice system. Sheriffs and jail administrators can work with behavioral health providers to ensure that screening for mental illness and substance use is done every single time someone is booked into jail. And in collaboration with probation, behavioral health providers can support individuals in staying in treatment in their communities and leading productive lives. So what do we hope to accomplish in this all-day symposium? First, we want to provide education and information on the critical issue of justice involvement of individuals with these disorders. Second, we will highlight local behavioral health and criminal justice collaborations and strategies for diverting individuals with these disorders from the criminal and juvenile justice system. We want to showcase how local communities are solving these problems. Finally, we want to share federal toolkits, resource guides, informational bulletins, and action-oriented publications from SAMHSA, our agency, from our Assistant Secretary for Planning and Evaluation, from our Centers for Medicare and Medicaid, from the Social Security Administration, National Institutes of Mental Health, and our Department of Justice. It is our hope that you learn something in the presentations that you can bring back to your discussions with other leaders, partners, or policymakers in your community. This would be success for us. Before we move on to our program for the day, And it is really, I think, a rich set of panels that we've planned throughout the day. I'd like to thank our federal partners from across the Department of Health and Human Services, particularly CMS, ASPE, and IMH, and the Department of Justice, the Department of Veterans Affairs, and the Social Security Administration, who have given their time, resources, and expertise to support SAMHSA in convening this symposium. You will hear from them on the 5 panels over the course of the day. And I think it demonstrates at the federal level the kind of collaboration and commitment that is needed to truly tackle and solve these issues. We want also to thank our colleagues at Policy Research Associates that run SAMHSA's Gain Center and bring deep expertise to this topic. They played a major role in putting this symposium together. We are very grateful to them. And also gratitude to my colleague, Dr. Jenny Simpson at SAMHSA, who was instrumental in setting up this symposium. And we want to thank all of you who are tuned in virtually. We've had, I think, nearly 800 registrations, as you are the difference makers committed to tackling these issues. So at this point, I would like to introduce our opening speaker, Mr. Pete Early. And before Pete comes up, I want to just give you a few words about Pete. Mr. Pete Early is a New York Times bestselling author and former reporter for the Washington Post. He was also a reporter for the Kansas Emporia Gazette and the Tulsa Tribune in Oklahoma. He is the author of 6 novels and 11 nonfiction books, including Crazy, A Father's Search Through America's Mental Health Madness, which was a finalist for the 2007 Pulitzer Prize Award. Mr. Early is a member of the National Alliance on Mental Illness, serves on the board of the Corporation for Supportive Housing, and was appointed to the Virginia Supreme Court Task Force that recommended changes to that state's involuntary commitment laws, and is currently serving on a committee investigating ways to improve Virginia jails. A strong, relentless advocate for behavioral health, Mr. Early has testified numerous times before Congress, lectured internationally and throughout the U.S., and toured a combined total of more than 100 jails, prisons, treatment programs, and housing facilities. We are honored to have him as our opening speaker today. Pete?
Thank you very much. Thank you. I'm absolutely thrilled to be with you this morning. I know that I'm preaching to the converted. Many of you have much more experience and much more knowledge than I do. My purpose today is to bring a human face and to remind you why you do what you do. I am the parent of an adult son with a serious mental illness. What does that mean? What does that feel like? It means that I know what it is like to look at a son who I saw born and see a complete stranger standing in front of me, someone who I recognize when it comes to his body, but is a complete alien to me when I hear him speak. I am the father of a son with a serious mental illness. What does that mean? It means I'm the subject of whispers. Gosh, someone with mental illness, what causes that? Is it bad parenting? Something wrong? Or as a social worker told me before he found out that I had a son with a mental illness, the apple doesn't fall far from the tree. All you have to do is look at the parent to see why this kid has so many problems. I am the parent of an adult son with a mental illness. What does that mean? It means that I have seen the police come. I've called the police. I've seen them taser my son. I've seen them handcuff my son. I've seen them laughing at my son as he's laying on the floor because of all the silly things that he is saying in his delusions. I am a parent of an adult son with a serious illness. What does that mean? It means having lawyers and a judge decide whether or not my son needs to be hospitalized based on a 5-minute conversation with him and then leaving him angry at me to deal with him after they walk out of the room. What does it mean to be the parent of an adult son with a mental illness? It means spending countless hours trying to convince your son that he needs to take medication, and in my son's case, medication helps. And then having an insurance agent say, well, I don't know why you take that medication, it's just a placebo. What does it mean to be the parent of a son with a serious mental illness? It means consulting parents whose sons and daughters have died, taken their own lives, or are incarcerated in jails and prisons. What does it mean to be the father of an adult son with a serious illness? It means having your heart broken. as you hold your sobbing adult son in your arms like a baby, listening to him talk about how he wants to be normal, just like everyone else, when everyone else is telling him that he is not normal, that he can't afford an apartment, that he doesn't deserve a job, even though he has a college education, or seeing that no one wants to date him or be his friend. I know those feelings, every one of them, because I've experienced them with my son, Kevin. I've been asked today to speak specifically about Kevin and my interaction with the criminal justice system, so I'll skip over his first two breaks. When he was first diagnosed with bipolar disorder and given medication, and why he didn't take that medication. I'll get right to his third breakdown, and that story begins with his older brother, Steve, calling me from New York, saying, "Dad, you got to get up here. Kevin's gone crazy." And me racing to Manhattan, where I found my son wandering around the city for 5 days. He barely slept. He'd hardly eaten. He was convinced God had him on a special mission. And during our 4-hour ride from Manhattan to Fairfax, Virginia, Kevin would laugh one minute and then begin sobbing the next. And I pleaded with him to take his medication. He screamed, "Pills are poison. Leave me alone." And we got to the emergency room in Fairfax, and the nurse rolled her eyes while Kevin talked gibberish about God having him on this special mission. And then we were taken in a room far away from everyone else because of how he was acting. And we sat there, and we sat there, and we sat there, and we sat there, and finally Kevin said, "There's nothing wrong with me. I'm going to leave." And I said, "Hold on, son, hold on." And I raced out, and I literally grabbed a doctor. And I will never forget how that doctor came into the room. He came in with his hands up as if he were surrendering. He said, "I'm sorry, Mr. Early, I really can't help you and your son." I said, "You haven't even examined him." And he explained to me it didn't matter. Virginia law was very specific at that time. A person had to pose an imminent, immediate danger to themselves or others before they could be required to undergo treatment. And Kevin had already told the nurse that pills were poisoning, and we'd been sitting there for 4 hours, so obviously there was no immediate threat. But the doctor turned to me and he said, "Mr. Early, you seem like a concerned dad. You bring your son back after he tries to harm or kill you or harm someone else." So I took my son home, and during the next 48 hours, I watched him sink deeper and deeper into a mental abyss. At one point, he had tin foil wrapped around his head to keep the CIA from reading his thoughts through our television. He slipped out of the house. He slipped out early one morning. He slipped out. He broke into a stranger's house. Luckily, no one was there. He broke in to take a bubble bath because he was convinced that he was dirty and needed to be cleaned. It took 5 police officers to get him out of that house. And when they did, they drove him over to a mental health center. And I went racing over there, and a very kind officer was standing outside. He said, "Whoa, whoa, whoa, let me give you some father-to-father advice. Even though we picked up your son in a stranger's house taking a bubble bath, even though he's told us he has bipolar disorder, even though he's told us he's lost his medication, unless you go in and you tell that psychiatrist your son's threatened to harm you, he will not go into a hospital. He will go to jail, and you don't want that." And I looked at the officer and I said, "My son hasn't threatened me." And he shrugged and walked away. So I'm here today to tell you, I do it with no pride because it hurt my relationship with my son. I went in and I lied. I said my son had threatened to kill me, and that was good enough to get him taken to a hospital where he voluntarily admitted himself. And I thought, wow, finally, he's going to get some help. And 48 hours later, I received a call from the Fairfax County Police. My son was being charged with 2 felonies, breaking and entering and destruction of property. How could this be happening? I couldn't get my son help, and now Virginia wanted to punish him for a crime he'd committed when he was psychotic. I decided, as a former Washington Post journalist, to investigate this. But before I left to do that, I wanted to talk to my son. I said, "Kevin, I want to investigate this." He said, "Dad, if it helps someone else, tell my story." Well, I did a little digging, and I discovered what happened to Kevin was not some aberration. It wasn't some freak event. I discovered what many of you already know, that as we sit here, there's an estimated 365,000 people with schizophrenia and bipolar disorder and depression sitting in jails and prisons, that 2.2 million are booked into our jails and prisons every year, that more than 1 million people with mental illnesses are currently on probation, that 40% of persons with serious mental illness will have an encounter with law enforcement during their lifetime, that 49% of all police shootings involve someone with a mental illness, 49%, that persons with serious mental illness are 4 times more likely than the general public to be fatally shot by the police, that individuals with serious mental illness stay in jails and prisons 4 to 8 times longer than other people charged with identical crimes, that persons with serious mental illness have a higher likelihood of getting additional charges filed against them when they are incarcerated, that persons with serious mental illness have a recidivism rate that is 15% higher than the national average, 85%. Of persons with serious mental illness will return to jails and prisons. And finally, that in 44 states, a jail or prison holds more mentally ill individuals than the largest remaining state psychiatric hospitals in every county in the United States. With both a county jail and a county psychiatric facility, more serious mentally ill individuals are incarcerated than hospitalized. These troubling statistics gave me the idea. I would find a jail in a major city far away from Fairfax County because I didn't want to irritate a judge or prosecutor. And I'd go and I'd spend time there up to a year following people through the criminal justice system to see what really happened to them. Then I'd come back and I'd talk to the experts and the correctional officers, the parents, the judges, and try to make sense of all of it. Well, I began in L.A., Twin Towers, largest public mental facility at the time. That's how it was being reported. And I lasted 2 days. They threw me out because of HIPAA. But the truth was they didn't want me to see what I was seeing. So I tried Cook County Jail next. They said no. I tried Rikers Island next in New York. They said no. I tried Baltimore, and they said no. I tried Washington, D.C., and they literally said, hell no. And I ended up going to Miami-Dade because of Judge Steve Leithman, a name I'm sure many of you heard. He said, I want you to see what's happening in my jail. I want to take you there briefly. There are 19 cells in the 9th floor and C wing, the suicide wing. The cell block is a U-shaped. The officers walked down the center. The 19 cells around them all had plexiglass fronts. And as a reporter, you go in and you try to figure out every sight and sound and smell and remember it. And when I walked in there, I smelled urine, I smelled feces, I smelled this human sweat. And as you walked in there, you saw people completely naked in cells that had nothing else in them. And because of the design of the jail, plexiglass cut off the air conditioning, blowing the cells. And it was bone-chilling cold, but there were no blankets. And because the jail was old, the water system broke down at least once a week. And so there was no water for people in cells. And you literally saw people drinking out of toilets because their medication made them thirsty. And when you walked through that jail, you heard the normal jail sounds of people coughing and spitting and doors closing. But when you listened closer, you heard the asylum sounds. You heard people screaming at unseen tormentors. And then I heard a thud, thud, thud. Then quicker, thud, thud, thud. Then louder, thud, thud, thud. It was one of the inmates running forward, smashing his forehead into the plexiglass. I ain't crazy, he screamed. Then quit acting like you are. And unconcerned officers called back. Now, during the 10 months I spent there, I discovered they called this floor the forgotten floor. And I thought they were talking about the inmates, and they were, but they were also talking about the employees. I got to know these officers, and every one of them told me they had received absolutely no training to work with anyone who had a mental illness. And even worse, every one of them told me that they were troublesome employees. They were sent to work on the 9th floor because their bosses hoped they would quit because they had the worst job in the jail. My tour guide was Dr. Joseph Poitier, a fabulous doctor with an impossible job. A lot of people think you'll get help if you get put in jail. We aren't a hospital. We're a jail. I went with Dr. Poitier on his morning rounds. There were 92 inmates on the 9th floor, 92 inmates. His rounds took us 19 minutes. That's an average of 12.7 seconds that we spent talking to each inmate. But Pete, these are criminals. They deserve to be in jail. Do they? Let's talk about Alice Ann Collier, chronic schizophrenia, the kind of person who used to be locked up in a state hospital. But now we've moved her back in the community, which is fantastic. But let's look at her life. She lives in a cardboard box, 2x4 contraption behind a restaurant. And when I checked her record, she'd been arrested more than 10 times in the last year, but she'd never gotten any kind of help. And this time she was in jail because she was walking down the street, and her eyes locked with an older woman who was waiting for a bus. And Alice Ann Collier screamed, "Stop stealing my thoughts." And she raced over and she shoved the older woman, not hard enough to knock her over, but she shoved her and went running away. And well-meaning witnesses came up and said, "You should get her arrested. You get that woman arrested and she'll get help." Well, help is not what Alice Ann Collier got. Florida takes crimes against persons over age 65 very seriously. In fact, a prosecutor can use his discretion to charge any of those crimes as a felony. And because Alice Ann Collier had shoved 2 other people at bus stops, she was charged under that state's 3 strikes rule with shoving people with felonies. That meant that she faced a mandatory 5 years in prison. But when she went before the judge looked at her and went, this person can't be tried. She's not competent. And in our system, you have to be competent in order to be put on trial. So he said, I'm going to send you away to the state hospital in Chattahoochee to be made competent, competency restoration, not treated, and there's a difference. Treatment means you get help. That's not what Alice Ann Collier got. Every day she was taken into a room and she was shown 3 chairs. Now, on one chair was written the word judge, another one prosecutor, and the third defense attorney. And when Alice Ann Collier could tell her keepers who sat in which chair, she was deemed competent enough to be put on trial, and she was sent back to the jail. Of course, she wasn't competent, and when she appeared before the judge, he said, "Why are you back here? Go back to Chattahoochee and get made competent." When I found Alice Ann Collier in the jail, she'd been traveling between the jail and Chattahoochee 1,151 days, and she'd still not been brought to trial. Now, I'm a reporter. I got my little pen and paper, and I went running over there. I said, "Look what I found, prosecutors. Look what I found." And they told me without any embarrassment. They knew exactly what was happening to Alice Ann Collier. In fact, they planned to keep her for 5 years, which was the maximum they could hold her without putting her on trial. Why? Because she was dangerous. Medications didn't seem to help her. And there was no safe place in the entire state of Florida. No long-term treatment facilities, no hospital beds, so they were keeping her on that bus simply to keep her off the streets. Now, she was typical. These people were not Hannibal Lecter serial killers. There were people with schizophrenia and bipolar disorder and severe depression. Let's talk about April Hernandez, same age as my son. When I saw her in the jail, correctional officers came up and said, "You should investigate that case. April was framed for car theft." And I went, "What? Who framed her?" Her own parents. Why did her parents conspire with relatives to have her arrested for car theft? Because she was psychotic. She was living on the streets of South Beach, where she had been gang raped twice and beaten 3 times by teenagers who thought it was hilarious to pick on people who were homeless on the streets, and there was nothing anyone could do because she was not considered a danger to herself or others. Now, what's interesting about April's case is she had started using drugs as a teenager, and everybody went, "Oh, that's why she's homeless. Oh, because she's using drugs. That's why she acts so strangely." And it was only after she was correctly diagnosed as having a co-occurring disorder, having a drug addiction and a mental illness, that she finally began getting some kind of help. And we know that 40% of persons who develop a serious mental illness as bipolar disorder and schizophrenia have co-occurring problems. And 70% nationally of people in jails and prisons have a co-occurring problem, and 90% of the ones I encountered in jail had a co-occurring problem. Finally, let's talk about Freddie Gilbert. I don't care where you live, you know someone like Freddie Gilbert. A Miami study found that in a population of 1.5 million, at any given day, there were 1,700 people living in cars on the streets. They were homeless. But that same study found of those 1,700 people, most were able to move through our move through our social system into some kind of supportive housing, except 510 individuals. They are always homeless. They are always on the street. And Freddie Gilbert was one of these 510. and every one of them had been arrested, and every one of them had a mental illness, mostly schizophrenia. And when I met him in the jail, he was so sick he could not speak. He stood naked in his cell, and he grunted like an animal, and they treated him like one, offering him sandwiches in return for his obedience. And when I checked his record, I discovered that Gilbert had been in and out of that Miami jail more than a dozen times, and he'd never gotten any kind of help. And that's because he was charged with misdemeanors, and under Florida law, he could not be admitted into a treatment program, even if one were available. And the result, he was stuck on that revolving door. After my book was published, the University of South Florida Mental Health Institute followed 97 of these frequent utilizers of services in Miami, like Freddie Gilbert, over a 5-year period. Nearly every one of them had schizophrenia. Everyone was homeless. Those 97 individuals were arrested 2,200 times, spent 27,000 days in jail, 13,000 days in crisis stabilization units, state hospitals, emergency rooms. They cost $13 million, and there was absolutely no sign of any kind of help or treatment or progress for them. But you wrote your book years ago, Pete. Surely things have changed. Yes, some progress has been made, but let's not forget J. Shamil Mitchell, less than 2 years ago, Hampton Roads, Virginia. J. Shamil Mitchell, schizophrenia, locked in the jail there, waiting to go to a state hospital to be restored to competency so he could put on trial. J. Shamil Mitchell, who couldn't get in the state hospital because there were no beds, whose paperwork was not found until 6 days after his dead body was found in his feces-covered cell. J. Shamil Mitchell died from a heart attack brought on by starvation. According to a lawsuit, the correctional officers denied him food because he would not obey orders. He lost more than a third of his body weight. What was his crime? He stole $5.05 worth of snacks from a convenience store. Back to my son, Kevin was put on probation after he broke into this house. He did great for 2 years. He was fantastic during that probation. He took his medication. Medication seems to help him. He just did super. As soon as that 2 years of probation ended, he stopped taking his medication. I could see that he was slipping. So I called our mobile crisis response team. I said, please come. My son is off his medication, and I'm afraid that he's going to get in trouble. And they said, wait a minute, is he dangerous? And I said, no, he's not dangerous yet, but let me tell you what happened. And no, you can't judge him on what happened last time. That's not fair. You call us when he becomes dangerous. We just can't come over. There are 1.5 million people in Fairfax County. We have one mobile crisis response team at the time. We get 500 calls a month. We just can't come over when somebody's off their meds. You call us when he's dangerous. Well, the night I didn't have to lie, the night my son became violent, I called that same dispatcher and I said, please, please come. My son is violent. And that dispatcher said to me, is he dangerous or is he violent? And I said, he's violent. Oh, we don't come then. Call the police. Well, I called the police. And my son was shot twice with a taser and taken away. How are we reacting to this crisis of the criminalization of persons with mental illness? Because our badly underfunded mental health care system that is broken and flawed can't help our people who need their help, we are turning the criminal justice system to save us. And the first step is always crisis intervention team training. And I am thrilled that my colleague from ISMEC, Ron Bruno, will be taking us into a deep dive today about CIT. And I've always supported CIT. It is the doorway to community change, to social change, to cultural change. It's the doorway to jail diversion. It becomes the entryway that sets communities up for problem-solving courts. It becomes a doorway to use of the sequential intercept model. And I'm thrilled today that you're going to have Dr. Mark Muntz, the co-creator of the interceptor model, here to talk. You've got some really fabulous people. I'm glad that Ruby, and I'm going to mess your name up. What? Kachelbush. This is why I'm not on the radio, folks, is here today to discuss federal programs. She is such a blessing, such an expert. She can talk about things such as the Stepping Up campaign. But let's use some common sense here. If I had a broken arm, I wouldn't call the police department and say, come fix it. If I needed heart surgery, I wouldn't call up the sheriff and say, come on over and give me a new heart. And if I had really nasty, nasty hemorrhoids, I wouldn't call up a judge and say, hey, judge, will you come over and take a look? So why are we expecting the police and the sheriff and judges to solve what is a community mental health problem? The best way to stop the incarceration of persons whose major crime is they got sick is by zero intercept, by not getting law enforcement involved at all. And how do we accomplish that? We accomplish it by waking up and understanding that you can't talk about mental health support reform unless you want to talk about supportive housing. And again, I want to compliment SAMHSA because you're going to have Ryan Mosier from the Corporation of Supportive Housing here today to tell us how you get supportive housing in your community. And you can't get better when you're living under a bridge. Housing is essential to mental health recovery. And you can't talk about it unless you want to talk about jobs. You can't talk about it unless you want to talk about transportation. You can't talk about it unless you want to talk about drug and alcohol programs. And you can't talk about it unless you want to talk about PTSD. And you got to remember that's not only veterans. Do you know that last year was the first year in our country's history where more law enforcement officers took their own lives than were killed in the line of duty because of PTSD? And you can't talk about it unless you want to talk about social connectivity that bonds you with your neighbors and friends. People with serious mental illness are the most isolated in our society, and that's why peers and peer-run clubhouses are so important. And why are they important? Because they give people hope. Writer Hal Lindsey said, man can live about 40 days without food, about 3 days without water, about 8 minutes without air, but only 1 second without hope. How do I know the collaboration between law enforcement and community services work? Let's go back to Miami. After Judge Leifman got me in there, he took my book, he went to a local TV station, he got them in, he started demanding that all the different stakeholders come together. He got that community to pass a bond issue. He has closed down the 9th floor. He is setting up the gold standard for jail diversion in Miami as we speak. The results so far, arrests have decreased from 118,000 to 56,000 annually. Recidivism has dropped by almost 50%. The jail population plunged from 7,300 to 4,000 inmates, enabling Miami to actually close one of its jails, generating $12 billion in annual savings. How do I know the cooperation between law enforcement, communities, and providing mental health services works? Because it's what helped save my son. The last time Kevin got sick was on Thanksgiving Day. He had gone off his meds. I could tell he was off of them. He could tell I knew. He was scared I'd call the police. He'd get tasered, so he ran out of our house. He jumped in his car and he took off. And I called and I called and I called, and he wouldn't answer his phone. And he finally answered. I said, where are you going? He said, I'm going to heaven. Well, that's not real reassuring to a father. Well, he got as far as North Carolina where he ran out of gas. And he called me, he's crying, and he said, Dad, help me. I said, I'll come. He said, no, don't come, Dad, don't come. I said, okay, come home. I can't, I'm out of gas. Okay, I'll get gas delivered to you, or go to a station, I'll give you a credit card. No, Dad, you don't understand. You don't understand. The voices in his head were telling him if he stepped out of that car, he would die. Now, we know that's all ridiculous. But how do you know you're listening to me? How do you know this is Friday? How do you know you're tuned into SAMHSA? Because your brain is telling you, and I'm telling you, if your brain told you that you would die if you walked out of the building you're in right now, you wouldn't leave that building. So I did what no father should do. I arranged for Kevin to get gas, and he drove completely psychotic all the way home. He went off the road twice. He didn't hit anyone. He wasn't stopped. I said, look, I'm tired of fighting. I want to be a parent. I want to be your partner, not your parent. What can I do? And he said, there's a safe place, a safe house you can go to. Take me there. I want to think. I don't want to take medications. I just want to think. I said, fine. I took him over a safe house, and he checked in. That was great. I went home. I took a big sigh of relief. Finally, we could get somewhere on this. Well, he got up in the middle of the night. took off all his clothes, because we all know if you get naked, then you're invisible, and he went walking outside. But listen to what happened to my son this time around. This time, a crisis intervention team-trained officer pulled up next to him, rolled down his window, said, "Hey, buddy, what are you doing walking naked down the street?" He said, "Maybe we should go over to the emergency room and get you checked out. It's really not safe for you to do this." And Kevin said, "Don't handcuff me. That's when I got tasered. I ran away. I'm not a criminal." And that officer used his discretion. He did not handcuff him. He put in the back of that squad car. And then he turned to my son and he said, "What kind of music you like?" And Kevin said, "I like rap music." And that officer turned on rap music. He treated him with respect. And they got to the hospital. My son actually got out, shook his hand, and said, "This is better than a taxi ride." He didn't stop there, though. That officer went inside, and when that doctor said to the officer, "Well, walking naked down the street is not dangerous," the officer actually said to him, "Okay, Dr. Smith, I'm going to look up where you live, and I'm going to drop him off on your front lawn." All of a sudden, my son was admitted, and then he got a fabulous case manager. And that case manager said to him, "Why don't you take your medication? I've gained 50 pounds. I can't drink. I can't have sex." She said, "You need to talk to a doctor and try to get that formulary correct." Do you know of my son's 7 psychiatrists, only 2 have ever bothered to learn anything but his name and his diagnosis? And that's because they're only going to be paid for a 15-minute med check, and they're going to shove them out the door and have a social worker take over. But treating the mind requires treating the heart. And the doctor talked to him, and they found a medication that had few side effects. And Kevin started taking his medicine, and it really helped. And then the case manager came to him and said, "You need housing." And I said, "Well, that's ridiculous. He can live with me." No, he's too old to do that. He needs to be independent. He needs to have pride. He needs to be responsible. He needs to pay 30% of his income, even if he makes no income. He needs housing first. So she moved him into an apartment with 2 guys with schizophrenia, and I was amazed at what that did for his self-esteem and confidence. And then she went to me and she said, "You know, Kevin, you're a lot more stable. You're doing a lot better than a lot of folks. You need a job." "What can I do? I have a mental illness." "Knock it off. Control the illness. Don't let it control you." So my son got a job, college educated. He was the guy at Home Depot who went around and picked up shopping carts. And he got depressed. All of his friends were moving on. All of them were getting married. All of them had friends and careers, and he was picking up shopping carts. And then one day, he saw his therapist. And his therapist said, "Oh, help me load some things." "Man, Kevin, you're doing great." And Kevin thought he was mocking him. He said, No, you need to come to my group. You need to see how ill other people are." And so he went. And he realized that he could help people because they were inspired by seeing how well he was doing. And so he came back, and the case manager said, "I have a great program you need to learn about. It's called peer-to-peer. Being a peer, someone with mental illness who's helping someone with mental illness." So my son underwent the courses, and today he works in Arlington County as a peer-to-peer specialist, a person with mental illness who helps others with mental illness. One of his clients, over 300 pounds, schizophrenia, hadn't been out of his parents' basement for months. Kevin started going over. He started visiting him, got him out. Got him to go to a fast food restaurant and to a movie. Now, that's not a big thing, unless that is your son. Today, Kevin and his mother are buying a home together. He's paying taxes and complaining about it. He's working full-time. He's attending graduate school, and he's just applied to Fairfax to become the peer specialist leader, the top dog over there in peers. So don't tell me people can't recover. I've seen it with my own eyes, and it was collaboration between law enforcement, community services that gave me my son back. I am the parent of an adult son with a serious mental illness. What does that mean? It means seeing my son given not a second chance, but a third and a fourth and a fifth, and sticking with him until he embraced his recovery. I am the parent of an adult son with a mental illness. What does that mean? It means interacting with CIT-trained officers who care, judges who care, prosecutors and defense attorneys, and community leaders who care. It means working with people who are able to see beyond the madness of his eyes and recognize him as a person of worth whose parents and brothers and sisters love and care about him. I am the parent of an adult son with a mental illness. What does it mean? It means that my son has taught me about resilience and the human spirit, about an individual's ability to overcome tremendous obstacles. And I am tremendously proud of my son and the man he has become. And I want other persons to get the same kind of services that Kevin got, the same kind of opportunities that he's received. That is what I want. And that's what you can help me achieve. You are not widget makers. You have chosen a much more noble calling. Every day you make a difference, and every moment you have an opportunity to help reform our system, to help save people such as Kevin. You need to make today the day that you make a difference. I'm going to close. I always close my speeches with this story. It's a religious story. I'm not promoting religion. I am not downgrading religion. I simply like the story, and I like the imagery that it shows. I was brought up in Oklahoma. My father was a small-town minister, and right there you will know that I got dragged to church every Wednesday night, twice on Sunday, and I got really good at sitting there not listening to a word my dad said, except for one story he told, and that's because it's about a woman who's having sex. It's always women in the Bible who are having sex, never the men, and you can find them if you know where to look. The woman is caught in adultery. She's brought to the center of the community. Everybody gathers a stone. They're going to stone her because this awful thing she has done. And we read that the teacher lifts up a rock and says, "Let ye who's never sinned throw that first stone." And we read that people put down the rocks. They put down the stones because they realize none of us are pure. All of us have sinned. All of us have fallen short. Sadly, today, we live in a culture where people don't put down those rocks. They don't put down those stones. They want to stone people who are different. They want to lock them up, get them off the streets, just get rid of them. My friend Brian Stevenson talks about stone catchers, people who stand between those angry mobs and protect people until they're strong enough to join us. It is the stone catchers in our society who give me hope. You are stone catchers. Thank you for doing that. Thank you.
Okay, Pete, thank you very much for those remarks. I'm really at a loss of how to follow with that. I can pronounce Ruby's last name, though, so okay. Your remarks were incredibly compelling, inspirational, and it's a challenging times that we are in, both in terms of trying to be stone catchers and in terms of trying to fix systems that we think are starting to improve. Then we see gaps, and we see breaks, then we see infusions of funding and people who are committed to it, then we see that go away. So we're really, in many ways, on a roller coaster ride, trying to get what you have painted as a compass north we should think about. I think your remarks reinvigorate us with hope that things can get better, and your sharing of your personal journey, I think, will be our compass north for today, and really not just for today, but even beyond that. We have partners in the room, partners on the phone, and we hope we can take your story, that the gems of what you shared with us today, your sons and other people's stories that you shared, will compel us to make sure we are relentless in our work here around trying to improve the situations, the services, the communities, the opportunities for people with serious mental illness and those also with co-occurring substance use disorders. So thank you very much for that. I know the people in the room probably want to have open discussions with you. We can't do that right now, but we'll try to do that perhaps during a break. So thank you very much, Pete. Again, let's give Pete applause for sharing his story. So I have the task now of beginning to set the stage for our next panel. And Pete, you've given us the human face of that stage. You've shared statistics with us as well. So I'm going to go briefly through some of the slides I have, which also have some of the statistics. Okay, whoops. And I'm not going to really go reading through those, but just to really again say that people with mental health issues, with serious mental illness, with addictions and substance use are really overrepresented in our jails and prisons. And you can see that more than half of state prisoners, about 2/3 of sentenced jail inmates meet our diagnostic and statistic manual criteria for drug dependence or abuse. We also see that about 1 in 7 state and federal prisoners and 1 in 4 jail inmates meet the threshold for serious psychological disorders. So those are some of the behavioral health issues we see in jails and prisons. But beyond that, we also want to, now Selby, okay, here we go. We know that incarceration also impacts other aspects of one's lives. That we know that there are serious health conditions and chronic health conditions that occur for people who are incarcerated, such as chronic health conditions such as diabetes or higher prevalence of HIV and AIDS in correctional settings. We also know that housing and housing opportunities, which we know housing is a critical stabilizing force for people with addictions, people with serious mental illness, that that is a disrupted part of people's lives when they're incarcerated, and that roughly 48,000 people entering shelters each year are coming directly from prisons or jails. And of the 11 million people detained or incarcerated in jails each year, as many as 15% report having been homeless. So we think about all of these barriers to services, all these barriers to recovery compiling for people with serious mental illnesses or addictions. It's not just the behavioral health issues that often go unattended, but the other health issues, and then all of the things we think of as the social determinants of a healthy life in the community also are impacted. So somebody's moving my slides here, so let me catch up with them. So what are we doing around this now? And Pete has really drawn attention to the gaps we have in our treatment systems and the needs for better partnerships across different service systems. The 21st Century CARES Act, passed in December of 2016, is a key policy driver for some of the work we're doing here at SAMHSA, along with our federal partners. The section of the bill, Helping Families in Mental Health Crisis Reform Act, focused on particular issues regarding mental health and substance use, the prevention issues, prevention and treatment of these disorders, the coverage, looking at financing and coverage for treatment for these conditions. There was a focus also in this congressional bill on reducing criminal justice system involvement, specifically for people with serious mental illnesses. And it also established the Interdepartmental Serious Mental Illness Coordinating Committee. It also elevated the status of SAMHSA's administrator to an assistant secretary level position. Again, focusing, really saying that we are going to prioritize on these particular conditions. I want to say a little bit about the ISMIC, or the Interdepartmental Serious Mental Illness Coordinating Committee, which is also a big framework or structure for how we've organized the panels for today's symposium. So this committee consists of both federal and non-federal membership. We have 14 non-federal members who were selected and appointed by the Assistant Secretary, including Mr. Early, who is on the ISMIC, and Mr. Ron Bruno, who you'll hear from later, who is also with us in this room today. The non-federal membership generated 49 recommendations in their required 2017 report to Congress. There are 5 focus areas in those recommendations. So there was a focus on data and quality measures, a focus on access and engagement to services, focus on treatment and recovery and what should a continuum of care look like for people with serious mental illnesses and co-occurring substance use. There was also a focus on criminal justice, and that's what we are focusing on today. And there was also an area of focus in those recommendations on financing of services and financing the continuum of care. I want to get to the next slide. So 5 of the key ISMIC, Interdepartmental Criminal Justice recommendations, are what you see on the slide there. To support interventions, that is treatment, prevention, recovery interventions that correspond to all stages of justice involvement. To develop an integrated crisis response system that diverts people with SMI and young people with serious emotional disorders away from jails, emergency departments, and the criminal and juvenile justice system. To prepare and train all first responders, which may be law enforcement as well as firefighters, EMTs, to train them to work with people with SMI and SED. And we heard Pete's compelling story of law enforcement that had been trained in crisis intervention training. Require universal screening for mental illnesses and substance use disorders and other behavioral health needs of every person booked into jail. And Pete, I did have an opportunity to get into Cook County Jail some years ago and meet with a judge, Judge Heston, who was actually at the juvenile level implementing screenings of all juveniles coming into detention. So there are some people who are trying to move the system. But to require this screening so that we know the levels of need of people coming in, we can identify whether they can be diverted away from incarceration. And then finally also to reduce barriers that impede access to treatment and recovery services upon release from correctional facilities and reentry back into and transition back into community living. So those were 5 of the key recommendations put forward by the ISMIC committee. And so our panels today really mirror those recommendations. So you'll hear discussions from subject matter experts around that, as well as innovative programs, and many of them are collaborative programs that Pete alluded to going on in communities that have really tried to tackle this intersection of the crossroads really between behavioral health and criminal justice. Okay. And so our criminal justice, so each one of those 5 focus areas of the ISMIC had a designated implementation work group to support implementing the recommendations. This is the composition of our criminal justice work group, the other federal agencies that were represented. And so the ISMIC is not just a SAMHSA effort, but it's really an effort which requires a lot of collaboration with our other federal partners. So these are the federal partners you see on the slide that are part of our criminal justice, juvenile justice implementation work group. And the work group is led by staff at SAMHSA, myself and Dr. Jenny Simpson. So I want to give you an overview of today's symposium, but first want to talk to you about what our criminal justice implementation work group is trying to do around each of those recommendations. That we are trying to put together what we are calling very practical, feasible implementation technical toolkits that can have ready uptake and access in the field, both on the behavioral health side, behavioral health providers and personnel, as well as criminal justice practitioners. Each recommendation will have a toolkit which we will make available, which are in process of being made available to the field now, and that along with that, we will look at facilitated training and technical assistance for the field. We're starting off today's symposium with two of the foundational concepts for the work in looking at the intersection of criminal justice and behavioral health. We have developed here at SAMHSA, again with federal and expert input, principles of community-based behavioral health treatment for justice-involved individuals. And PRA has, along with Mark Munitz, has really developed and further advanced the concept of the sequential intercept model. So our next panel presenters are going to really start with those foundational concepts. Then the other four panels remaining through the day are going to reflect again those recommendations, and the first is going to be really looking at building collaborations, second on crisis response and early diversion, third on screening in jails and prisons, and the fourth with a focus on reentry. Each panel is comprised of national subject matter experts, local innovators, and federal partners sharing resources that are available to you in the field. So that's the structure of our day. So I want to now bring up, I want to now bring up Dr. Jenny Simpson, who's going to talk to us about the principles document and guide. And Jenny is a senior staff person in our criminal justice team here at SAMHSA. And then following her will be Mr. Chan Neither, who is our project director at SAMHSA's GAIN Center. Both of them bring tremendous expertise and experience in working at the intersection of behavioral health and criminal justice. So, Jenny?
Great, thank you, Lark. So today I have the, I would say, distinct honor of introducing for the first time SAMHSA's Principles of Community-Based Behavioral Health Treatment for Justice-Involved Individuals. The development of these principles, as many people may know, has been a truly collaborative process across federal stakeholders, national experts, local practitioners. And it's really been a labor of love for us here at SAMHSA. And I think Pete's talk this morning really puts a face on these principles, and that I hope you keep in mind as I go through this presentation, because that's what I can't capture right now. So thank you for that. Advancing the slide. Hold on one second. Thank you. So why principles? Why did we start off on this process? So historically, work at the intersection of criminal justice and behavioral health has focused on criminal justice professionals. So training law enforcement, working with corrections, providing that information, awareness, behavioral health awareness, de-escalation for criminal justice professionals, and less has focused on behavioral health providers. So we recognize this gap in information, tools, and resources, recognizing that when you go into a psychiatry program or a social work program, you may not get any training as a clinician on working with justice-involved individuals. And so we saw that there was a gap that needed to be addressed. Thank you. So when we were developing the principles, we started with what are the key challenges for providers. And as we were developing these, it was a rigorous consensus-based process. So we listened, had listening sessions with providers, with local practitioners, criminal justice professionals, with national experts. And we found really three key challenges. First were partnerships, whether it be with law enforcement, pretrial services, courts, community corrections. And I know as someone who worked in the field, having those partnerships, I didn't know where to turn to find them, and that was an incredibly important piece if we shared a client who maybe was on probation or parole and someone I was providing services to. So that partnership, even how to do that, was knowledge that wasn't readily available to me. Second was knowledge of criminal justice system and concept. So that kind of who, what, when, where, why. Where might my client be? I'm not sure, what pretrial services might mean, or community corrections. Who are the personnel that this individual may be with? What do I do when someone enters jail? All these questions that for providers who aren't trained in with any kind of knowledge of criminal justice present a knowledge gap. And third, effective and responsive treatment, recovery, and support services for justice-involved individuals. And I'll say this starts with evidence-based treatment for justice-involved individuals, which includes, and part of this effective treatment is addressing criminogenic risk and needs factors. And I will come back to that later when I discuss one of the principles. And this is really a necessary part of treatment and something that, as the behavioral health field is working at this intersection, recognizing that those criminogenic factors must be addressed, and they're an important part of treatment. And also case management and support services to justice-involved individuals. So as Pete detailed, difficulties in finding housing, employment, opportunities for people who have criminal records. Those are challenges. If you don't have the information to work with someone who has those challenges, nowhere to go, that's really a gap in your knowledge. So from providers, we also heard that there, as I described this, a complexity in working with justice-involved individuals where they may be in the system, the unique needs that they have in finding that housing or employment, things that are specific to the risk and needs factors, which I'll return to. And for providers, there's additional skills that they have to, they're aware that they don't have and that they need to find that information. And then there's also, and what I would say, stigma. So in a recent article from Psychiatric Services, and this is just one survey that was done on 627 psychiatric rehabilitation program providers, the findings were that providers reported lower regard for criminal justice clients than for clients without criminal justice involvement. Providers were also less likely to report having a great deal of respect for clients with versus without criminal justice involvement. That's really a hurdle to overcome. So when we went to developing the principles, there we go. We started with first the draft, and we took that draft through a technical experts panel held on August 17th, 2017. In this technical experts panel, we had national experts, community-based behavioral health providers, criminal justice professionals, professional associations, federal representatives who came together to really give us feedback, work with us, problem solve what these principles needed. After revisions to that initial document, we took the document to go through peer review in the field by experts in psychiatry, psychology, social work, criminal justice, criminology, medicine. We really tried to hit as many people as we could to make sure that this was as strong and consensus-based as we could make it. And finally, we put the principles through public comment in May of 2018, allowing anyone who wanted to comment on these principles. So I'm happy to say the principles document is going to be published in 2019 by SAMHSA, and it includes, along with these principles, information and resources for providers and agencies who want to implement these principles. So now I'd like to go through introducing the principles. So the first principle is that community providers are knowledgeable about the criminal justice system. This includes the sequence of events, terminology, and processes of the criminal justice system, as well as the practices of criminal justice professionals. Now, as I spoke about in some of those key challenges, understanding where your client may be in the criminal justice system can help you with that continuous and coordinated care when an individual may enter into jail or prison and when they come back out into the community. So it's essential for knowing as you track in those services that you can provide to the client where they are. You also can understand whenever you're working with with your criminal justice colleague, what the terminology is they're using. That's when we don't necessarily speak in the same language. And I think there's cross-education that can happen there because criminal justice professionals may not know our language. And that's knowing that demonstrates the desire for collaboration as well. There's also opportunities to recognize when you can divert clients into treatment and services such as drug treatment courts. And when under probation or parole, you can facilitate coordinated care and adherence to supervision and requirements as well. Now for the second principle, community providers collaborate with criminal justice professionals to improve public health, public safety, and individual behavioral health outcomes. Again, this one is really key. That collaboration is essential when you think about ensuring continuity and care coordination when there are transitions from jail, prison, emergency rooms. Also, we have law enforcement who may be taking an individual to an emergency room. It's really essential that you have someone that you are connected with. That collaboration includes information sharing when appropriate, clarifying roles and responsibilities, what behavioral health providers do, what criminal justice professionals do. Ensuring that treatment and supervision requirements are complementary. So again, that requires talking with your criminal justice colleague on the other side and making sure that those efforts together serve the person that you are both working with. And then working with the client to identify and meet their treatment and supervision goals. So just, at the very heart is ensuring that care, the individual gets the best care that they can receive. And so later today, you are going to hear about the Bureau of Justice Assistance's Police Mental Health Collaboration Toolkit, which can help establish these important connections. The third principle is evidence-based and promising programs and practices and behavioral health treatment services are used to provide high-quality clinical care for justice-involved individuals. So now evidence-based programs and practices should be used for all individuals. We'll start with that as just the key baseline there. But there may be adaptations or interventions that are specific to a justice-involved population. And these adaptations can include recognizing and addressing the risk factors that may increase the likelihood of someone reoffending. So there's a focus, some of these interventions focus on motivation, problem solving, skill building, coping skills, anger management, things that providers will be familiar with, but with additional skills can really tailor these to justice-involved individuals. It also includes integrated treatment for substance use disorders, including medication-assisted treatment for opioid use disorders, which is the standard of care for substance use disorders. Principle 4, community providers understand and address criminogenic risk and need factors as part of a comprehensive treatment plan for justice-involved individuals. I think this may be one of the hardest for providers who are not familiar with the criminal justice system, haven't worked with criminal justice professionals, and understanding criminogenic risk. It sounds like someone may be at risk of violence. That's not what this means. We know, and research is really continuing to demonstrate, that behavioral health treatment alone does not reduce the likelihood that someone is going to reoffend. And conversely, interventions that only address criminogenic risk and need factors do not improve behavioral health outcomes, so they are complementary. Criminogenic factors include risk and needs that research have demonstrated increase an individual's likelihood to reoffend. These include, and I would suggest that people, after I announce these, be sure to take a look at the research, look at tools. If you're a provider, understand these more, because just this little bitty piece is not going to give you a full understanding. But these include a history of antisocial behavior, antisocial personality pattern, antisocial cognition, antisocial associates, family marital problems, work-school problems, lack of health and leisure and recreational pursuits, and substance use. All these together, they're risk and need factors. providers may have experience in addressing some of these. So I think, those transferable skills are there for working with justice-involved individuals. So when we move to Principle 5, integrated physical and behavioral health care is part of a comprehensive treatment plan for justice-involved individuals. So we know through the research that formerly incarcerated individuals are at an increased risk for serious and complex chronic health conditions and may require coordinated care with other healthcare professionals. So rates of infectious and non-communicable chronic diseases are high in incarcerated populations and those under supervision. And incarceration can exacerbate these conditions. So this can include HIV, hepatitis C, tuberculosis, diabetes, liver disease, and hypertension. So testing for these diseases and working with healthcare providers is essential in ensuring that justice-involved individuals receive good quality care. Principle 6 is services and workplaces are trauma-informed to support the health and safety of both justice-involved individuals and community providers. Research also tells us that justice-involved populations have high rates of exposure to traumatic events. And while incarcerated, this trauma may be compounded by trauma that's specific to the jail or prison setting, including sexual and physical violence, intimidation, confinement, isolation, and coercion. And prior trauma, even before someone enters, again, compounded by that experience. So for the safety of both clients and the providers, creating and promoting a trauma-informed workplace and approach to services, to the setting, promotes safety and trust, and can minimize any kind of situations that might put providers or justice-involved individuals at risk. Principle 7 is that slide. Let's see if I can advance that slide. Can I get it? There we go. Okay, great, thank you. Case management for justice-involved individuals incorporates treatment, social services, and social supports that address prior and current involvement with the criminal justice system and reduce the likelihood of recidivism or the likelihood to reoffend. So individuals involved with criminal justice, the criminal justice system, reentering from communities from jails and prisons face unique obstacles in finding housing, employment, coordinating health and behavioral health care. And case managers play a critical role in connecting individuals to services that address the social factors that can lead to reduced quality of life, poor health outcomes, and recidivism, including that lack of housing, employment, social services, supports, and untreated substance use disorders. And I think, Pete, you gave us a really good, clear understanding of what that can mean for someone. So case management is so critical there. And finally, the last principle is that community providers recognize and address issues that may contribute to disparities in both behavioral health care and the criminal justice system. So different populations, including those that are based on race, ethnicity, gender, sexual orientation, gender identity, and economic status, have disparate access to high-quality behavioral health treatment. We also know that there is a disproportionate representation in the criminal justice system of minorities, sexual and gender minorities as well, and those that with low socioeconomic status. So it's important for providers to understand that there are structural biases in our systems that can lead to inequality and further perpetuate disproportionate representation in the criminal justice system, as well as reducing access to behavioral health services. So one very clear step in reducing disparities and addressing this principle is to welcome opportunities to serve this population. And I think in closing, that's our last principle. I will say that these principles will support and drive SAMHSA's work going forward. And through the Gaines Center, you will see additional tools and resources that will be coming out in 2019 to support these. We know that we present these principles and providers need the information and resources to fill that gap that has existed. So we look very forward to these coming out and putting these out to the field. Thank you.
Good morning, everyone in the room, and thank you for everyone on the phone for joining us today. I want to welcome you all on behalf of the Gaines Center. We've had some SAMHSA welcomes, and we're pleased as operators of the Gaines Center to have such a high rate of participation on the webinar today. My name is Chanson Neither, and I am the director of SAMHSA's Gaines Center. For my portion of the panel, I'll be providing an introduction and overview of the sequential intercept model, or the SIM, which, as Lark mentioned, is foundational. The SIM serves as an organizing framework for much of the work that we do through the Gaines Center, much of the work that SAMHSA does generally around criminal justice and behavioral health, and about which the upcoming panelists will discuss in more detail. The focus of the sequential intercept model is on men and women with serious mental illness, substance use disorders, co-occurring disorders, and who are also involved with or in contact with the criminal justice system. The SIM can be used as a tool to develop cross-system strategies that promote and support recovery, ensure safety and quality of life for everyone involved, keep people out of jail and in treatment, while in jail, provide constitutionally adequate treatment, and upon release, link people to comprehensive, appropriate, and integrated community behavioral health services. The SIM can be used to address challenges to collaboration. Limited resources can often create a competitive and/or a protective environment among systems. Funding silos can make communication about cross-system efforts much more challenging. Systems often represent different cultures with their own histories, languages, values, concerns, and operations. But these challenges can be overcome using the SIM as a tool. The SIM can be used to improve integrated service delivery by promoting and enhancing collaboration. Collaboration among professionals who work in the justice and behavioral health systems, people with lived experiences in those systems, and family members and other advocates for people involved in criminal justice and behavioral health. But it's not just the criminal justice and behavioral health systems, it's also all of the other systems and supports that are so necessary to supporting a person's recovery. Support systems such as social services, benefits and entitlements, health, housing, and in many cases, veteran services are also critical players to be at the table. The sequential intercept model helps illustrate how people typically move through the criminal justice system in somewhat predictable ways. While we know that the criminal justice system is not necessarily linear, we can use the SIM to ensure prompt access to treatment, that there are opportunities for diversion, ensure timely movement through the criminal justice system, and engagement in community resources. Some of you may have seen the SIM presented as a circle. Others may have seen the SIM presented as a funnel. The model that we use at the Gaines Center and that is most familiar to SAMHSA is the linear version of the sequential intercept model. As you can see, the sequential intercept model consists of 6 intercepts, intercepts 0 through 5. So let's take a closer look at each. So at Intercept 0, we examine what the crisis care continuum looks like. Intercept 0 is focused on what services are available and whether or not there are mechanisms in place for people to understand how to access these services without having to call 911. Some examples of the services and programs that are frequently part of Intercept 0 include emergency room diversion and use of peer support or peer navigators in emergency room settings, crisis stabilization, residential crisis facilities, crisis respite, peer respite, mobile crisis, critical time intervention, and others. As we transition from Intercept 0 to Intercept 1, the arrows between these two intercepts go back and forth. There's a relationship between these intercepts because we know that these intercepts often interact. Sometimes contact with law enforcement is unavoidable for a person in crisis, so the interaction between these two intercepts is necessary. When we talk about coordination and collaboration between these intercepts, it's imperative that the behavioral health community and behavioral health professionals try to help law enforcement officers to answer one very important question, and that question is divert to what? If there is no answer to that question or no viable option in answer to that question, then the person is most likely going to jail. When we look at integrating Intercept 0 and Intercept 1, there are several specialized crisis response models that we can look at that help promote this integration and collaboration between crisis and law enforcement. One of those is centralized drop-off facilities, especially facilities that are co-located with substance abuse services and have police-friendly policies, such as no refusal of anyone who comes through their doors. And very importantly, a streamlined intake process, minimizing the amount of time that it takes for a law enforcement officer to drop an individual who's in crisis off at one of these facilities can substantially enhance the interest of law enforcement in utilizing these facilities for people in crisis. Cross-training is another very important feature of specialized crisis response. Mental health and behavioral health professionals understanding what the law enforcement aspect of crisis response looks like. Often ride-alongs with officers are one strategy for that. And then developing community linkages such as case management, care coordination, co-response, or warm handoff strategies. As we look more toward Intercept 1, looking at law enforcement and emergency services, there are several models that are often used in different communities across the country. One is the crisis intervention team model, which we'll hear more about in one of the later panels. The co-responder model. Off-site support models, where officers in the field receive support via telephone or video conference from mental health professionals. Mobile crisis, and specialized EMS responses. Some common gaps at Intercept 0 and 1 include lack of crisis stabilization units and continuum of crisis care services, including detox, lack of sufficient mobile crisis response, and lack of mental health or crisis intervention team training for 911 dispatchers. As we move into Intercept 2, which looks at post-arrest pre-booking, we find that some essential elements that need to be present at Intercept 2 include the screening and identification of mental health and substance abuse issues, the presence of a court-based clinician who can identify people who should be referred out of the criminal justice system, the use of recovery-based engagement strategies that focus on choice and prioritize the services most important to the person, considering behavioral health needs, and a proportional response that takes into account what services are necessary at that moment and what services are necessary longer term. Looking more closely at the identification and referral aspect of Intercept 2, the personnel who are involved in this process may vary depending on how the court systems are set up. The process may include people such as law enforcement officers, booking officers, jail medical staff, pretrial service agents and agencies, public defenders, prosecutors, and in the case of a history of prior military service, the Veterans Justice Outreach Specialist. Identification and referral at Intercept 2 can utilize many different strategies, including data matching, mental health and substance abuse screening, and potential diversion options for the individual being presented at arraignment. Some common gaps at Intercept 2 include the lack of diversion opportunities, lack of specialized supervision for people with mental and substance use disorders who are on pretrial supervision, and lack of multiple behavioral health screening and identification strategies. As we move into Intercept 3, we look at the courts and the jails. Some key issues at Intercept 3 include screening, identification, and assessment, while in jail access to medication, mental health and substance abuse treatment services, and communication with community-based providers who may have been providing services to the individual prior to his or her incarceration. Court-based post-booking diversion options, treatment courts such as drug courts, DWI courts, mental health courts, veterans treatment courts. There may be one or multiple specialty treatment court options available in the community, and in particular, when multiple options are available, a consideration of which option is the best match for the individual and collaboration among the courts and the screening, identification, and referral process is critical. Some common gaps at Intercept 3 in the jails include lack of sufficient screening for veterans or history of military service, continuity of medication and use of off-formulary medication, and insufficient data about the population with serious mental illness and substance use disorders in the jail census. When we look at courts, we find that there's often an over-reliance on treatment courts over other viable diversion options. Treatment courts are sometimes limited to post-conviction models. Treatment courts may be focused on misdemeanors only or limited to felony or misdemeanors only. And co-occurring disorders are sometimes not well understood in our specialty courts. As we move to Intercept 4, this is where we're looking at the reentry process, the prison or jail, from prison or jail. Some reentry models include refer-out models, where jail or prison institutional staff provide inmates referrals to community-based services upon release. In-reach models, where community-based providers conduct intakes and arrange service plans prior to release. And transitional reentry programs, which are a coordinated and shared responsibility between institution staff and community-based providers for all aspects of reentry. Some common gaps and issues at Intercept 4 include lack of coordination across multiple services and support systems, insufficient medication or prescriptions upon release, lack of enrollment in Medicaid or SSI, insufficient connection to community-based services. The timing of release is often a big issue, procedures surrounding release, transportation issues upon release, lack of stable and appropriate housing options, and lack of treatment providers who can meet the multiple and often very complex needs of people with mental illness and substance use disorders who are involved in the criminal justice system. As we move into Intercept 5, you can see that at Intercept 5 there are two sets of lines, one that goes into the community and one that points back into the criminal justice system. The second set of lines is due primarily to violations of the terms and conditions of parole or probation. And one of the promising practice models that can help address this issue are the use of specialized caseloads by probation and parole departments. Specialized caseloads models rely on effective partnerships between supervising probation and parole officers and community-based treatment providers and other supports, and can reduce the risk of a technical violation by improving linkage to services and improving functioning among people who are under supervision. Some common gaps at Intercept 5 include lack of alternatives to violating someone, lack of specialized caseloads and caseloads with a high ratio of probationers to officers, again, access to appropriate housing, and issues with behavioral health providers, including lack of agreements on what information is and can be shared with probation, poor implementation of risk, need, responsivity strategies, and lack of access to medication-assisted treatment programs. Across the 6 intercepts, there are many gaps that are common. Information sharing and issues having to do with HIPAA, whether real or imagined, can create significant barriers to coordination of care and treatment between and among the systems. Cross-training of criminal justice and behavioral health professionals, what is the role of one versus the role of the other, and a lack of understanding among both the criminal justice and behavioral health systems of the issues and the constraints and the things that they face every day working with this population can contribute to myths and can contribute to adversarial relationships. The lack of trauma-informed approaches and trauma-specific services. You heard Jenny speak a few moments ago about one of the 8 principles and spoke about trauma-informed care and how often our criminal justice settings and interactions, particularly for those people who have histories of traumatic events, can be re-traumatizing. Cross-system screening for veterans and military service, issues related to healthcare reform, integration of peer support and peer services, housing options and access are a big issue, lack of a formal cross-systems planning structure. And that's one of the things that we utilize the SIM for in communities across the country is as a planning tool, working with cross-disciplinary and cross-agency teams of stakeholders to develop a formal planning structure and formal strategic plans to address many of the issues that we've talked about as part of this presentation. And finally, little use of data to inform decision-making and program planning. And that's certainly an issue that particularly over the last several years has had a lot of attention paid to it and a lot of resources being dedicated to further developing database decision-making protocols and supporting communities that want to but don't know how to implement database decision-making strategies. So in summary, the importance of the SIM is that it helps keep people out of the criminal justice system and in community-based behavioral health services. It promotes seamless transition to the community upon reentry, supports the development of a strategic approach to protect public safety and improve public health, and can be used to leverage the community brain trust and help criminal justice and behavioral health professionals to speak a more common language. I want to encourage you, if you're interested in learning more about the sequential intercept model and the work that SAMHSA does and that we do through SAMHSA's GAIN Center, to visit the GAIN Center's webpage at www.samhsa.gov/gains-center. You'll find SAMHSA's 800 number, which you should feel free to reach out to SAMHSA via that number, or via 1-800-311-GAIN. That's a direct link to the GAIN Center if you're looking for more information about the sequential intercept model. Thank you.
Thank you to everyone on the Chan. Thank you, Lark, Pete. We are ahead of schedule right now, so we will allow questions from the virtual audience, also questions in the room. We'll have to restate them so that the audience can hear, but we're glad to take questions right now. Okay, and while we are switching over to questions and answers, we will have the webinar archived and available, and the slides will be available as well. So for those of you who I know have been asking about that, this all will be available. So we do have one of the first questions that we have. Is there a way to approach our court and emergency systems to begin closing the gap between mental disorder and providing services? I will ask Chan, would you like to take this question? The question is there a way to approach our court and emergency systems to begin closing the gap between mental disorder and providing services?
I think if you take a look at this sequential intercept model and some of the information that we have available on the Gain Center website, there are some suggestions about how to begin the discussion of collaboration between and among different systems on these issues. Since I'm not sure, this is Amy, what perspective you're coming from, best way to approach our court and emergency systems. It would be hard to give you very specific advice, not knowing your system and not knowing the perspective that you're coming from, but I would encourage you to visit the Gain Center, to contact us. We have virtual consultations where we can help you talk through what your issues are, who your stakeholders are, and help you come up with a plan to address those issues in your community. I agree. Oh, down here. So I think the next question is, you mentioned difficulty with providers implementing risk need responsivity strategies. It is common knowledge with criminal justice professionals, but do you know of any resources or training for behavioral health providers on the R&R model? Will you talk about that at all as part of your panel? Yes. Mm-hmm. Yeah. So one of the things that we'll be doing through the Gain Center is a learning collaborative on risk need responsivity. If you haven't heard about that panel yet, be on the lookout for more announcements about that. And again, you can visit the Gain Center website. We'll have some more resources as we go throughout the day who will be talking about some of the places where you can get training as a behavioral health professional on R&R. And the Gain Center has also conducted 3 webinars on the topic that are archived and forthcoming, and will be available and announced when those are available. So keep on the lookout for those as well. Some other resources include the National Association of Drug Court Professionals. I believe BJA has some resources on risk need responsivity. Yes. The next question is, are states currently using the sequential intercept model that are good examples of successful implementation. There are states that are using the sequential intercept model as a way to understand how their state systems work together or don't work together, and how the state can help better support collaboration and coordination between behavioral health and criminal justice at the local level. The SIM model has broad applicability, but was really designed to be a model that looks locally at systems. Part of what we use the SIM map to do is to help communities understand their systems by engaging in a mapping process of their systems where they can create a local systems map that really reflects using the general sequential intercept model, what the local, usually county-based system looks like. We've worked with many states in the past, and I'll look to my colleagues in the back to see if there's any particularly good state-level example that you would like me to highlight or you would want to come up and highlight. Okay. So and there's a new, I'm not sure if it's quite a center of excellence is the name in Pennsylvania as well. I think that much of the work's being funded by BJA that'll be doing some implementation work in Pennsylvania at the state level as well using the SIM. Good. So with that, we will go ahead and take a few moments break and transition to the next panel.
Okay, good morning, everyone. My name is Melissa Neal, and I am a Senior Research Associate with Policy Research Associates, and I'm the lead for communications with SAMHSA's Game Center. And am very excited to present this first panel talking about partnerships to pique some interest in this panel. We are going to be covering some information about statewide efforts in using the SIM. So please stay tuned. I'm really excited that we start with partnership when you look across the nation and you look at the jurisdictions that are doing good work in this area in enhancing their behavioral health and justice system collaboration and creating diversion opportunities. The key that we see in many of those places is effective collaboration. People are working well together. Whether you have funding or no funding, whether you are a rich or poor resource area, collaboration can make all the difference and create really unique and innovative opportunities to move people out of the justice system into treatment and services. And so with this panel, we'll be covering statewide efforts, as well as efforts done by one agency. We'll have a supervisor talking about how her one agency, a probation office, is leveraging partnership to improve services to people with mental illness. And so I'm just going to provide a brief introduction of all of our panelists. We have Dr. Mark Munitz, and as Pete mentioned earlier, he is one of the co-creators of the sequential intercept model. He's a professor and the Margaret Clark Morgan Endowed Chair of Psychiatry at Northeast Ohio Medical University. He oversees the Ohio Criminal Justice Coordinating Center of Excellence, which he will be talking about more in his presentation. Dr. Margie Balfour is the Chief of Quality and Clinical Innovation at Connections Health Solutions, and she's an Assistant Professor of Psychiatry at the University of Arizona. Jessica Ethington is a supervisor with the Maricopa County Adult Probation Department since 2005. She also supports a community living placement for justice-involved people who are under probation and have a serious mental illness. And finally, Maria Fryer is a policy advisor with the Bureau of Justice Assistance, and she oversees the Justice and Behavioral Health Discretionary Grant portfolio. And without further ado, we're going to turn things over to Dr. Mark Munitz.
Well, thank you, and good morning. I'm really excited to be part of this symposium, and hopefully what I'm going to talk about will build on what we've already heard this morning. I've been asked to talk about the work we've been doing in Ohio, and we've been doing this work for nearly 2 decades, and I've been given a maximum of 15 minutes to talk. So I'm going to be talking fast and won't cover this in the depth I would love to, but you'll get my slides, and I'd be happy to have contact with you subsequently. So I'm going to talk about the Ohio Criminal Justice Coordinating Center of Excellence, what we call the CJCCOE, and this goes back to May of 2001, at a time when Dr. Mike Hogan was the director of the Ohio Department of Mental Health and had the idea that the state could be more effective in a decentralized system in the age of community-based care if they worked with local universities, predominantly medical schools, but also other institutions, where there was interest, expertise, and energy around a particular evidence-based practice. And they created a number of these coordinating centers of excellence. And at that time, I was a medical director of the Summit County, which is the Greater Akron Area Alcohol and Drug Addiction and Mental Health Services Board, the mental health authority for the county. And we had started what at that time were very innovative programs. We were the first county in Ohio to have a CIT program and had the first mental health court in our state. And so I was enthusiastic, as were some of my colleagues, in spreading the word about these jail diversion opportunities. And so we convinced Dr. Hogan, I think with some help from Hank Stedman at the Gain Center, to create a coordinating center of excellence around jail diversion. So the center was funded by the state using SAMHSA block grant dollars as a 1-year experiment, which has been renewed for the past 17 years, 1 year at a time. We've never gotten an increase in our funding. The funding is quite modest. We're operated by Northeast Ohio Medical University, NeoMed, where I'm now the chair, and we have a very small staff, 1 full-time director, a full-time dissemination coordinator, part of my time, and a growing number of consultants, which have become increasingly important, as well as partners, as we'll talk about, because this is all about collaboration. Our mission is to promote jail diversion alternatives for people with serious mental illness, most of whom have co-occurring substance use disorders, to keep them out of the justice system and keep them in the treatment system as much as possible. And I think really at the inception, Dr. Hogan and Dr. Stedman had the idea that the work that the Gain Center was doing nationally could have even more impact if there was a local version, a state-level version, what Hank called a mini Gain Center. So that's what we've been, and I think we've realized his vision to some degree. If I could have the next slide. So very gratifying to hear the emphasis on the sequential intercept model, because in fact, when we started the work of our center, although there were some promising practices, we were supposed to be, the centers were to promote evidence-based practices, and we really didn't have any at that point that we could say had strong evidence behind them. So Dr. Hogan encouraged me, actually ordered me to create a conceptual model. And working with Patty Griffin, who was a senior consultant with the Gain Center, who had been consulting with us in Summit County, and with Hank Stedman, the sequential intercept model evolved. As you're hearing, it's continuing to evolve. And that's been the framework of our work and has been widely disseminated, which has been very gratifying. Much of our attention in the first decade of our center was to disseminate the Crisis Intervention Team program. CIT, as created in Memphis, we see as the most effective way of partnering between law enforcement and the mental health system, people with mental illness and their families. And in answer to one of the questions of how you get people together, starting a CIT program is a tremendously helpful way of beginning collaboration. In Ohio, early adopters of CIT through our center developed a document describing the core elements of CIT, which informed the Memphis CIT Center creating the core elements of CIT from they're now endorsed by CIT International, kind of the current expert consensus around CIT programs. And we're very proud of having trained close to 12,000 sworn law enforcement officers since we started in 87 of our 88 counties, and are continuing to evolve CIT programs. More recently, in the last half a dozen years, we've with the benefit of training from the Gain Center, we had a cadre of facilitators trained in operationalizing the sequential intercept model into sequential intercept mapping as the Gain Center has developed. And we've used that, I believe, quite effectively now in helping to map serious mental illness services and its intersection with the justice system in 24 Ohio counties. And we've adapted that more recently to address the opioid crisis and have completed sequential intercept mapping focusing on opioids in 9 Ohio counties. If I can have the next slide. If there's one word to the key to our success, it's collaboration, and collaboration at multiple levels. So we've been able to benefit from strong partnerships with national partners. In some cases, those national partners are also funders, which is terrific, and also with state partners and funders. And I don't have time to go through each of these, and they each play a very important role, but I want to make particular note of our partnership with our state NAMI organization, because the work that we've done would not have moved as quickly as it has without the partnership with NAMI Ohio. A lot of that's in kind, some of it's actually sharing funds. I also have to point out that if you want to get collaboration to happen, it's really wonderful if you can find a judge, and even better if you can find a Supreme Court justice. We've been very fortunate in Ohio to have Justice Evelyn Stratton, who when we started was a Supreme Court justice, subsequently retired, and is now even more active in this work and partnering with us as she's taken on leadership of Stepping Up in Ohio with support from a local foundation. Another key collaborator, if you're fortunate enough to find a foundation that can be interested in this issue, we have in PEG's Foundation in Northeast Ohio. Next slide, please. So the second key to our success, which conforms with the collaboration idea, is showing up when invited, and at times asking to be invited, and we have to be a little pushy at times, but we've been very active at state level meetings that bring the stakeholders together across the systems, modeling for local communities what the collaboration that needs to happen at the state level. And then we also convene meetings with our various stakeholder groups across systems. When I refer to friends in the slide, it's people who we don't have funds to support, but they're very involved in our work. It's state level agency representatives, advocacy groups, people from the mental health system, et cetera. We communicate as much as we can. Our CIT coordinators are a statewide group that's informal but very meaningful, very important. We communicate by email and increasingly through video conferencing. Next slide, please. So the real work that makes a difference is at the local level. What we're doing is really to support that work, and we've conceptualized our approach as a top-down and bottom-up, and the bottom-up is much more important. The grassroots work is really where things happen. The top-down is some of it's cheerleading, a lot of it's providing expertise, but the real work happens at the local level, and so we've done that through our dissemination of CIT. I think the way it's happened in Ohio with local champions at local counties spreading the word, and we've assisted in developing a peer review process so that these programs continue to evolve and continue to gain in their quality and adherence to the core elements of CIT, and by convening people involved in coordinating these programs on a regular basis so we can all learn from each other. We've been very involved in the Stepping Up initiative at the county level. Our center director has been traveling the state with retired Justice Stratton, Tom Craig from Peg's Foundation, visiting counties, encouraging them to convene the right group of stakeholders across the systems, including county commissioners or county executives, so that the counties will issue the resolution, step up to try to reduce the number of people with mental illness in their jails, and then refer to our center to do sequential intercept mapping as we were trained to do by the Gain Center folks. So we then help counties assess their readiness to do this, because they need to be prepared, they need to be ready, and then plan in a comprehensive way for a mapping workshop. And then after the mapping workshop is complete, we provide ongoing technical assistance to maintain the momentum that they have coming out of those workshops and to provide ongoing expertise going forward. And the next slide, please. Another benefit of doing sequential intercept mapping in a broad number of counties is you identify in a very concrete way, and it's graphically displayed here, what common gaps are across a state. So in our state, and I think we knew this, I don't think it's a surprise, and I suspect this is true in many states, but we found in the first 23 counties where we did mapping that 20 of them prioritized as a gap that needed to be addressed some aspect of the crisis response continuum. 18 of the 23 counties identified as a priority gap challenges in data collection and information sharing. Housing, you can follow forward, but so if I have the next slide, identifying those gaps at the state level then allows us to work with our state partners to begin to address those gaps on a wider system level, because some of these cannot be solved locally. So we've been trying to address with our state partners the crisis response continuum. In March, we held a statewide conference to look at best practices in our state. And nationally, we brought Dr. Hogan back to Ohio to talk about the Crisis Now initiative. We brought Dr. Balfour in, who you're going to hear from next, to talk about the model program that she's been part of developing in Tucson, Arizona. In terms of the data collection challenge, we have engaged an attorney to develop a manual, intercept point by intercept point, on what the legality is and the possibility of sharing information, and there's more possibility than most people think at each of the intercept points. We started with law enforcement, mental health, and we'll be working our way through the intercepts. We're working statewide on figuring out how to better use CIT encounter data, to use data to inform both CIT programs at the officer level, but perhaps even more importantly at the level of the individual who's encountering the police, particularly those encountering the police repeatedly. And then consistent with what we heard earlier, we've identified that the mental health community really doesn't have the tools yet to address criminogenic risks and needs. And we convened recently a group of national experts to help think together, is this an unmet need for which there's not yet a good answer? And then if the answer to that was yes, which it was, then what can we do to develop an approach that can be used in the mental health community to address these needs? Next slide, please. So I know I'm going real fast, but I want to conclude with some lessons learned. A state-level technical assistance training and dissemination center, a mini gain center, I believe can make a difference in a state. I think we have done that. We've been able to use the block grant dollars available to the state to have an ongoing base of support, and you need that ongoing base of support to then be able to leverage to get additional funding, and we've been able to braid additional funding from state and federal sources and private foundation sources to expand the reach of our work. And I believe there are advantages to states to work with the university rather than to try to have centers at the state level. Although universities have a lot of bureaucracy, my observation suggests it's a little bit less than state government. We also have the opportunity to stimulate research. We have researchers who are not part of our center but are with us and help us then take the work we're doing and begin to develop research studies to address some unanswered questions. We might be able to address some policy issues that are harder for state employees to address. And you can find areas of synergy where, for example, another part of our department is spreading coordinated specialty care programs for first episode psychosis. And we realize in those programs we're not finding people being referred by CIT officers, by jails, or by courts. So we're working to help all of those criminal justice intercept points understand that there are these specialized programs, and unfortunately those are sites and individuals who may encounter someone having their very first episode of psychosis, and we want to get them the best help we can. Next slide, please. I've given you a lot of words, and I thought some pictures would be helpful to really finish up. The map of Ohio, which Ohioans are very familiar with our 88 counties, we're very proud in the upper left of how widely we've spread CIT, and I think and now CIT coordinators getting up to speed in how to do that job. The photographs really just emphasize the importance of bringing people together. To the left is a group doing action planning after a sequential intercept mapping exercise, and you can see people in uniform with people who are probably mental health professionals or advocates. And the picture to the right is one of our statewide CIT coordinators meetings where we come and learn from one another. And my final slide, please. The work that we're doing is very much a team effort, and we have our small team, and I need to particularly shout out to Ruth Samara, this CCO Center Director, who's doing a fabulous job, and Lieutenant Mike Woody, who's been with us from the start, founding president of CIT International. And then a special thanks also to Mike Hogan and Hank Stedman for having this concept of a mini gain center that we've been able, I think, to carry out reasonably well. And I think my final slide has my contact information as well as the website of the CJCCOE, which we would encourage you to visit. It also it has a lot of information, a lot of resources. And with that, I thank you, and I'm done.
Am I good to go?
All right, now we're going to turn to Dr. Margie Balfour for her presentation.
Hi, good morning. Thank you so much for having me. I'm going to be talking about examples of how we've actually done some of the things to support the sequential intercept model down in Tucson, Arizona. Next slide, please. And we pretty much, we have things across all the intercepts, but what I'm going to talk about is the program that I'm involved in that is mostly living around intercept 0 and 1. Next slide, please. And to start off with, I want to talk about our behavioral health system structure, because really, Medicaid has played an important role in the ability for us to be successful in this state. A lot of our people are funded via Medicaid, so they're a very important partner. Arizona is divided into 3 regions, the north, the south, and then the central, which is Phoenix. We're down in Tucson, where the little Wildcat is. Our Medicaid department is named Access, and it, for each region, contracts with a regional behavioral health authority, which is then responsible for all of the payments and oversight of the crisis system, as well as a large part of the behavioral health system. They put it out for bid every year. Ours is Simpatico, which is part of Centene, although they recently, the local group changed their name to Arizona Complete Health. They take money from Medicaid, they braid it along with SAMHSA funds, state crisis funds, county funds, and the result of that is that we have a financing and governance structure that supports accountability and oversight of the crisis system. Next slide. And what that means is that there can be centralized planning around what should the crisis system do, what should its goals be, and then holding all the different partners accountable. And, you know, we're a red state now in Arizona, and they are, very fiscally responsible, but I mean, we are a Medicaid expansion state because that did make financial sense. And what this is a really good example of where the clinical goals and the fiscal goals are actually pretty closely aligned, which also is something that allows kind of disparate groups to work together. Because me as a clinician, my goal is I want my people not in the jail, not in the ER or the hospital, and instead being in the community engaged in care. And those are also things that from a payer standpoint are fiscally responsible. And so like the little conductor there, we have the Regional Behavioral Health Authority overseeing all the pieces, because they contract with all their various providers, but to make sure that they're working together. Next slide, please. And this is kind of an example of how these strategic goals can filter down from the state. So at the state level, there was a goal set through the governor's office around decreasing. I think that's probably why it's the only state where every single county has signed on to stepping up. And granted, we only have 15 counties, so it's better, easier than 88. But that it's been a statewide effort. And so then the Medicaid Department, Access, contracts with all of its managed care organizations and the regional behavioral health authorities. And in those contracts, there are deliverables around reducing criminal justice involvement. So then the RBAs, the regional behavioral health authorities, which are financially at risk, they then are contracting with their subcontracted providers. And in those contracts, there's requirements around doing things to reduce justice involvement. So that results in some targeted processes. So, for example, in southern Arizona, we have Crisis Line, and some of those 911 calls are transferred over to them. The Crisis Line has a dedicated law enforcement number, so when they need to access the Crisis Line for information and things like that, they get a supervisor right away. We have crisis mobile teams, and they are contractually required to respond faster if law enforcement calls them than versus a routine call. And there's also co-responders as well. And then that also leads to, in the REBA contracts with the providers, they contract for some specific programs that are designed, like evidence-based programs that have been discussed previously around the justice population. And another thing that they're required to do is what they call reach in. So if people are in jail and it's their plan member, they have to go in and find that person and work with them on a discharge plan before the release date. And so all of this is designed to reduce justice involvement. Next slide. So in Tucson, our approach in our programs, where I'm mostly involved, is to really have close collaboration with our mental health systems and law enforcement. We have shared goals. We want care in the least restrictive setting, a no wrong door policy, and really treating this idea that law enforcement is a preferred customer of ours. Because if we want to keep people out of jail, law enforcement has the patients, So they're as much as a customer as the patients are. And then really using data to drive our system design. And so as a result, we've been working together to align our training, operational processes, and performance incentives to facilitate these goals. Next slide. And so this is a schematic that's actually from SAMHSA around all the different components of a crisis system. And we have a lot of these, and I'm going to be mostly talking about the stuff in the red area, the response, and then later I'll talk about some of the early intervention prevention. Next slide. So sort of one of the main centerpieces of our crisis system in Tucson is the Crisis Response Center. And this facility was built in 2011 with county bond funds. And it was really driven by the county's desire to reduce the seriously mental ill population in the jail. So it was designed to be an alternative to jail, but also EDs and hospitals, but really driven by the justice system. We serve about 12,000 adults and 2,400 kids per year. And the services, even though the county owns the building, the services are financed through that regional behavioral health authority system. And it's sort of one of its main missions is to be the law enforcement receiving center with really a no wrong door approach. So, we don't ever turn law enforcement away. You can't, be too drunk or too acute or too agitated. We have a 24/7 for both adults and kids. There's a 24/7 urgent care. Anybody can walk in, say, I'm new to town, I need to be connected to services, or I missed my appointment, or I'm just not feeling well. And we can see them and get them out in a couple of hours as like just an urgent care walk-in. The heart of the operation is really our 23-hour observation unit, which I'll talk about in a minute. And then we have a short-term inpatient subacute unit for the adults as well. We're staffed 24/7 with providers, either psychiatrists, nurse practitioners, or PAs, nurses, techs. We have a lot of peers, social services staff. And it really was also meant as a place for the community to come together. So there's space in the building where over the life of the building, there's been different organizations that have co-located staff there. Right now there's a different organization that runs a peer-run post-crisis kind of follow-up wraparound program. And they have an office right there in the building so we can easily refer to them. And then the whole campus is really designed to facilitate for this to work. It's adjacent to a level 2 trauma center, so there's a breezeway connecting us to the ED, so they can send people to us, we can send people to them. It helps us sort of be able to do that no wrong door where if someone has a medical issue, we can transfer them over really quickly. The crisis call center is in the building. They're kind of like air traffic control for the whole system. There is an inpatient psych hospital where most of the civil commitments go, and then the health court is right there so that it all can work together. Next slide. And, people talk about CIT a lot, and it's more than just the training. If you actually go and dig up the original CIT papers or white paper, it talks about how having a mental health receiving facility is critical to the success of pre-arrest diversion, and there's been later research that backs that up. And these are the original requirements for these receiving facilities. And I highlighted number 3 and 4 because when we do consulting around the country and we see all these places, and it's really number 3 and 4 that are the hardest to do well. That not having clinical barriers to care and not getting the officers in and out really quickly. Next slide. And we kind of have this reputation in mental health where, it's easier to get into heaven than a psychiatric facility. So what this means is we don't do that. A lot of some places will be like, well, the person can't be, too drunk. They can't come in if they're intoxicated, or they can't be too agitated. They can't be too violent. We want those people. We think we can treat them better than the emergency room can, definitely better than the jail can. And so we never turn officers away, even if they bring us someone that was, quote, taken to the wrong place. Maybe they should have gone to the detox place across town, or maybe they do have a medical issue. It doesn't make any sense to tell that officer to put the person back in the back of your car and then take them home. or take them somewhere else, because then they'll never come back. So we take everybody and we say to the officers, "Thank you, sir. May I have another?" And then we, we do what's right for that patient. We don't put all that decision making on the officer. Next slide. And then another key feature is, cops are busy and they have crimes to fight. And if we're training them in all of this, recognizing behavioral health issues and bringing them to treatment instead of to jail, then we need to make that easy for them, because they're as well-intentioned as they could be. They also have a lot of, competing stresses, where they've got all these calls to get back on the street. So we want to get them in and out as quick as possible. So our goal, it takes like half hour or so or more to book somebody into jail. So our goal is to beat that. And we set as a target 10 minutes turnaround time for cops to get in and out when they're dropping people off to us. The law enforcement was involved in the design of the building. They really felt like if they were going to be bringing people to treatment rather than to jail, like they didn't want to, they wanted it to be secure and not like they're dropping them off to some like sketchy clinic somewhere. They really wanted a secure entrance, and so this gated sally port was built. So the officers buzz a button, it rings a phone that we all have like PTSD from the ringtone, so it triggers our admissions team to come in and meet them. They have an intake area. We've got an office for them and a restroom for them, where they have everything they need right back there, so they don't have to be walking all over the facility and then staff ask them to take their guns off because they don't like that. So it's really designed to just have them be able to go in and out. Next slide. And it's working. This is a graph that shows the law enforcement drop-offs that we have every month. And then the orange dots are the turnaround time in minutes, the median turnaround time. And so we hit our 10-minute goal pretty much every month. And the bars are divided into voluntary and involuntary. And I want to talk about this for just a usually when law enforcement is dropping people off, they're under some sort of involuntary hold, so some sort of civil commitment, involuntary hold. But in Tucson, it's the opposite. 60% of the people they're dropping off to us are actually voluntary, and I think it's a real testament to them, because they're going out and they're interacting with people and engaging with them and saying, "Hey, would you like to come to a place where you can get treatment?" And they so 60% they drop off, because they're giving them a ride, basically. And one of our docs calls it the Uber police, but I think it's a great thing. Next slide. And we do have a lot of different services, and it's taken 20 years to build this, but I want to spend just a few minutes, if I have time, to talk about what the law enforcement teams are doing, these mental health support teams at the bottom left. Next slide. So I talked about the crisis continuum, and CIT is great around responding to a crisis, but what about preventing the crisis in the first place? Next slide. So Tucson actually has a very old CIT program, and despite that, we had the Gabby Gifford shooting, in Tucson, and so the law enforcement community looked and said, well, really, let's take a fresh look, and is there a way that we can prevent some of these things from happening by getting people connected? Next slide. So they developed these mental health support teams that have a group of officers who are really focused on people who are already in the civil commitment system, making sure they stay connected, and that if they need to be brought in for treatment, that they are done so in a safe and humane way. And then the really innovative part is the detectives who are looking for people who might be falling through the cracks and getting them connected ahead of time. Next slide. So these are these are the mental health team, the MISS team officers. They wear plain clothes, and they have unmarked cars, which I think it looks like a cop car, but they're unmarked, and so that really helps diffuse the situation and not get people so agitated when they see law enforcement rolling up, because it's, they look like social workers. Next slide. And then the detectives, what they're doing is things that, like, if you call the police and you were robbed, you get a robbery detective. Or if you, if there's a murder, there's a homicide detective. But there's not any weird stuff detectives, like my neighbor's not doing well, or like, there's some guy acting funny who walks up and down the street. So they investigate those, and then they look to see if there's a mental health issue. Does that person need to be connected to the mental health system? Are they already connected? Maybe their case manager isn't aware of some of the stuff that's going on. And then if there's some sort of threat to public safety, then they work with the court system. But in all of the years they've been doing this, I don't think they've ever sent somebody to jail. They're able to divert them from further on going down the justice system. Next slide. And this is a training model. I will just skip that. I think I'm at my time. So if you just go all the way to the last slide with my contact info. Oh, wait. Do that one. Go back. And just some outcomes is that as a result of this, so these nuisance calls, like these are the things that land our people in jail. Civil disturbances, drinking in public, vagrancy, things like that. And as this model has been put in place, those have been decreasing every year. And then really a culture change on how the organization responds, how people respond to crisis. So if there's like a call that someone is suicidal and they need to be picked up and brought into treatment because there's whatever involuntary document out there that says they need to be brought in, the person says go away. In most cities, that's a suicidal barricaded person, which necessitates a SWAT team call, which, like the sergeant over the MIST team says, if they're not going to come out for my 2 plainclothes guys, they're not coming out for 30 guys in a tank. So it doesn't make any sense to do that. And so they've stopped using the SWAT team and really taken the time to have the MIST team work with them. Sometimes they call us, and then we can help negotiate. And those have gone down, and that's a big, huge cost savings. So if you now go to the last slide with my contact info. And that is me. And we are a BJA learning site. So if people want to come visit, you can follow that link or email me. And I'm happy to talk about more of what we do. Thank you.
Thank you, Dr. Balfour. And now we're going to turn over to Jessica Ethington for her presentation.
Good morning, everyone. As she said, my name is Jessica Ethington. I'm one of the SMI supervisors with Maricopa County Adult Probation Department in the Phoenix area. If we could go to my first slide, please. So what I want to talk about is the collaboration that we have with a variety of stakeholders, some of those in the mental health court, and I want to talk about some cross-training that we've done with the Regional Behavioral Health Authority, and also how we've been working on bridging the information sharing gap between law enforcement and clinical teams. But first, let's start with probation and our specialized mental health court. So in this court, it's a post-disposition court for a couple of different types of court proceedings. We have review hearings, which is where we try to intervene with somebody's probation grant when maybe they're going down a different path than we would like them to. We also have our probation violation hearings for the SMI probationers in that court, so we can have the full team present to create a proper plan for these individuals. So the team that we have in this court, it's a very strong collaborative relationship between the attorneys, both defense attorneys and prosecution. We have judicial officers who are trained in the SMI population and the mental health system. We have the clinical teams present, the probation officers, community providers, and we also work with the jail staff, specifically some of the internal programs inside the jail for any kind of pre-treatment that we may need to do. And we also have something called Correctional Health Services, where they will assist in making sure that the SMI probationers are getting the care they need while they are incarcerated. So this court is a combination of a problem-solving and a therapeutic court. And what we try to do here is take a more proactive approach to discharge planning and crisis intervention that does not require hospitalization, so that we can try to minimize any kind of incarceration that these individuals may be subjected to. When I say proactive approach, what we typically do is focus on what are the needs of these individuals, what is it that led them to be incarcerated for whatever reason, and what is it that we can do differently with them, with their buy-in, so that we can try to minimize this type of situation in the future. So in order to do so, we have a collaborative approach that's going to include the use of the R&R principle, the risk needs responsivity. So what we do there is probation will assess the risks that they pose to the community through our risk assessment. Here in Maricopa County, we have an OST, which is a pre-sentence risk assessment, and then we have the FROST, which is the reassessment once they're in the community being supervised by a PO. Then we need to identify the needs, and this is something that we do with the clinical team, so we can find out what their clinical needs are and what their normal everyday needs are. Once we have those two pieces of information, we're going to figure out how to best respond in order to meet the risk that they may pose to the community or to the victim of their offense. And we want to make sure that we're also responding to the needs so that we can increase their stability and we can hopefully enhance the likelihood of their success in the future. Next slide, please. So here in Maricopa County, we have a total of 22 probation officers who are specially trained to only work with SMI probationers. They are required to complete a specific amount of training hours annually that are specifically related to mental health issues, such as different medications, different community programs, different agencies, and how to work best with the clinical teams in order to incorporate the harm reduction approach and the risk reduction approach so that we can have a very comprehensive supervision model for these individuals. One thing that we have done is the Regional Behavioral Health Authority has allowed us to have access to their training system. So the probation officers can get the exact same information that the case managers and the clinical teams are getting. So we can share that perspective with them and have a better understanding of what it is that they're doing for the people we're also working with. And then we can marry our approach with theirs. Another thing that we do is we have consistent and regular communication with agency leadership regarding changes in any kind of procedures or practices that we may need to implement. For example, we have a community provider here called Community Bridges. They have 3 FACT teams and a couple of ACT teams. So every quarter, myself and the other SMI supervisor, along with our division director from our department, meet with their leadership and the clinical coordinators for each of those teams. We review what has and hasn't worked, what we may be able to improve on, and then we try to make some changes both from the clinical side and from probation side so that we can try to meet everybody's needs and make sure that we're addressing anything that the probationers are experiencing so that we can help them achieve that success that they need. Next slide, please. So one thing that Maricopa County Adult Probation is doing with this cross-training is we create monthly trainings that we conduct or that we share with the clinical teams. These trainings explain what probation is, explain probation's purpose and the goals. We talk about how we're trying to assist them in implementing positive behavior change so that they don't come back to us. We focus on the fact that the clinical teams are going to be there long-term and probation is here short-term so that we can do everything we can to assist them in establishing a lifestyle that's absent of the criminal justice system. We've shared our risk assessments, how we conduct them, why we conduct them, and when we conduct them, and how we're trying to incorporate a risk reduction model into our supervision. when we're doing a risk reduction model, what we're trying to do is assess the risk of each of the criminogenic needs, of the criminogenic factors, When we identify what the highest risk needs are, then we want to try and figure out what is the behavior that is driving them to have the consistent involvement in the criminal justice system. Once we identify that, we'll create a plan that's going to marry well with the harm reduction approach that the clinical teams are taking. We've also discussed the mental health court and individual roles inside that court. We talked about what the judge's responsibilities are, the attorneys, probation officer, the community providers, as well as the clinical team's roles. There's a clear delineation of roles, but also an understanding that sometimes we have to blend those lines in order to make things work. So another thing that we've done is we've made sure that clinical teams understand what our case plans are, which is basically a probation version of an ISP. And we've also made sure that the officers understand what an ISP is and how it's created and how often and why. We've also created a way for the probation officers and the case managers to share these with each other without violating HIPAA so that we can make sure that these plans mirror each other so that we're not overwhelming the individual with a variety of goals and a variety of responsibilities, and we're trying to reach the same ultimate goal for their success and their stability. Next slide, please. So one thing that we're really focusing on with the clinical teams and with the REBA is bridging that information sharing gap, which can be a daunting task. We have to make sure that we're protecting their right to privacy. We want to make sure that we're not violating HIPAA. We want to make sure that we're not oversharing information that not everybody may be privy to. One thing that we do have from our court is an administrative order that allows for information sharing between probation and community partners that does not necessarily require an ROI, but it's only for public safety issues, such as if we have a probationer who may be having contact with a victim, and maybe it was a pretty severe offense that they're on probation for. If we don't have an ROI, maybe they switched clinics or something like that. If we don't have that ROI, we can tell them, you know, the court has said it's okay for you to give us some basic information so that we can try and protect the victim and protect the community. This has allowed us to really work with the clinical team so that we can try to reduce the number of warrants that we issue for the probation violation. That way we can kind of tackle those issues ourselves rather than involving the courts and the jails, so that we can try and get them back on track without having to take them into custody. We've also created some secured inboxes in Outlook, in our email system, to streamline the sharing of the protected health information. So we have court every Wednesday, and one thing that the case managers have to do is prepare a progress report for court. That progress report is going to have some protected information such as medication and diagnoses and programs. So instead of them having to send that through multiple channels in order to maintain the confidentiality of the information, we were able to create these protected inboxes so that they can send it straight to our Outlook and our emails, and the probation officers can pull the information straight from there instead of having to wait till the 11th hour sometimes for them to work through their own process through the REBA, and we can pull that information and have everything ready a little bit earlier for court. We're working on trying to do that from probation's reports to the clinical teams as well. Instead of having to fax them, we can try and share them electronically. The emails that we have, we're only able to send encrypted emails within the county. So we're trying to find a way to reciprocate that with the clinical teams. We want to make sure that the case plans that the probation officers are creating are very similar to the ISPs that the clinical teams are creating. So in order to do that, we found a way to redact the information that we can't share with other agencies that are not law enforcement. And we share that information as often as we possibly can with the clinical teams. This would include their terms and conditions of probation, the pre-sentence reports and the probation violation reports, and the case plans, and we can also share the results of the risk assessments. So we just have to take some basic information off of there, and we provide all of that as often as possible to the clinical teams so that we can make sure that they're aware of what's going on with this person's probation grant. And that way we're not running into issues with victim safety or community safety that the clinical team may not have been aware of before that could impact the compliance with probation. So the result of our efforts with bridging this information gap has led to probation being considered as part of the clinical team. In doing so, we've been able to establish an expectation that probation be part of the regular staffings at the clinics or in the hospitals for discharge planning, that they are in attendance or at least brought into the creation of any kind of discharge plan that's outside of court. They're consulted on housing placements and applications that are submitted by the clinical teams for treatment plan or residential or anything like that. And we're able to put and to incorporate the court's expectations for these individuals into the clinical expectations so that we can make sure to streamline the supervision from both sides and to make it more of a comprehensive and collaborative approach, thus leading to lower recidivism rates and more success for these individuals. Thank you.
And now we welcome Maria Fryer to the podium to share about federal resources that are available.
Hello, and thank you for being here today. I apologize for the sound of my voice. It's the time of year, I think, and I've been told by close colleagues it doesn't sound that bad. So with a few slides, I'm just going to continue. Thank you very much to SAMHSA, Jenny in particular, Locke, and David for having us. So to start at the beginning, these are just some of the products and services that BJA bring to actually operationalize the policy discussion and bring it to the local level. And one of the biggest programs and what I'm most proud of to start at the beginning is with the JMHCP, the Justice and Mental Health Collaboration Program. A little history about the JMHCP and how it came to be. It was authorized through the Mentally Ill Offender Treatment and Crime Reduction Act, known as MIOTCRA. And it authorizes $50 million for criminal justice and mental health. It was reauthorized in 2008, and we had continued changes to the legislation in 2016. You may have heard of the 21st Century Cures Act, which amended and reauthorized the JMHCP program first created by MIOTCRA. And typically each year, the funding that's allocated is between 10 and 12 million for programming and training and technical assistance. In fiscal year 18, that dramatically increased from typically the 10 to 12 million to 30 million, which substantially increased our ability to support states, tribes, and local governments and how they respond to people with mental illness and co-occurring mental illnesses and substance use disorders. And through JMHCP, our focus has increasingly shifted toward more system-wide improvements to create bigger impact on the problem, identifying people early on from first contact, of course, with law enforcement, collecting more data, understanding the gaps and the drivers of people with mental illness in the system, and learning how to facilitate broader, more comprehensive approaches that include additional stakeholders in government, health, and safety. Next slide, please. So the purpose of the Justice and Mental Health Collaboration Program, of course, is to help states, local governments, and tribal organizations improve responses to people with mental illness who are involved in the criminal justice system. Since its inception, JMHCP has been promoting and the development and implementation of statewide change. In many ways, it has been the fire starter for change between multiple community stakeholders. Its broad application has provided states, tribes, and communities the mechanisms to open up those communication lines between justice, juvenile justice, mental health, and substance use treatment systems to meet local needs and grow the strengths that may already exist in a coordinated response. JMHCP requires that grantees partner between justice and mental health authorities to improve outcomes by increasing access to appropriate community-based service delivery systems of care and coordinating public safety outcomes. Next slide, please. There are 3 categories of the Justice and Mental Health Collaboration Program, 2 of which focus on preventing people with mental illness or co-occurring mental illness and substance use from moving deeper into the criminal justice systems, and those are categories 1 and 2. Category 3 is the broadest category in terms of what it can fund for project development. It can enhance or expand a front-end collaborative response. It can help expand a well-established needed services for people that are in the system to help improve those recidivism rates and improve upon connections to care when a person is preparing to reenter. Having these 3 broad categories requires our training and technical assistance providers to possess a wide variety of expertise, from law enforcement all the way through to reentry. Each grantee is assigned a training and technical assistance provider to assist in the implementation and sustainment of the project after the federal funds have ended. Next slide, please. This is one of our proudest achievements, which was mentioned earlier by Tucson and described by the Tucson Center, and it's the Law Enforcement Mental Health Learning Sites. The BJA-supported Law Enforcement Mental Health Learning Site Initiative delivers peer-to-peer learning through a cooperative agreement with the Council of State Governments Justice Center. The current 10 agency sites above represent a diverse cross-section model strategies and examples of police mental health collaboration. These 10 learning sites as host agencies offer their experience and expertise to promote strategies through a police mental health collaboration, such as crisis intervention teams, co-response teams, mobile crisis teams, case management approach, and a tailored approach that can save the life of an officer, a person with mental illness, or a family member. Together, these sites provide resources for states and local law enforcement agencies to more effectively respond to people who have mental illness. Agencies that receive technical assistance through the learning sites to enhance their strategy can reduce repeat encounters with law enforcement and make encounters with officers safer. Each learning site will answer questions from the field. They host visits. They work with the CSG Justice Center staff to develop materials for practitioners and community partners. So please contact the Council of State Governments Justice Center if you would like more information. You can also go to the Police Mental Health Collaboration Toolkit, where the information on these learning sites is also listed at www.bja.gov/PMHC. Next slide. The online and mobile resources for law enforcement, one of our biggest achievements in 2016 was the Police Mental Health Collaboration Toolkit. Prior to the launch of this toolkit, in actually 2014 and going a ways back, we convened a group of law enforcement practitioners, researchers from the field, academics, and advocates, and really wanted to hear what is a need of the field. And overwhelmingly, we heard loud and clear that they needed information. They needed information on how to collaborate, what are the resources, what are considered best practices, and they needed it in one place. This inspired the one-stop shop of the Police Mental Health Collaboration Toolkit. So what is the toolkit and how can it be used? The toolkit is an online and mobile resource designed to give law enforcement specific answers to design a strategy and partner with behavioral health that meets their agency's needs. It guides law enforcement through the process of starting a new police mental health collaboration or enhancing an existing collaboration. It's designed to be operational and interactive. Each module is arranged by content like overviews and narratives, videos, FAQs, and loads of resources. It's self-contained, and everything is contained within the toolkit. The toolkit addresses key topic areas, including PMHC program planning, implementation, management, training, and performance measurement. The material is drawn from the experiences of law enforcement practitioners, including the 10 agencies that serve as the law enforcement mental health learning sites we just mentioned earlier. It is currently in new development with modules such as behavioral health perspective. We knew this was an important piece. If we're going to talk about a collaboration, of course, we started with law enforcement, but we know the other half of that is the behavioral health community. Of course, people with lived experience, a very important piece. And the law enforcement executives' needs, and how do they implement? How do they maintain? How do they collect data? And how do they continue to tell the story of what works? These are all coming in the next year, and I'm so happy to be here today and share with you those resources. We're going to have more resources this afternoon by someone who sounds a lot better. So thank you very much for having me.
Thank you, Maria. And that concludes our panel. We are now taking a break for lunch, and we will start back promptly at 12:30 Eastern Time for our second panel on crisis response and early diversion. Thank you.
All right, good afternoon, everybody. This is Brian Case. I'm with SAMHSA's Gain Center. This panel number 2 that we have for the symposium today is going to look at crisis response and early diversion programs, which are really a laboratory. A lot of communities are focusing on developing different models for approaching adults with serious mental illness in crisis, and also youth with serious emotional disturbances in both community and school settings. Our speakers today are first we'll have Ron Bruno, who's a founding board member of CIT Utah, CIT International. All right, and the current senior vice president of CIT International and a founding board director and executive director of CIT Utah, director of CTS services, and also a member of the Interdepartmental Serious Mental Illness Coordinating Committee. Our second presenters are from Diversion First in Fairfax County, Virginia. We'll have Lieutenant Reddick Morris of the Fairfax County Sheriff's Office. He's the co-CIT coordinator and supervisor at the Merrifield Crisis Response Center. Presenting with him will be Lisa Potter, who's the Diversion First lead at the Office of Strategic Management in Fairfax County. Our third presenter today our third presentation will be from Jackie Green, who's an assistant professor of public law and government in the School of Government at the University of North Carolina at Chapel Hill. She's also a senior advisor to the National Center for Youth Opportunity and Justice. And finally today, to talk about federal resources, will be Ruby Kozelbosch, who's the Associate Deputy Director for Justice Systems Policy with the Bureau of Justice Assistance at the United States Department of Justice, where she oversees BJA's criminal justice reform work, including the Justice Reinvestment Initiative. So let's get started today with our first presentation by Ron Bruno on crisis response systems.
Well, thank you, Brian, and good morning or good afternoon, depending on where you are in the country. I'm going to be talking about crisis response. And just so you know, I do have a law enforcement background. I am still a law enforcement officer. So I'm going to share some perspectives as a law enforcement officer, a CIT officer, as an administrator of a statewide CIT program, and as an advocate for crisis intervention teams internationally. But, you know, when I talk to communities and try to talk to them about crisis response, what kind of system? There's always this overarching, looming question that is hanging out there, and I would like to actually begin by addressing that question with you today. Crisis response. Should the criminal justice system or the mental health care system have primary responsibility? Sounds like a simple question. Sounds like it should have a simple answer, but it really doesn't. It really doesn't, because, of course, historically, it is defaulted to the criminal justice system. And I can tell you one thing, the criminal justice system really does find ways to try to address things. Not always the correct way, not always the most effective way, but they always find a way to correct things or to work on things. And a lot of times just throwing training at it. Well, if there's a problem, hey, we'll just train our way out of it. But unfortunately, crisis systems are something that we just can't train our way out of. We've got to look at who has the major responsibility, whether it is law enforcement services or if it's criminal justice services or mental health care services. And that's what I kind of want to talk about today, which direction we should head into. I'm going to be kind of pointing out some of the ISMIC recommendations, and then I'm going to walk us through a crisis response system that's integrated and can be effective, and talk about the different types of components and how they're integrated. But as we look at the recommendations that were inside the ISMIC report that were provided to Congress last year, especially the ones that were from the Criminal Justice Work Group, if we look at 4.1, support interventions to correspond to all stages of justice involvement. Consider all points, including the sequential intercept model. We've already heard about the sequential intercept model, and we heard about intercept 0. That actually was, for those of you that were not clear, that actually was an intercept that was added later on. The original model began with 1, law enforcement involvement, but then they thought, but isn't there something before that? And that's where 0 came along. And if you look and read the recommendation in the ISMIC report, it actually clarifies. It says, pay particular attention to the 0 intercept, community services. because that's where we really should be addressing crisis response, is at the community services. If we look at the next recommendation, 4.2, it says develop an integrated crisis response system to divert people with serious mental illness and serious emotional disturbances from the justice system. And it goes on in detail to say community-based mental health services must be in place to address the crisis needs of the people with SMI and SED. Again, going back to intercept zero, we need to make sure we have those accesses. And it goes on to define that a person with serious mental illness or a serious emotional disturbance who is in crisis should be able to get adequate mental health care in the community without contact with law enforcement, I mean, if you think about it, and as a couple of my colleagues have said and have confirmed, one of my colleagues, Dr. Amy Watson, says, you know, the problem is that families and people that have lived experience will wait till it's very dire before they will reach out to 911 to have somebody with a gun toting on their side come out and deal with their loved one or that person. And I asked my other colleague, Pete, about that today, says, how do you feel about that? And he agreed that, you know, if there's access without calling law enforcement, yes, people would access that quicker instead of waiting until the crisis is that much more severe. So we really kind of got to look at how we can develop that. So let's walk through a crisis response system. As you can kind of see, there's two kinds of fields here. If you divide this right down the center, there's two kinds of fields here. On one side, it is the criminal justice system. On the other side, it is the mental health care system. The criminal justice system has the ECC, which is dispatch, the Emergency Communications Center. On the other side, the mental health care system hopefully has a 24-hour a day, 7-day-a-week crisis line. And I say hopefully, because many places in this country, the crisis line does become 911. And in other parts of this country, we actually have a dedicated crisis line, but at 5 o'clock, everybody goes home. So somebody calls up, gets the crisis line thinking they're going to talk to a clinician, and the words they hear are 911, what's your emergency? And that's the issue is, again, we're bringing the criminal justice system into it. We're bringing it up front, and we wanted to put it as a supporting role in back. You'll notice that there's that big fat arrow that is in between those two systems, the ECC and the crisis response. And the reason is because those two have got to be working together in collaboration. So, for example, we train our dispatchers, or our call takers, I should say, to ask a few series of questions to determine, is there a real need for law enforcement to respond out? And if not, they can do a warm handoff to the crisis line. And many times that crisis can actually be resolved just over the phone with the crisis counseling. You know, when I go around the country and I teach law enforcement officers how to de-escalate situations, how to recognize behavioral health issues and de-escalate a person that might be in crisis, I always ask a series of questions. And one of the questions I ask is, raise your hand if you would say that the majority of calls for service regarding mental health issues require a law enforcement response. And guess what? Nobody raises their hand. The majority of calls we're sending our police officers out on for crisis do not require law enforcement. So why are we doing it? We're making it a criminal justice system every time we send the law enforcement officer out to that. Let's step down to the next level because, you know, we need to have some resources past those two. And you'll notice that over on the criminal justice side from the ECC, of course, we can always dispatch out, and it's a resource, EMS and law enforcement. Over on the other side, hopefully we have some resources under there too. So, for example, a warm line. A warm line is generally staffed by a certified peer specialist, somebody with lived experience that can actually understand what somebody might be going through. Law enforcement gets a lot of calls sometimes where a person, because of their mental health issues, might believe something and call law enforcement about that issue. And law enforcement will go out and make the determination, well, there's really nothing I can do. The person's not a danger to themselves or others. This is obviously just a mental health situation. I can't do anything, and they leave. And then a few days later, a week later, person calls in again because of that, and all of a sudden law enforcement goes out, and it's just this rotating door. However, that warm line has actually shown that communities that have integrated a warm line, that a call can come into the crisis line, they determine that it is not a need or it's not a real crisis. This is a person that needs an empathetic ear, somebody that can understand what they're going through, and they can hand that off. And generally, build up a relationship so the next time that person is having those symptoms, feeling that way, or have those concerns, they can contact the crisis line and say, I want to talk to John at the warm line, and get handed down and completely remove all of those calls that were going to law enforcement. But hopefully they also have an MCOT, Mobile Crisis Outreach Team. Let me just talk right now real quick. We've got some major law enforcement agencies in our country that are doing co-responder models. And that's really great for those very, very, very few gigantic law enforcement agencies that could possibly even support it. But we know that the majority of law enforcement agencies in this country cannot support mobile or embedded dedicated co-response. Just cannot do it. In fact, if you look at the ones that are out there, to be honest with you, I cannot name one that is a primary response that can handle the load of their community. So they've got to have something else. And if the co-responding team is strictly always a cop coming with them, then that's, again, always making sure the criminal justice is involved. However, if you look at this model where we can have a dedicated mobile crisis outreach team that is separate from law enforcement and allow them to go out and actually deal with a situation when law enforcement isn't needed, and at those times that law enforcement is needed, they can contact MCOT, they can come out together, and guess what? We have a co-responder model. So it kind of can serve both. And as far as that law enforcement component, and I'll talk about that in just a little second here, we need to have not just every single law enforcement officer. We need to have an expert, a specialist, but a specialist from patrol. We don't want to ask a law enforcement agency, hey, you've got to create something special. What we want to ask them is identify some patrol officers that have that in their heart that they want to deal with this population and become an expert in that, and give them the training and the support and the continued training so that they know the resources that are out there. Not only the resource of, hey, this person needs help in that building, not just the resource as, hey, they need to speak to a clinician in that building, but a resource, they're so expert they can say, I know the resource. You need to talk to John in this building. In fact, let me call him and set something up. And then we go to the next level, which is the ER from the ECC side, or hopefully we have a dedicated receiving center, triage center, whatever you want to call it, or even some areas are access centers, which is part of a hospital system, but it is in a separate way and it goes off the living room model. We've already heard from Tucson today how successful that model is, and it really does work. But you notice that box in the middle, and that's really the whole idea, is that the person can remain at the scene. We've got to stop training our communities in our country to think that when my son, my loved one, my child has a crisis, or when a person with lived experience becomes symptomatic, we've got to stop training them to think, I got to contact law enforcement so they can come out here, put me in handcuffs, take me to the hospital, to an ER, so they can talk to me for a few minutes, because that's the only way I can have my symptoms addressed. We need to get them to start thinking, hey, I need to contact the crisis line, and hopefully they can resolve it there. But if not, they can send out a clinician that can provide that exact same destabilizing care that they would get in the ER right into their living room. Because what happens is then we start to train our communities to understand you can deal with your symptoms many times right in your house. You do not have to be unplugged from society or from your community. And then the last focus that I wanted to just quickly touch on is 4.3, prepare and train first responders on how to work with people with serious mental illness and serious emotional disturbances. And it says, ideally, crisis amongst people with SMI and SED should be resolved without involving law enforcement. You see that continuous theme. But when the crisis system fails or the level of dangerousness warrants, law enforcement and other first responders should be prepared to respond safely and effectively to people with SMI and SED. I'm with Crisis Intervention Team, and that program is realistically not a training program. It is so misunderstood. People think that it stands for CIT instead of Crisis Intervention Team. They think it's Crisis Intervention Training. That program, realistically, it stands for development. First off, development of how do you build the system? How do you bring the partners together? What do they talk about, and how do you develop that crisis response system? It's development. How do you develop that expert officer? And that's really what CIT is about. I invite anybody that has an interest. You have my contact information, but you also have the website of www.citinternational.org. You can go on there, read our research papers. You can read our statements, our position statements, and you can get the core elements of CIT. Thank you.
Thank you, Ron. So our next presentation is going to be on Fairfax County's Diversion First Initiative, featuring Second Lieutenant Reddick Morris and Diversion First Manager Lisa Potter.
Hi, good afternoon. So we wanted to start off our presentation just by providing you a little bit of context about our community. Fairfax County is a large urban suburb of Washington, D.C. We're about 15 miles west of the district. We have over 1.1 million residents, and our county spans about 400 square miles. We have the largest community services board, which is the behavioral health entity, the largest jail, police department, and public safety system in the state. It's a very diverse community. Approximately 30% of our county residents were born outside the United States, and there are over 100 languages spoken in households throughout the county. It's generally a very prosperous community, though we do have very large pockets of economic, social, and other disparities, certainly among people with behavioral health needs. We have had tremendous community and political support for our diversion initiative, but in a county of our size, one of our challenges has been taking this to scale. Next slide, please. So just a quick note about our overarching Diversion First initiative, and this is our system-wide effort to offer alternatives to incarceration for people with mental illness, co-occurring substance use disorders, and/or developmental disabilities who come into contact with the criminal justice system. And our goal is at every intercept point, and we do use the sequential intercept model, to provide either some type of intervention or an alternative to incarceration. We started this initiative in 2015, but really kicked in our efforts and started programming in January 1st of 2016. Next slide, please. So our initial efforts really kicked off with gathering a group of stakeholders and mobilizing the community. And we started with a group of about 40 stakeholders, and now we're over 200 strong. We also have a very active Diversion First leadership group, and that's a group of policymakers who come together when there are barriers and challenges that can't be resolved at the program level. Early on, we tried to align ourselves with national efforts and best practices. We signed on to the Stepping Up initiative as well as the White House Data-Driven Justice Initiative, and we started planning for our Merrifield Crisis Response Center in August of 2015. We had a very aggressive timeline, and our goal was to open January 1st, which was about 6 months later. And for those of you who know or work in local government, that was lightning speed to get things up and running. We had a lot of MOUs to get in place, processes and business practices for exchange of custody, staffing, physical space, but we were able to do that and opened that crisis response center, which allows for exchange of custody among 7 jurisdictions. It's open 24/7, and Lieutenant Morris will speak a little bit more about the activities that occur at the MCRC in just one moment. We also focused heavily on CIT and mental health first aid training for first responders, for law enforcement officers, police department, office of the sheriff, also for fire and rescue, for the magistrates, general district court, juvenile court. We really cast a very wide net for CIT and mental health first aid. So that was the bulk of our efforts in 2016. Then in 17 and 18, we moved into a focus on the jail and instituted the brief jail mental health screening for everyone booked into the jail, focused on supervised release programs and pretrial services and other court services. We also did design a co-responder model that we've just piloted, and to the earlier point about that being the only response, we do also have a mobile crisis unit that responds to other emergency calls, not as part of the co-responder model. We have a veterans docket. We just initiated a drug court, and we have a supervised release compliance docket. We're in the process of submitting an application to the Virginia Supreme Court for a full mental health docket. We're also working on on-site medical clearance for our crisis response center, continuing to work on data and evaluation, and our focus in the next year and probably beyond will be more work in intercepts 4 and 5. Next slide, please. So our Merrifield Crisis Response Center, or MCRC, is located within our behavioral health site in Merrifield, Virginia. And this site offers law enforcement personnel an opportunity to transfer custody, and we have an array of mental health services that are also provided to include screening, assessment, outpatient, case management for both youth and adults, psychiatric and med management services, peer supports, and integrated health care. So at this point, I'd like to turn it over to Lieutenant Morris, who's going to talk more about the services and supports offered at MCRC.
Good afternoon. If we can go to the next slide, please. Thank you, Lisa. As you can see here, Lisa just talked about the Merrifield Center, 254,000 square feet of building here, which CSB was able to bring all their services that were once located throughout the county into one particular facility. As she mentioned earlier, you have the diversion from potential arrest. As we are able to take individuals who may have a low-level offense in the field for a call for service. Individuals may be experiencing mental health change. Officers who have gone through training, mental health training from CIT to mental health first aid are able to make that determination in the field and bring those individuals to the Merrifield Center for an assessment. And that exchange of custody is usually with my group here, where we do that warm handoff of individuals from officers from the field to the officers from the police department as well as the sheriff's office here at the Merrifield Center, at which point they can be assessed for their mental health change. But there's not only involuntary admissions, we have voluntary admissions as well. They come through here. We also have referrals to the appropriate level of care and connections into the community. And we also have a very robust peer support group. So we have a peer recovery support specialists that are here as well. Next slide, please. As I spoke earlier in reference to training, as we talked about the CIT piece, the Fairfax County law enforcement officers, we have over 550 that have been trained in CIT, but we have a very robust partner group here with other 8 agencies in Northern Virginia. We've trained over 700 in the CIT 40-hour block of instruction, but also to help out in making sure that our law enforcement community is trauma-informed, we have taken on the mental health first aid training as well. And that mental health first aid training for the Sheriff's Office is a 100% investment for all staff, and we're at 571. We're just about 85% done. And then we also have our fire department partners as well. They have over 900 of their staff that have been trained. And as we talked earlier in reference to the diversion from arrest, over 5,000 people have been brought into the Merrifield Center by our officers in the field. And this is part of that training piece, as we've seen our numbers greatly increase from the paperless emergency custody order to the paperless emergency custody order. And of those 5,000, 1,200 were diverted from potential arrest. And that's a very big number as it relates to almost over $80,000 to incarcerate someone in a local jail for 1 year who may have a mental health concern. So that's a very big savings to us here in Fairfax County. Next slide, please. One of the things that we've learned as far as staffing, data, and as we celebrate our successes, from the staffing piece, when we first started in 2015, we started here with 4 people 2 from the Fairfax County Police Department and 2 from the Fairfax County Sheriff's Office, and it was a 12-and-a-half-hour schedule. As we move forward with the support and the vision of our executive leaders from our 8 agencies as well as from the local government itself, we went 24/7 over a year ago. So our staffing increased. Presently, we're sitting at 16 law enforcement officers, excluding supervision, and we're doing 24/7, which is greatly aided from the field with the training that the law enforcement community has received. With those numbers that have increased from the ECO perspective, it greatly helps. But one of the big things we have to do, we have to take into account, is this individual the right fit? As you know, training is one thing, but an individual employing that training is something that's very important to us as we are supporting the Diversion First initiative here. So finding the right people and being able to select those individuals based off of our recommendations has been huge, and we've been very successful for those 16 people that are, our boots on the ground. As far as our data, as we know, data runs everything. We have our own data and collection individual here who reports back to the state, but also reports out to our stakeholders group because they want to see what's the return on investment. And one of the big things we're able to do is provide that information. And as we continue to grow, we look at other ways and other data that we can collect, which will give our executive leadership here in Fairfax County the information that they need. As we celebrate the successes, sometimes that's a little hard because we're in the middle of it and making it happen, but we do have an annual report that goes out every year. Right now they're working on the one from last year, from the data for last year, so that'll be coming out soon. We celebrated our 24/7 operations here at the Merrifield Center, which is very, very big for us. And also, we get out as much as we can, and quite often, to be honest, to present to the community. And that's an ongoing endeavor for us, and it's also the piece that helps us to market our brand that we have here at the Merrifield Center, just so that we can get the word throughout the county and throughout the region that we have here as well. Next slide, please. So the lessons learned, staffing and resources. Well, we have great success here that we've experienced in Fairfax County with the Diversion First piece and the Merrifield Center, and being able for officers to spend probably about 45 minutes to an hour so they can get back into the field. But with that and that training endeavor, we're seeing a spike in our numbers, as I mentioned earlier, as far as the ECO perspective. So officers are very well informed, they're trauma informed, and they're taking those new skills and they're employing them in the field. And so a lot of individuals are being diverted to the Merrifield Center. One of the things we look to do is, as we continue to grow and we look to increase our business process, is to make sure we have those clear goals. And we also take the time to review what we have in place. And we also look for champions. We look for champions everywhere. As I'm speaking to this group here, we hope that we'll get some feedback from you all and champion the successes that we have here. Maybe even speak to a few of you who'd like to launch a similar endeavor that we did here in Fairfax. Some of the challenges, I think this is across the board, as we get into information sharing. As we know, our mental health professionals are covered under HIPAA, and also we have those who are in the substance abuse community with 42 CFR. And obviously, when you bring a group of law enforcement folks into a human services side, it's a little different. So there's some different cultures as to how we may conduct business, but we all are for one common goal. So over the time, we've been able to meld that pretty good through our leadership on site from the public safety side, and also the leadership that's here from the CSB. One of the other things is with this success, that's the other thing that comes back to get us as we co-locate here. With that success, we're outgrowing what this brand new building that came open back in 2016. But I'd rather have the success and a place to bring our individuals, and then we can continue to grow from that point moving forward. Next slide, please. Well, that completes our presentation piece. But as you can see here, there is a link to fairfaxcounty.gov as well as the Diversion First site for us here. So there'll be additional information as it relates to what we're doing, where we're going, and we invite any of you to reach out to us if we can assist you in any way.
Okay, thank you, Lisa and Lieutenant Morris. Our next presentation is from Jackie Green to discuss the school responder model.
Thanks, Brian. Holly, you can go ahead and advance to the next slide. So I am here today to talk with you about a younger population than you've heard about so far in this panel. I'm here to talk with you about our young people who are still school age. So that can run anywhere from our wee ones who are going to school all the way up to our oldest ones who are in high school. And I'm going to talk to you about the school responder model. So this is an effort that began with what we called Models for Change, which was a huge juvenile justice reform initiative funded by the MacArthur Foundation for many, many years. And there was a Mental Health Juvenile Justice Action Network as part of that work, which was a bunch of state folks coming together to think through the problem that we have in the juvenile justice system, that youth with mental health needs are way overrepresented. So about 70% of young people who come into the juvenile justice system have some kind of mental health need. These folks came together and started to think through, what do we do about that? And one of the things they thought should be done is that many of those young people who are not true risks to public safety ought to stay out of the juvenile justice system. And that's where the school responder model was born. The first folks who worked on it were in Connecticut, in Summit County, Ohio. We consider them our founders. And as you see on that slide, the work has expanded. There was a really great public-private partnership between SAMHSA and the MacArthur Foundation that helped us support folks in 2 cohorts to kind of expand this work where they are. And currently, there are 4 high schools in Michigan and 4 high schools in Louisiana who have just launched school responder models as part of an NIJ Comprehensive School Safety Initiative study who we've worked with as well. Next slide. So why schools? Well, first, we know from a lot of data that if kids are going to access mental health services, and the data tell us most often kids with mental health needs don't have access to those services, but if they do, they are most likely to access them at school. That doesn't necessarily mean school runs those services. There might be host those services of a community provider inside the school, but we know if kids are going to get mental health services, the most likely place for them to get them is at school. We also know from lots of national data that young people who are classified with disabilities for educational purposes are disproportionately arrested in schools. So they make up about 12% of the overall student population, but they represent a full quarter of kids who are arrested in the school setting. And, you know, generally, if you want to find kids, look for them at school. They spend a lot of time there. So schools are a great place to get a big bang for your buck if you want to focus on this work. Next slide. So something that's very different about the school responder model than lots of other, quote-unquote initiatives that you hear about is that it has key components, and those key components are operationalized differently from community to community, depending on what existing resources they have. So you saw on that first slide all these different places across the United States that have worked on building and implementing school responder models. That was done in all of those places with very little new resources. And while people in the first instance are sometimes frustrated by that and really want, a big new grant, start a new program, the school responder model is different, and we think, because it's different, more sustainable. So it is really these key components that folks operationalize within their existing resources so that once you've planned it and built it, it just becomes a new way of doing business that will endure, and there's no particular grant that's going to fall away and make the work end. So just quickly, the key components you see on the slide, first is building a cross-systems collaborative team. And I can't emphasize enough how important this is. As we've worked with these schools in some radically different kinds of places, they all seem to have in common this feeling like they function as little islands inside their communities. And they are very often trying to problem solve mental health issues for their students with just the people who work inside that school, when they might be sitting inside a community that has some pretty robust mental health services for young people. That's not always the case, I know, but in some places it is the case. And so getting people from the school, the local mental health service system, and law enforcement to sit around a table and think through how can we create new pathways for our students. So just as Ron talked about in the first presentation of this panel, so that the response is not just remove them and find some other place for them to get their needs met, how can we create a new pathway? Because for kids, we know that very often means entry into the juvenile justice system. And you see that the second key component is family and youth engagement. So family and youth also have to be part of this cross-systems collaborative team. Really critical here because, you know, having conversations with family members about kids who are having trouble in school and sometimes having conversations about mental health needs of their kids are both very delicate things and need to be done right and need to be planned with family voice at the table and involved from the beginning so that you create a process that families actually feel welcome in and are likely to use. And then you get to the implementation of the behavioral health response. So this is really what most people would think is the school responder model. And this is about creating a structure to have students screened for any kind of mental health need. If they flag on that screening, to then connect them in a very intentional and structured way to a clinical resource that can do a full assessment. And based on that clinical assessment, get that young person into the community-based services that will meet the needs that they have. And as I said, and I'm going to give you a couple of examples, people operationalize that differently depending on what they have in their community. And then the last key component is creating formal structures. So we've worked in lots of places where they have had a fantastic school social worker and maybe a really wonderful therapist who works at a community-based provider. And so they feel like, well, our students are fine because we call this great social worker who works in our school, she calls her friend who works at the community-based provider, and our students get connected to services. The problem with that, of course, is that people change seats, right? And so the school social worker might not be there next year. The treatment provider might get promoted or move to a different provider who doesn't take the insurance that your kids have. And we have found, especially in struggling schools, the turnover is just tremendous at the personnel level. So creating these pathways in formal ways so that there is formal training, there are formal policies and procedures, there are MOUs between the school and the provider and law enforcement is really the best way to operationalize an SRM so that it lasts and endures even when maybe your champion retires. Next slide, Holly. So what does this look like? Well, in the places where we've worked, it can look really, really different, as I said, depending on local resources. The most kind of pure crisis intervention model that you'll find in the school responder model is in Connecticut. So Connecticut was one of the original sites for the school responder model, and they created what is called the School-Based Diversion Initiative. And that involves a bunch of training for people who are working at the school, and that means not just teachers, but anybody, any adult who is in that school setting. They also have the luxury in Connecticut of having a very robust mobile crisis service for children. So in Connecticut, if you dial 211, you can access a mobile crisis service for children that has a maximum 45-minute response time no matter where you are in the state. That is a luxury that we don't find most other states have, but they have it there and they use it for their school responder model. So folks in the school are trained to start thinking like, you know, this young person is acting out or this young person is having a crisis. Perhaps the people who could best help in this situation are mobile crisis. And so they've changed who they're calling. They aren't necessarily calling the police now. They're calling mobile crisis, or maybe they're calling them both. But they call crisis, and crisis does the screening assessment in connection to mental health services. And they can stay with a kid and family for a little bit of time to make sure that connection happens. In Summit County, Ohio, they have a very different structure for their school responder model. So their SRM is housed at a family resource center that is at their juvenile court. But please don't understand me to mean that that means they have an open court case, because they don't. So The school refers to the case manager who works at the Family Resource Center, and the case manager reaches out, connects with the student and their family, and does the screening and connection to community-based resources. And that is all outside of any kind of formal petition or court process. Next slide. We also did this work with folks in Schenectady, New York, and they made an interesting choice in Schenectady. They decided that they wanted to actually work with students who were getting into big trouble in their schools. Most places we've worked start by working with students who are getting in trouble in school, but usually it's the low-level stuff that people want to work on first because that's usually easier to kind of sell to people. But in Schenectady, they went straight for their students who are at risk of long-term suspension. So they've done something serious enough that they could get suspended for quite a long time. And they created a diversion process that runs in tandem with the suspension process and shortens the suspension process for students. That includes a screening done by a social worker, a whole team, an emergency response team, who then develops a case plan, and they actually have implemented a lot of school-based therapeutic options for their students, including a very robust use of restorative practices and a real trauma-informed approach inside their school system. So that's a different way that an SRM has been operationalized. And then finally, 4 of the high schools we're working in right now in Oakland County, Michigan, are working to, they've just launched, and they are screening students, and then they created their biggest provider there is called Easter Seals. And there was a lot of confusion about what would happen with students once you made a referral for them. So Easter Seals created a point person for each of these schools so that the schools have a person they can call about their students, which has really helped kind of clarify the pathways for students and helped better connect them to services. Next slide. So a little bit about the results. Here's some data from Schenectady, and this is just the first 13 weeks of the last 2 school years and this school year. So it's a year-to-year comparison of just part of the year. And I think there are a couple of important things to note in the data you're seeing on this slide. One is you'll notice that the totals are going down. So in the first 13 weeks, they had the year before they implemented, they had, their first year of implementation, they had 70 students who were referred for superintendent hearings for long-term suspensions. And you'll see that the second year of implementation, it went down to 57, and this year, in their third year, it went down to 52. And that reflects the fact that they are having fewer serious incidents at their school. And they do credit this diversion program for a lot of that change in numbers that they're seeing there. You'll also see how the red and the yellow, the balance between those have shifted. So in the first year, all of this is something that students and their families can choose. You can choose diversion. You're not mandated to diversion in this process. If you don't want to do it, you go to your traditional superintendent's hearing and you just follow that traditional pathway. And you're probably out of school for quite a long time. And the first year, you see, a lot of people said, yeah, I'd rather take the superintendent's hearing. But as they implemented this structure and they had some success, word kind of got out that actually this diversion pathway can be really good and really successful for kids in Schenectady. And you see that far more people are accepting the diversion pathway now as they're further into implementation. Next slide. And this just puts together a couple of data points from some of the other places. So Connecticut, I told you SBDI in Connecticut is really kind of the most robust school responder model we have right now. And they have a lot of data there. And they have found that in the first year of implementation of SBDI, court referrals from the school drop on average 45%. And what I didn't put on the slide but know is that their referrals to mental health for those students went up, I think it's 98%, almost 100%. So they're seeing a big shift in those schools from using the court system to respond to students to using the community-based mental health system to respond to students. And just very quickly, in Nevada, that was a very interesting site for us because it was incredibly rural. So this was in Lyon County, Nevada, which is a very, very rural place where they don't have a lot of services at all for their kids. And they had been only accessing services for their students in need through probation before they started their school responder model work. And in just the first year after implementing their school responder model, they saw a 15% reduction in referrals to probation in that community, which they really credit for having this new pathway, which is really what we think of it as. It's a new pathway. It's not a school justice pathway. It's a pathway for students to get the kind of treatment, services, and support that they need. Holly, can you flip to the last slide? So here are just some resources for you. There are bunches of them on the web, especially if you go to that SRM website, which is the second link down on that slide. Once you get in there, a lot of resources are embedded, and they are practical resources that localities used and allowed us to put up on the website in developing their SRMs. So we hope that if it's something you're interested in, you can find some resources and tools there to help you get started. Thanks.
All right, thanks, Jackie. So for our final presentation, we have Ruby Kozelbosch of the Bureau of Justice Assistance. Excuse me.
Good afternoon, everyone, or good morning, depending on where in the country you're joining us from. I'm happy to be able to share with you some information about federal resources that can support crisis response and early diversion. Just a reminder about the funding resource that my colleague Maria Fryer mentioned earlier. BJA is going to be releasing all solicitations, I would imagine, within the first quarter of 2019, so please be on the lookout for the Justice and Mental Health Collaboration Program. And some of the great work that you heard on the juvenile side, those are also eligible and allowable uses of Justice and Mental Health Collaboration Program funds, can support both adult and juvenile diversion-related activities. If we could advance to the next slide, I'm going to spend the bulk of my 10 minutes talking to you about some new resources that BJA and its partners have put out to support counties that are engaged in the Stepping Up initiative. I'm also going to tell you about a training and technical assistance resource center that can support law enforcement responses called Serving Safely. And then I'll end with a new resource that we'll bring online in 2019 that provides a framework for police and mental health collaboration that Maria also spent some time talking about. The Stepping Up initiative is one of the most exciting initiatives that I've been able to be a part of in my tenure with the Bureau of Justice Assistance. And this was really a collaboration between the Council of State Governments Justice Center and the National Association of Counties. BJA is a funder of this, as well as the American Psychiatric Association Foundation, and it has really strong support from our federal partners at SAMHSA, the National Institute of Corrections, and also other organizations like NAMI and the National Sheriff's Association. The point of Stepping Up is for counties to pass resolutions and to build consensus to do the hard work of reducing the prevalence and the number of people within the nation's jails who have serious mental illness. The slide said 450. I checked this morning. We're actually up to a little bit over 460 counties have now passed resolutions. These counties are within 43 states, and actually over 40% of the country's population now lives in a Stepping Up county. We can just advance the slide. We came to this wasn't happenstance on how we came to realize that this was a good way to go, how to invest dollars, how to begin work with counties, and how to guide their efforts. BJA had supported, through the Justice and Mental Health Collaboration Program, some really deep dives into the data, policies, and practices of in between 5 and 10 jails around the country, to take a look at who was in those jails, and first understood that the prevalence rates are astronomical. So if 4% of the general population has a serious mental illness, in the average jail it's about 17%, or over 4 times the rate of the general population. Why, and what can we do about it? The other thing that we realize is that people with serious mental illnesses are staying for longer at every step of the way. So whether you're in the phase of a jail stay that's pretrial, or for the sentenced population, we also realize that a lot of times we're making people worse. So if they were engaged in community mental health services on the way in, we didn't always make sure that we reconnected or used that kind of golden opportunity while folks were in the jail to provide a new connection to meaningful services in the community. And then fourth, I think what a lot of those counties, why they come to this is that they're sick of seeing the revolving door for individuals that desperately need to be connected to services, but they keep getting arrested and booked into the jail, and so it happens again. So what I love about Stepping Up is that it really focuses counties on these 4 goals. So we want to reduce the number and the prevalence of people that are booked into the jail. We want to shorten length of stay. We want to increase those connections when people are reintegrating communities, and we want to reduce recidivism rates. In order to do number 1, it necessitates universal screening for serious mental illness and a follow-up with an assessment if that person is screening and looking like there is the presence of mental illness. We can advance to the next slide. One of the major documents that came out first about Stepping Up was these 6 questions that county leaders need to ask. Is our leadership committed, and what does that look like? Do we conduct timely screening and assessments? At the time this came out, we were hard-pressed to name a county in the country that was actually doing universal screening of everyone booked into the jail. Do we have baseline data? Are we conducting a comprehensive process analysis and inventory of our services? Sequential intercept mapping is a great way that counties can do that, number 4. 5, have we prioritized our policies, our practices, and our funding improvements so that we can impact those 4 outcome measures? And then are we tracking our progress? Is what we're doing yielding the results that we set out to achieve? On the next slide, we haven't stopped in developing resources, and so briefly I'm going to tell you about 3 relatively new ones and ones that we continue to develop around Stepping Up. One is the Project Coordinator's Handbook. This came out. Usually there's one poor soul that gets tasked with the coordinator role, and that's usually not their only job, and that's the taskmaster and the boundary spanner, the data collection geek, the subject expert, you name it. Someone usually ends up with that position, and so we felt like having a handbook to arm that individual with would be a good idea. Also this summer, we launched an online county self-assessment, and then we continue building upon a series of briefs that bring people towards the goals and break down each component of Stepping Up. On the next slide, just a little bit of a deeper dive into that Project Coordinator's Handbook. So for that person that is sitting in their county, in those 463 counties that are Stepping Up counties, this really takes them through and helps them figure out, who do I need at the table? What agencies do I need represented to make this change happen? And how do I get them at the table? What data am I going to need, and what do data sharing agreements look like? How do we compile all this data and report it back in a meaningful way instead of scattershotting folks that we convene and are spending their precious time to work with us on initiative? How do we feed them information that's actionable? So that's what the Project Coordinator Handbook does. The Stepping Up self-assessment tool, this is an online tool that counties can do together. You can save your progress. It basically asks you questions that tracks with those 6 key questions to get at Stepping Up goals. You can save progress along the way. You can print it out. You can figure out, where have we not done anything yet? What have we partially implemented? What have we fully implemented? And what I like about this is I think it really focuses teams so they know, what do we need to be working on next? What's the next piece of information that we need? What are we going to tackle next? And it helps you organize your thoughts and your efforts and figure out where, as a team, you should be focusing. Again, this is available online for any county that wants to create a login and begin using it. And then on the next slide, there's a series of briefs. One of them has been released, and its focus is on screening and assessment. There's another one that will come out in early 2019, and we plan to continue releasing them. They're kind of quick snapshots that are great to hand out to Stepping Up team members to understand what are we trying to accomplish and what are kind of key takeaways about how we get there. So really would encourage folks to take a look at stepuptogether.org. That's where all of these resources can be found. Another resource that the Bureau of Justice Assistance has supported, in 2017, Congress appropriated a new funding stream of $2.5 million, and TASC-BJA was standing up a National Training and Technical Assistance Center to improve law enforcement responses to people with mental illness as well as intellectual and developmental disabilities. Serving Safely is the name of that center. It is operated by the Vera Institute of Justice, and I am happy to say that they are available a phone call away or an email away to request training or technical assistance. Every week, Marie and I get a digest of the technical assistance requests that have come in. We have team meetings to determine how they're going to be responded to and how we can most effectively provide resources, and whether that need be a deep or a shallow dive. Maybe it's just information or connection to a peer law enforcement agency that's doing the good work that they're trying to do. So Serving Safely is another resource. And my last slide is to preview something that will be coming out in 2017. We have been deep in this work for the last 12 to 15 years of really understanding what are the key components of a successful police mental health collaboration. Ron Bruno talked earlier about crisis intervention teams, CIT International, and the amazing work and the thousands of law enforcement agencies around the country that have started crisis intervention team efforts and baked them into standard operating procedures for law enforcement agencies around the country, and what those collaborations should look like. We've got 18,000 law enforcement agencies in this country. So we have more, I would argue, still to date than not, more who do not have a collaboration in place than do. And so we find that we continue to build out resources to help describe what effective collaboration looks like, whether a law enforcement agency and their partner mental health authority are choosing to implement the crisis intervention team model or a co-responder model or a case management model, or what works for their communities. The police mental health collaboration framework, just like Stepping Up, really focuses counties on 4 key measures that you should be looking to impact. The framework is going to really focus those collaborations on 4 key measures that you should be looking to impact. And they are increased connections to resources, fewer arrests, reduced repeat encounters with the same individuals with serious mental illness, and reduced use of force during those encounters. So please be on the lookout for that in 2019. We'll make sure it's available everywhere at bja.gov, the Police Mental Health Collaboration Toolkit that's online that Maria mentioned earlier, and through Serving Safely. We don't want there to be any one wrong door. So thank you. That's all I have for you this afternoon.
And at this time, we're going to take a brief break in advance of our next panel on screening for mental illness and substance use disorders.
Good afternoon. My name is Lisa Callahan. I work with the SAMHSA's Gain Center and Policy Research Associates. The next panel is going to be on screening for mental illness and substance use disorders in jails and detention centers. As we heard from a number of the earlier speakers, there often are times when people with mental illness and other behavioral health disorders are transported to the jails and to detention centers. And at that point in time, we've also heard it's really important for there to be universal screening for behavioral health disorders when people are in jail or detention. We're going to hear from 4 speakers today. The first speaker is Paul Leffenwell. He's a clinician and forensic services team lead with the Burt Nash Community Mental Health Center in Douglas County, Kansas. He has a number of years of experience working in both county and state corrections, and he'll be our first speaker. The second speaker is Dr. Merrill Rotter. Dr. Rotter is a forensic psychiatrist in New York, where he advises the commissioner of the Office of Mental Health for the state of New York, and is also on the faculty at the Einstein College of Medicine. He's the director of the Law and Psychiatry program and has worked for years in the crossroads between criminal justice and behavioral health. The third speaker is Dr. Keith Cruz. Dr. Cruz is a clinical psychologist who specializes in youth and adolescents. He is on the faculty at Fordham University in both the Department of Psychology and the law school. Dr. Cruz, his clinical practice includes providing direct care assessment and treatment services with justice-involved youth, and he provides a considerable amount of training and technical assistance to jurisdictions to improve their services and responses to justice-involved youth. Finally, John Berg, who is the program lead for a number of SAMHSA's drug court and reentry grant programs, will be the speaker to talk about federal resources. John is the senior public health advisor in the CSAT for SAMHSA, and he has over 17 years of experience in state corrections and has served in many capacities as a clinician in corrections. So I will turn this over to Paul Leftenwell from Douglas County, Kansas.
Good afternoon. In a kind of an update I got, I was asked to speak more about some of the kind of frontline applications in the screening and assessment process that we use here in Douglas County, maybe with an eye towards providing some information about some maybe usable options for people working in facilities elsewhere. And so just to briefly summarize, I work at our facilities in Lawrence, Kansas, which is in Douglas, Kansas, in the eastern part of the state. And it's a 186-bed facility. We serve 5 different law enforcement agencies over 4 cities. And we have got a capacity of 186 beds, and we are typically over capacity by 30 to 50, which means we're what we call farming people out to other facilities we have contracts with to take our overflow. What we in the forensic services team here do is we work for the most part a normal kind of 8 to 5 schedule, and what that means is we're not able to always see face-to-face every inmate who's booked into the facilities. Well, our screening process starts with the booking officers who now have the brief jail mental health screen included in the booking process. And so those inmates who respond positively to some of the questions with the mental health screen there will be notified of that. And then we make plans kind of during regular working hours to follow up with those inmates who get booked into the facility. Now, we have an advantage in that I work for the Community Mental Health Center, so I have access to our electronic medical record. And so myself and the other clinicians here can go through our record, match it with all the bookings, and see who is in fact a mental health client, who's been a past client, who's had crisis screenings at the hospital, as well as co-responder contact. So we do have a pretty comprehensive database to go through each day with everyone who gets booked into the jail. So we have pretty good information. It's people who might come from out of county or who for whatever reason have never had contact with the mental health system that we have no information on. But in addition to that brief general mental health screen, those inmates who are identified by us, we do a more comprehensive mental health evaluation. Like I said, we do a records review. We also perform the SBIRT, the brief trauma questionnaire, and the LSIR screening version. If a person in jail is in the facility long enough to where they might qualify for reentry services, they'll then get a full LSIR prior to them participating in that process. But for us, what that means is we have a pretty good list of people to see each day. For those folks who might be either too intoxicated or for whatever reason don't particularly want to talk with us, we'll let that be for the time being. We of course will do any sort of crisis assessment as needed, and if necessary, we have a protocol for managing mental health crisis here in the jail, and we'll implement that kind of an as needed basis. But we are trying to catch people after their arrests, prior to their first appearance. Sometimes from a practical standpoint that doesn't always work, and we're catching them after their first appearance. Maybe they're waiting on an attorney to represent them at their next court appearance, or waiting to make bond, or something like that. But we're trying to catch up with that person to make sure that if in fact they are in need of mental health services or substance abuse or trauma services, including maybe domestic violence, shelter care, or something of that nature, we connect up with them, provide them with that information, provide them with contact information for us at the jail. And then what happens is, if they're agreeable to all this, as they transition out of the facility, we can act as actual kind of short-term gap case management services and actually go out into the community with that person and help physically get them connected with those services. Typically, this will almost always involve intakes at the mental health center. We have several agencies that can provide some mental health services, but the community mental health center is the primary. We have a substance abuse recovery, of course, but then we will kind of physically assist them with doing that. Sometimes that can be a difficult process, especially with our homeless population. We try to make staying in touch with us as easy as possible. We have gone to the homeless shelter. We have gone to the public library, for example, where we might need to locate people and to continue to help facilitate that process. I mean, I've worked with people over weeks, getting them to and from court appearances to prevent their rearrest for missing court. But that's kind of the ground level process that we use. You can go ahead and advance the slide. To kind of keep intervene with people, assess, refer as needed, and hopefully get them connected. And then once we've done that process, we are in touch with the mental health center. So if they do have case managers, we're going to be contacting them to make sure their case managers know about their court dates, assist with transportation as needed, basically kind of take care of the ground case management work until they get really more established with other care providers in the community to help provide those services. So our focus is really on assessing them when they come into the facility, referring them as needed, as needed when they get out, and then doing what we can to make sure they kind of meet their obligations in terms of appearing in court or appointments with probation or something like that, to kind of keep them out. Typically, once people have engaged in services, we are seeing a reduction in bookings for seriously mentally ill folks, so that's been pretty good. Go ahead and advance the slide. So the brief jail mental health screen, we get pretty good cooperation from people getting booked in, answering those questions. For those who choose not to answer the questions, like I said, we are going over our records to kind of determine if this is a person who's had contact with the mental health system before. Like I said, we're lucky to have access to our electronic medical record system at the mental health center, which will have crisis screeners at our local hospital. It'll have their information in there, contacts by our co-responder in the community who responds with the police department. So we do have a pretty good database of information to go by. And occasionally people will say no to everything. Their symptoms are perhaps too intense, maybe some paranoia or something, and they won't want to answer the questions. And in the case even if the officers are not necessarily familiar with the person, if he's presenting with something unusual, there's some reason to suspect they may need mental health follow-up, we take referrals from the officers and booking, nursing staff who may follow up with people. Our nurses have their own mental health screen, they do. And then anything the officers might observe in the pod, as well as requests from the judge, the prosecutor, or the defense attorney at their first appearance, if they've got an attorney at that time. So we will take any request from anyone to follow up with someone here in the jail. Anytime we find out there's someone who might be in need of our services, we try to get with that person as quickly as possible to do a screening and further assessment as needed. Go ahead and advance the slide. So what we're looking at doing is our most severe cases will be referred to a newly established behavioral health court. And we also have a program where the district attorney started it's kind of a drug court right now. It's for female offenders. And then we're looking to add substance abuse treatment here in the jail. We don't have that up and running yet, but hopefully that will start here in a couple of months. So we'll be able to address some of those needs from here if the person doesn't get released to go to treatment, for example. The advantage to getting it started here in jail is so we don't end up with people sitting here waiting on treatment beds when they could be actively engaged in some treatment. And then we started adding some of the screening data from the bookings to our criminal justice data system we have here. We have mental health alerts already on some of the inmates who are booked in. It's one way we get alerted to their presence here in the facility and the need for us to follow up with them. And then, go ahead and advance the slide, please. But basically, we look at trying to catch up with people who may have also been released prior to us seeing them. We have a lot of people who don't spend very long here. I believe it's 25% of all of our bookings are in the jail for 3 hours or less. So that means anybody who appears after the staff has gone home and hasn't been in need of after-hours crisis screenings, they're going to be out and gone by the time we all get into work the next day. So we then review the booking sheets for the presence of any indicators, and we will try to contact that person out in the community if we have a means of getting a hold of them to just see if there was any follow-up that might be needed. We also will alert any people who are active clients of the mental health center. We will alert their case managers that they've been incarcerated, to let them know that they may need some additional follow-up outside of the regularly scheduled appointments. And then from there, we, like I said, we'll do any short-term case management that's necessary. If caseworkers will go out into the community and meet with people there, for example, to schedule more comprehensive substance abuse evaluations, just help people get to appointments, kind of the basic case management work. All four of us clinicians here, I'm the clinically licensed supervisor, and we have 4 master's level licensed, or 3 other master's level licensed social workers, and typically some students who also assist with us in that process. I think that's covered all the slides.
Okay, thank you, Paul, for giving us an overview of the work that you're doing in Douglas County, Kansas. Next, we're going to hear from Dr. Merrill Rotter, who will continue the discussion about screening and assessment of adults with mental illness and substance use disorders in adult jails.
Okay, good afternoon, everybody. Let me take me to the next slide, please. So this is obviously something that you've seen multiple times in the past, including earlier today. Sequential intercept model. What I want to suggest here, and this is when thinking about the jail role here, is that conceptually we want to see the jail as part of a continuum of care, if you will, when it becomes required or necessary, such that we're thinking beyond the day of care, but rather that the person came from somewhere, is going back to somewhere, and what are the opportunities once they're in the jail system to do both meet the immediate needs, but think conceptually beyond, and what else we can think about for longer-term needs and perhaps discharge planning. So what I'll be talking about over the next several minutes, right, is kind of a conceptual approach to thinking about in an intentional and mindful fashion what our role is, why we are screening and assessing our clients who end up in jail while they're there. I'll give some examples of some of the tools, but beyond the fact that we only have 12 minutes here, and that there are actually, SAMHSA has a very comprehensive monograph on screening and assessment of people with co-occurring disorders in the justice system that came out in 2016 that's worth looking at and has dozens of tools and over a course of hundreds of pages, the pros and cons. I'll give a couple of examples, but as we'll see at the end when I circle back to conceptual ideas, what are some of the considerations that are worth thinking about that will drive what tools may be appropriate for your particular situation? And there are several variables that I think are worth being intentional about. Next slide. Right, so the two basic, if you will, parts that we're talking about here within the sequential intercept model really are 2 roles and 2 goals here, right? So the intercept 2 there, that is at first initial detention, meaning that they're in jail right now, and we can think about our role in terms of the cross-sectional needs someone might have, meet the immediate needs, and how we identify and screen for those. And then, of course, once they're in jail and maybe heading back to the community, or will be certainly, what are the opportunities for more comprehensive reentry planning? And my sort of, if you will, conceptual argument to drive up the point home is that we can think about what the opportunities for one or both are, both depending on our system, our staffing, et cetera, as we'll look at in a couple of minutes. But again, being intentional about what our role is vis-a-vis the client who is in jail and what our goal is important if we're going to be getting to look at what we want to assess for, identify, screen for, and then therefore what tools that we might use. But let's pick those apart for a couple of minutes. Next slide, please. Next slide. Thank you. So in terms of the cross-sectional needs, if you will, here are some examples that one might think about, one of which you just heard some detail about the sequential, I lost my slide here, sorry. Pardon me. Oh, here we go. The brief jail mental health screen. So you heard the details from Paul just now about that, essentially. Clearly, it's an 8-item scale in which you're looking for 6 are current symptoms, 2 are some historical factors, 2 or more positive suggest a lifetime diagnosis of a mental illness. It's the advantages of that, the pros of that are that it can be done by very non-clinical staff, including corrections officers, as you just heard. It does not, however, screen for anxiety, does not screen for personality disorder. As Paul mentioned, it's not diagnostic specific, just the presence of some kind of mental illness. So that it's got a positive if we want to make sure we don't miss people, but it doesn't necessarily tell us a lot about what to do for that individual. The pros, the DAST and the MAST, which were noted earlier as well. The DAST being the drug assessment screening test, and the MAST being the Michigan alcohol screening test, really are 2 short tools to pick up the presence of a history of drug use or alcohol use, or both. Again, the pros are it's a quick thing that can be done by almost anybody and will help identify somebody whose risk for destabilization or behavioral issues may include substance use, but doesn't necessarily tell us a quantity or frequency, doesn't necessarily tell us which drugs, and even more relevantly for the cross-sectional, it doesn't in and of itself tell us, is this person potentially intoxicated? Do they potentially need more detox services or something for medical reasons in the jail setting, if you will? And then doesn't tease out for us whether if there are behavioral health symptoms, are they due to the substance use or not? We just know that it's present. Again, these are identifying tools as opposed to really deeper dive assessment tools. And then finally, clearly, just to note that many, if not all jails, are screening in some way, shape, or form for suicidality. And the CSSRS, or the Columbia Suicide Severity Rating Scale, is one of many, but it really is becoming, to my mind, the state of the art, both largely outside of the jail or prison setting, but it's being increasingly used in that setting as well to identify people who have had a history of suicide and even a recent history of suicide or suicidal ideation, at least within the past 6 months. That would suggest that perhaps a deeper dive for current ideation, et cetera, needs to be considered. Again, so I think that I argue the 3 things we want to be really concerned about from a cross-sectional perspective, is indeed, is there a mental illness, maybe substance use, and suicidality, of course, but the critical focus for that, the role we have there is identifying those things to help the client get as safely through the day as possible to maximize their cross-sectional stability and their health. But again, these are just identification tools when we have to ask more substantive questions, non-structured questions to get at what the diagnosis might be and indeed what medications might be appropriate, if that's appropriate to manage what may be an acute presentation of mental illness and or substance use or substance withdrawal, essentially. But again, the important thing here from my perspective conceptually is we can think about these as what tools do I need to get through the day to get the client as safe as possible and as stable as possible through the day. Next slide, please. We can then reentry planning, again, as a separate role and a separate goal, is something that can also be done within the jail or prison setting, but the jail setting, of course, we're talking about today. The APIC model is one model for thinking about how do you plan for reentry. With reference to what we're talking about this afternoon or this morning, we're talking about really the I and the C, the identification of the planning for the treatment services, and then within that, then the plan then helps us identify the programs and coordinate the transition plan. But really, what do you need to do to assess for that plan? And that's potentially slightly different. Still behavioral health, but when we talk about like a psychosocial, it will add certainly the social aspect to that. So, for example, next slide, the types of instruments that might be relevant here beyond the brief jail mental health screening would be the modified mini screen or the mini international neuropsychiatric interview, the mini, which is really more of a diagnostic interview for things like depression, schizophrenia, etc. Help identify what exactly the disorder is or disorders are that may need intervention. It's been tested largely in non-offender populations, though it's been applied to offender populations. It doesn't pick up the possibilities of malingering, which is certainly an issue within an offender population as well. But it does identify mood, does look at anxiety and psychosis, and again, helps drive diagnosis, which is better for treatment planning. Substance use, again, the DAST and the MAST, but what I don't have here is something like the Addiction Severity Index or the ASI. That's a structured tool that then begins to drill down to what the actual substances are, how frequent, how recent, again, to get a sense of how much of the reentry planning should include substance treatment, essentially. Trauma is a huge issue, as we know, of course, in the offender population, practically universal. The PCL-5, which is the post-traumatic stress disorder checklist for DSM-5, is an item scale looking specifically at the presence of post-traumatic stress disorder symptoms. The challenge there, of course, is that while the presence of or history of trauma may be almost universal in an offender population, how it presents isn't always within a PTSD, if you will, framework. People become depressed, have personality disorders, substance use, etc. So it's an important kind of area to be thinking about. The PCL-5 is one of the most frequently used examples, but doesn't necessarily capture the array of possible trauma sequelae or consequences. Frankly, it also doesn't ask about the trauma itself. It's just about the symptoms. So one has to then really screen earlier for a history of any traumatic exposure. The PCL-5 doesn't do that. And then finally, and this was mentioned by Paul as well, if we're thinking about reentry planning, it really pushes beyond their immediate needs into what are the risks of recidivism, which often are related not only to the serious mental illness the person may have, but in fact also other significant criminogenic or social factors that will lead to a greater history or risk of rearrest. And so something like the level of symptom inventory or the case management version of that is a way of picking up all the needs associated with recidivism, which is a concern for our clients. And then certainly risk of violence, to the extent that violence is present, can also be looked at in a structured fashion. The HCR20 is a training in and of itself, but is worth noting that there are structured approaches to the risk of recidivism and structured approaches to the risk of violence, with the notion of risk management and risk planning around that for when the individual returns to the community. Again, these are examples of instruments that allow us to think about where the person's going and not just getting through the day in jail. Next slide. And finally, having laid out a number of these tools, and it's just worth noting that which tools you choose, not just from the menu that I shared in the last few minutes, but in fact what you may choose if you choose to go to look at the SAMHSA monograph on screening and assessment tools, for example, we'll have to take into account and should take into account in a, again, intentional fashion all the considerations relevant to your specific jail setting. So these are several. The volume, how many people are coming through any given day. So how much you can do, how deep a dive you can do, how much you can think beyond cross-sectional will partly depend on how many people are coming through that you need to see, essentially. So you can triage your efforts appropriately. I'm going to skip the next one for a moment. What kind of staffing you have within your jail system, how dependent you are on COs, frankly, to do parts of this screening, non-clinical staff, if you will. Do Do you have higher level clinical staff who can do deeper dives in terms of clinician interviews? The clinician version of the mini, the neuropsychiatric interview is certainly much more specific than the general version, the modified version of the mini. Helps you get better diagnoses, better history, and better treatment planning. But you may not have that available. So depending on, indeed, the level of staffing will also drive which tool will be most appropriate for your particular setting. What services you have will also partly dictate that, essentially. Do you have access to detox? Should you be screening for people who may be withdrawing so you can actually get them to the appropriate services? So that's going to be a piece of it. None of these tools necessarily to help you with placement within your facility, partly because the tools aren't specific to your facility, and whether you have segregated units for people who are at risk for decompensating or not being able to care for themselves, or at risk in general population, whether you have segregated units for people who are at higher risk for violence, where the DOC drives a lot of those decisions rather than clinical decisions. All of that will vary from place to place, and indeed then will also add to what you need to be thinking about at your screening level when someone comes into the jail system. Certainly differentiating people, SUD from SMI, is an important challenge in thinking about treatment planning for our patients. It typically isn't something that we think about necessarily in the jail itself, but certainly in reentry planning, getting a sense of how much of, if there are, often there are both obviously present, but what's the greatest contributor and how to prioritize services is an important issue. And then finally, back to the original concept here, that there are at least two roles and goals for us in the jail screening and assessment process. That is the cross-sectional getting through the day, if you will, the reentry planning, the seeing jail as a way station, if you will, and someone's going back to the community and thinking about where they're going to go. Those are separable, and separable roles and separable goals and separable ways of approaching. However, depending on the length of stay within your jail, they may not be separable temporally. If most of your clients come in and go out in 24 to 48 hours, then you can't necessarily punt on the reentry planning, even if you wanted to. So that it's worth noting that sometimes you can't really wait on discharge planning, and maybe what indeed the old adage from hospitalization, that discharge planning starts on the day of admission, perhaps that also would apply in your case if in your jail people move through that quickly. So that said, what I tried to present here in summary, therefore, is just an approach to thinking intentionally about what we're trying to accomplish, that there are pros and cons to the various tools that are available to you, and that understanding those pros and cons in the specific context of the considerations of your particular jail setting is really the best approach, I believe, to picking the right tools for your population and for your staff. Thank you.
Thank you, Merrill. Next, we're going to be moving on to hear from Dr. Keith Cruz, who will talk about screening and assessment in detention with juvenile offenders.
Thank you so much, Lisa. And if you could go ahead and move to the next slide. Basically, in the sort of brief amount of time that I have here today, is you're going to be hearing, at least from me, some kind of universal concepts as it applies to screening and assessment. That you've already heard from other presenters. I'll try to help capture some information that is a little bit more specific to a juvenile justice population. And I'd like to start with sort of a top-down view here and a little bit of history at this point. In 2003, there was a blue ribbon panel of mental health professionals, juvenile justice professionals, policymakers, et cetera, that convened and published what was referred to as the Consensus Conference paper on juvenile justice screening and assessment. It outlined a series of recommendations in 2003, which were pretty important for the field in terms of juvenile justice at that time. And some of them are listed here. Of course, one of the first recommendations was to provide an evidence-based emergent risk screen within the first 24 hours of a youth's arrival at a juvenile justice facility. And of course, with emergent risk screening being primarily at that time the focus on suicide risk, active suicide ideation, and the possibility of thinking about picking up on potential harm to others as well. And the second recommendation was then to provide an evidence-based mental health screen and or assessment for all youth as early as possible to determine their need for mental health services. And so what we see is that mental health screens were recommended as serving two roles. One, to identify emergent risk needs, and then broader mental health needs as well. And then, of course, screening then should lead to the identification of a smaller subset of individuals who are universally screened at the point of intake, and identifying youth who may need a more comprehensive mental health assessment. That should, of course, then look much more like a traditional mental health assessment process, drawing on multiple sources of information, measuring a range of relevant mental health concerns that were either identified by the screen or from other collateral sources of information. Another important recommendation was that this reassessment should occur on a regular basis, and that regular staff training should occur on your overall screening and assessment processes. Next slide, please. And of course, what we mean by an evidence-based in terms of these recommendations is a screening tool that is, of course, standardized, meaning it's a brief process, likely to be used, can be used by non-clinical staff, that it's relevant, meaning that it is essentially validated and has been tested that there is research supporting the use of the tool in a juvenile justice sample. And the outputs of that screen then should be to, of course, identify youth with conditions that would be suggestive of a mental health disorder, suicide risk, potential risk of harm to one another. And so the outputs of a screen are essentially it should lead to some decisions or structured rules that allow staff to essentially screen in and screen out individuals who are suggestive of mental health difficulties in a reliable and valid manner based upon research findings. With the important caveat and to remember is that the screening is not a diagnostic process, nor does it replace a comprehensive assessment. Next slide. And so what we know is that, of course, good juvenile justice screening practices are those that are based on a tool that's relevant, designed for use with the population, in this case, justice-involved youth. Has research supporting the tool's reliability and validity for the various scores or decision rules that have been created for the screen, and that it can be administered and scored based on a standardized approach to support uniformity in the system response. Screens are typically conducted at intake, but what we know a unique thing in terms of juveniles is how fast and quickly mental health symptoms can change, particularly in an adolescent population, and how different contexts or environments can impact that. So we also typically think about screening tools as something that is not just done at intake and is filed away, but is something that juvenile justice staff can bring out and reutilize and rescreen youth based on changes in circumstances, changes in settings, et cetera. And the most important thing that I think is to get across, and Meryl has already referenced this, is that screening is more than just selecting a tool. I always refer to screening as a process, and the fact that it needs to be supported by policies that can involve the selection of the tool, and the tool can then drive some aspects of the policies, but every screening policy and practice needs to have some guidance that facilitates how the screening tool is going to be administered, who's going to administer the screening tool, who's going to have access to that information from the results of the screening tool, and policies and practices that facilitate both the communication with other staff and between the juvenile justice professional and the youth or the family who's going through the screening process, and clear policies that involve the protection or confidentiality of those results, essentially who's going to see this information and how it's going to be used. Next slide. And in reference and sort of acknowledgement of this idea of screening in juvenile justice settings being a process, I will point you just to a document that was offered up and developed at the National Center for Mental Health and Juvenile Justice, which outlines mental health screening in juvenile justice settings as involving 10 different steps in 4 phases, sort of reflecting this idea of a process, where the first phase is really setting your framework, figuring out what exactly do we want to accomplish in this screening and assessment process? What are our needs? What are our resources? What do we hope to learn from a screen? And you have to essentially work on setting your framework first before you jump into selecting the screening tool. Oftentimes, in my work with juvenile justice agencies, that's the first thing that they ask. What tool is best to screen for what? And in my consultation back, I redirect them to say, what do you want to learn from the tool? What are your resources? And how will this fit into your overall process? You have to set the framework essentially before you can get to good decisions about identifying the tool that's going to most appropriately meet your needs. Then the third broad phase is essentially developing a plan to implement that screen. That's developing the decision rules. Hopefully that is guided by evidence, research evidence, and then locally developed responses to those empirically identified screening indicators. This often means locally developing sort of a service matrix and guiding staff in terms of what you're going to do in response to each of the flags from a screen. And this will also look at, juvenile justice system developing information sharing policies, and then of course piloting hopefully the screen, and also making sure that you've rigorously trained your staff in the screen as well. But then we're not done there. The final phase is of course data collection, creating a database where you're tracking the results of your screen and evaluating essentially the number of youth that are screened in and screened out. How does that compare to a prior literature? How does that compare to the use of these tools and processes in other systems to make sure that you're actually capturing the youth that you intend to in your screening process? Next slide. And I do a lot of work in the area of trauma. As Meryl was just referencing, trauma is, of course, a very important target, given that between 15 to 25% of youth in the juvenile justice system likely meet that criteria for post-traumatic stress disorder. And this is one example where you need to really think about the setting and the context of what you're going to try to accomplish through your trauma screening process, because not all trauma screening tools are built in the same way. While they may all universally identify or flag youth that might be in need of a further comprehensive trauma assessment, or flag youth who might be needing trauma-specific services, trauma screens are not all built the same. They could be an exposure-only screen, focusing on just past potentially traumatizing events. It could also focus just on those symptoms of post-traumatic stress disorder, or what I refer to as essentially current trauma reactions. Or you could get a screen that would focus more broadly on trauma-related symptoms, things like dissociation, other types of depression and anxiety difficulties. And if you just jump into and say which tool works best without an understanding that there could be different dimensions to a screen, you may be identifying a screen that really doesn't fit your purpose and context from within your juvenile justice agency. And of course, then with any of these, it's that third step there is developing a very, very specific implementation plan in terms of the training of your staff, the development of that policy and procedure, and then developing your quality assurance and data monitoring component as well. Move to the next slide, please. And some of my colleagues who have also written on distinguishing, of course, the differences between screening and assessment, and just following on the trauma example, this is just a visual depiction of some of the characteristics of a good trauma screening process and how it's differentiated from a trauma assessment. And so these are some guiding concepts that are perfectly appropriate for the adult context as well, but we also see them as also being relevant for screening for a particular area, in this case, trauma and juvenile justice. That a good trauma screen should be universal, should be able to be administered to all youth, particularly at system intake, should be cost effective, meaning that it's quick and efficient and doesn't take up a lot of staff time. It should descriptively end with being able to identify youth who may be suggestive of having current trauma difficulties. And ultimately, an output of that should be used to guide who you would want to refer for further secondary screening or some type of further trauma assessment. And of course, it's very, very different from a more comprehensive trauma assessment, which is going to be targeted very specifically around potential traumatic events, current trauma reactions. It's going to be comprehensive in that it's going to draw on multiple pieces of information. Ultimately, a good trauma assessment should be more diagnostically driven. And a good question with that is, does this youth currently meet diagnostic criteria for something like acute stress disorder or post-traumatic stress disorder? Is there the presence of any other co-occurring mental health disorders that sits alongside that trauma diagnosis? This, of course, needs to be done by a trained mental health professional, and is often going to involve a referral for this type of assessment, most likely generated from the non-clinically trained juvenile justice staff at the earlier trauma screening process. And of course, the outcome of a trauma assessment is also very different. It should be used to formulate a good case conceptualization and to inform treatment planning to help to monitor then that treatment progress and help to evaluate and help essentially juvenile justice staff to detect and prevent decompensation or any of the adverse reactions that may be co-occurring alongside the trauma that have relevance to the juvenile justice system. These might include things like anger problems, difficulties in school, difficulties in relationships, aggression, and violence, etc. Next slide. And the most important thing that I just want to pass along in this brief time is that, of course, just as the other presenters have mentioned, we have a host of screening tools for different areas, and they're just represented. A few of them are represented here with links. We have screening broadly for mental health difficulties. The Massachusetts Youth Screening Instrument is one of the most common mental health screen that is utilized in juvenile justice settings. We also have screens obviously specific to trauma. We have what I would refer to as sort of a combined screen that would look at both a combination of mental health and substance abuse risk. We also have substance use specific screens as well, with the CRAFT being a very common example of that. And consistent with what Meryl mentioned is we also have different screening versions to assess for risks and needs. We have a screening version of the Youth Level of Service Case Management Inventory, and also the Youth Assessment and Screening Instrument has a pre-screen component that then would alert and determine who we need to refer to for a more comprehensive risk need assessment. All of these have been utilized not only in terms of juvenile detention centers or long-term juvenile correctional facilities, but given that the most common the common placement of a youth is actually on community supervision and probation, all of these screens are utilized by juvenile probation officers in community contexts as well. And I think you can move to the next slide.
Okay, thank you, Keith. I wanted to also just a couple of takeaways from both Dr. Cruz and Dr. Rotter's presentations is, especially before John Berg speaks about the resources that are available on this topic, how important it is for planning and thoughtful consideration of what your resources are, both in your detention facility or your jail and in your community when you start to think about introducing screening in detention or jail facilities, that it is a really thoughtful, planned activity, not something that is just sort of someone's decision that they want to implement a particular screening tool. So I'd like to introduce John Berg now. He's going to talk about the federal resources that are available around screening and assessment.
Thank you, Lisa. Good afternoon. I'd like to thank you for participating in today's symposium. I appreciate the opportunity to share about a few of SAMHSA's resources. It's very important to screen adults for mental illness and substance use within the criminal justice system. A significant and growing number of people in the justice system have co-occurring disorders, and approximately 17 to 34% have serious mental illness. People with co-occurring disorders present numerous challenges within the justice system. These individuals can exhibit greater impairment in psychosocial skills and are less likely to enter and successfully complete treatment. They're also at a greater risk for criminal recidivism and relapse. The lack of screening for CODs also prevents comprehensive treatment and case planning. It prevents matching justice-involved people to appropriate levels of treatment and supervision, and rapid placement into specialized programs to address CODs. Next slide. The Screening and Assessment of Co-occurring Disorders in the Justice System is a monograph available online through the SAMHSA store. It is intended as a guide for all who are interested in developing and operating effective programs for justice-involved individuals who have mental illness, substance use, and co-occurring disorders. It is the most comprehensive screening and assessment resource to use across the criminal justice system, as it uses a wide range of evidence-based practices for screening and assessment of people in the juvenile or justice system who have co-occurring mental health and substance use disorders. The monograph reviews a range of selected instruments for screening, assessment, and diagnosis for use in justice settings, and provides a critical analysis of advantages, concerns, and practical implementation issues such as cost, availability, and training needs. Although the title of the monograph includes co-occurring disorders as an overall theme, the document is broken down into sections for tools to screen or assess for mental illness, substance use disorder, trauma, treatment, readiness, and suicide. Many of the instruments described in the monograph are available online and free to the public. The monograph has links throughout which allow direct access to the resource. The monograph also includes this chart. Thank you. Includes this chart of recommended screening instruments used to screen for mental disorders, substance use disorders, co-occurring disorders, motivation and readiness, trauma history, and PTSD and suicide risk. Next slide. The monograph also includes this chart of recommended assessment instruments used to assess mental disorders, substance use disorders, and treatment matching, co-occurring disorders, trauma history and PTSD, and suicide risk. Next slide. And here's the link that we provided. A new version for the monograph is currently under review and will be made available through the SAMHSA store when it is complete. Next slide. Just as in the case with adults in the criminal justice system, it's also important to screen children and adolescents within the juvenile justice system. Some children and adolescents have mental illness and serious substance use problems. Almost 21% of children and adolescents in the United States have a diagnosable mental health or addictive disorder that affects their ability to function. 5 to 9% of youth ages 9 to 17 have a serious emotional disturbance that causes substantial impairment in how they function at home, at school, or in the community. Many children and adolescents with mental illness and substance use problems do not receive treatment. An estimated 60% of children and adolescents with mental health problems do not receive mental health services. Furthermore, screening and early detection can help parents and caregivers identify emotional or behavioral challenges and assist in obtaining appropriate services and support before the problems intensify. Next slide, please. Identifying mental health and substance use problems of children and adolescents in a resource is a resource guide for staff providers and clinicians who deal with adolescents. The purpose of the guide is to address the approaches, methods, and strategies used to identify mental health and substance use problems of high-risk youth in settings that serve either a broad spectrum of children and adolescents or a high-risk population. The guide identifies youth as those between birth and 22 years of age. The information in this guide targets specific child-serving settings to help determine the best approach. The 7 settings addressed in this guide are child welfare, early care and education, family, domestic violence, and runaway shelters, juvenile justice, mental health and substance abuse treatment for co-occurring disorders, primary care, and schools and out-of-school programs. Next slide, please. The guide includes this list of resources on screening young children with the links to access the resources. Next slide. The guide also includes a list of resources on assessing and treating young children with the links to access these resources. The next slide provides the link to the guide. Next slide. SAMHSA created a new evidence-based practice resource center to provide communities, clinicians, policymakers, and others in the field with the information and tools they need to incorporate evidence-based practices into their communities or clinical settings. The Resource Center contains scientifically based resources including treatment improvement protocols or TIPS, toolkits, resource guides, clinical practice guidelines, and other science-based resources. Next slide. The Treatment Improvement Protocol, or TIPS as we call them, series provides science-based best practice guidance to the behavioral health field. TIPS reflect careful consideration of all relevant clinical and health service research, demonstrated experience, and implementation requirements. Tip 63 reviews the use of the 3 Food and Drug Administration approved medications used to treat opioid use disorder: methadone, naltrexone, and buprenorphine, and the other strategies and services needed to support recovery for the people with OUD. It is important to link healthcare providers, behavioral health treatment providers, and officials in law enforcement and in corrections to resources that will prevent opioid overdose deaths. SAMHSA Tip 63 is one resource that can assist professionals providing assistance to those in the criminal justice system. Next slide, please. This toolkit offers strategies to healthcare providers, communities, and local governments for developing practices and policies to help prevent opioid-related overdoses and deaths. This is an important resource for those that are working in the criminal justice field with substance use disordered individuals that are at risk of overdose. Next slide. We list the resources that we mentioned, and thank you very much.
We'll take a 5-minute break and prepare for the next panel.
Good afternoon. This is Dan Abreu from the SAMHSA National Gain Center, and I'll be moderating our last panel of the day, Promoting Successful Community Reentry. And it's arguably one of the most important areas of focus of the symposium today. There's a study out of the state of Washington following 30,000 inmates released, and within 2 years, the death rate, mortality rate of that cohort of individuals was 13 times that of the general population within the first 2 weeks of release. That study was later replicated in Rikers Island, and they found similar results. Reentry, good reentry, is actually a matter of life and death. And we know some things about how to do it well. Maybe it's the season of the year, but the analogy I like to use is that good reentry planning is a little bit like putting up Christmas tree lights. There's a lot of needs to consider. There's health needs, there's substance use needs, there's mental health needs, then there's housing and benefits. And if any one of those lights goes out, the whole discharge plan can break down. And we're going to focus today on three main areas: housing, benefits, and the specific needs of veterans. It's important, again, when looking at reentry, that you've got your programs in place immediately upon release. As soon as that the first footstep on the sidewalk. We know that recidivism is highest within the first 90 days, and with the current opioid crisis, again, we want to make sure that that transition from prison into those services for medication-assisted treatment are in place promptly upon release. So I'm going to introduce our panelists now. So our first panelist will be Ryan Moser with the Corporation for Supportive Housing, where he is the Vice President for Strategy and Impact. And he's responsible for data and analytics, strategic alignment, and impact investment portfolios. Next panelist. Kristen Looper will be talking about the SOAR Technical Assistance Center. She's the Program Area Director at Policy Research for the SOAR TA Center, and she previously worked as the Director of the Georgia SOAR Program. Marguerite Shervish is a Technical Director for the Prevention and Treatment Team, and she'll be talking about the federal guidelines around Medicaid eligibility for incarcerated populations. There's a lot of confusion around this issue around the country, which is a barrier to getting those Medicaid services, and she'll be addressing that issue in her presentation. And lastly, Sean Clark, who's the National Coordinator for Veterans Justice Outreach in the United States Veterans Affairs. He will be speaking about the Veterans Justice Outreach Program, and I'm pretty sure he'll also be addressing the Healthcare for Reentry Veterans Program, which looks at the reentry piece of the veterans services, while the VJO is more, the Veterans Justice Outreach is more of a front-end piece. So I'm going to turn it over to our first panelist, Ryan Moser, to speak about housing.
Thank you so much, Dan, and thank you to SAMHSA and everybody for having me here today. I am Ryan, and I'm extremely happy to be talking about justice housing because I work in a lot of different housing areas and looking at behavioral health needs, aging needs, youth needs across the board, and thinking about how supportive housing in particular plays into those. But none are near and dear to my heart than justice concerns. So next slide, please. All right, so just to let you know who's talking to you. CSH is a national nonprofit. We're an intermediary. We are a community development bank, so we finance supportive housing with loans and grants, and we help design programs, create public policy. We work in about 48 states over the course of a year. Nationally, we're a federal assistance contractor, and we're very deep in homelessness roots, but also in these other feeder systems like justice that are so important to understanding housing and community service needs. You know, today I'm going to try to just set a baseline to think about what does housing and health look like around the justice population, in particular thinking about behavioral health, and what does that need feel like? How big is it? How does it differ, and how variable is it across people and individuals and places, right? And then I'm going to talk you through some models where we look at what does this look like in New York and Ohio? What are different models for family reunification? How is pay for success fitting into the mold? So that's kind of the agenda of where we'll take it, and I'll try to then help you think about how to engage with communities and how this can fit into your systems. Go ahead, next slide. All right, so there's a ton of conversation out there now. You have to kind of have missed the truck and fallen off of a different one to not have heard about social determinants of health, right? Everybody's talking about how important housing, jobs, employment, school are in order to get health outcomes in our struggling health economy, right? But I'm here to tell you that housing is also an equally important social determinant of safety. Right? And when we think about how people are involved in the criminal justice system, the collateral consequences that accompany not having housing and extreme poverty, we look at this kind of cycle of involvement that happens. We understand that housing can be in every single point in the sequential intercept, a factor that creates greater complications and can prevent people from recovery, can prevent people from engagement effectively with employment or their families, can prevent and disrupt people's housing status, right, can cause eviction and lease violations, and can in fact cause further incarceration. Go ahead to the next slide, please. All right. However, now, and especially this is important if you're thinking about this from either a behavioral health or a criminal justice lens, right, but housing, if you have any conversation with anybody coming out of jail, it's one of the top three, right? Maybe four issues that you hear about. So it's either employment, or I got to get back together with my family, or I need some transportation, or it's housing, right? And those issues are just always rising to the top as one of the cruxes. Housing is one of the most challenging to fix because we have a culture that has an exceptionally high rate of housing instability and high cost in housing markets, right? So we have a lot of housing issues that are much broader than just the ones that we're facing, right? But we also need to know that just because somebody has designated that they need housing or says that they need housing doesn't mean that that housing need is all the same, right? And the reality is that when we look across different correctional facilities, different behavioral health facilities, there is very little consistency with the way we ask people about housing, how we use that data, and how we understand what that need looks like. I think about housing need as a sort of a three-tiered bucket here, right? So that top piece is the low need, and that's about half of people that are coming back. And these are folks that are probably going to go back to family, to existing housing settings, right? Maybe there's been a disruption, but there's not going to be a major disruption. They'll be able to get back on their feet very quickly or with limited supports, right? Those folks probably have lighter behavioral health needs or other disabilities and issues going on underneath, right? They have fewer complicating factors. They probably have a strong work history and are more likely to be able to reenter with limited supports in the community, right? The next set, and here it's like 30 to 40% at a broad stroke. These are people with much higher needs at still what I would consider moderate. So there's probably behavioral health or mental health needs going on here, maybe addiction issues, right? We might have a limited or spotty education history, limited work history, some disruption. It could be histories of lease violations or rent arrears, things like that that are going to be harder to fix when somebody's coming out. Right, but the notion is that, maybe with some support over a period of time or with some assistance helping reunify with family or with some assistance helping somebody with rental costs in the beginning or with housing search, they may be able to get back into the market without a huge disruption and with short-term assistance and be able to pretty quickly stand up on their own. Right, now that doesn't necessarily mean that that's a good long-term stable situation. Right, and so those longer issues related to housing stability and access to treatment, all those things are going to continue to rear their heads. But it's very different when you think about the high need, and these are the folks that CSH focuses on heavily. Right, so when I think about high need, I think about people that may have concurrent disorders going on, so severe mental health issues, a lot of disruptive addiction disorders, maybe physical barriers as well, histories of trauma, long-term involvement with systems, maybe long histories of homelessness or really sporadic housing. Right, probably little to no rental history that's effective, maybe a whole list of arrears and different kind of credit issues that will pop up if you ever do try to get into housing, and can create issues related to employment and reunification with family, all sorts of other things too, right? So that high need are the folks that I generally am talking about when I think about supportive housing. So it's important to think about this need and this variation so that when you're looking at somebody coming out or when you're working with a community to prioritize limited resources, you can help them think about, okay, you know what, let's focus our supportive housing resources on those with the highest need. Let's build those partnerships. For moderate need, maybe we can think about other housing supports and resources we can bring to bear. Go ahead, next slide, please. So how big is the need really, right? So we did a national needs assessment really for the first time 2 years ago, looking at supportive housing need across the country. And you can find this on CSH's website. All the information is public and available, csh.org/data. And you can sort by different systems. So this particular map that I produced for this slide is showing you the jail population, or the jail custody numbers, right, on a point in time at a daily census amount, the prison census amount, and people in juvenile justice care, so young people in juvenile justice, right? So that, when we look at our need nationally, that's about a quarter of the supportive housing need that we think of, right? So I want to call that out because when you think about the amount of time and energy that's spent related to supportive housing in the homelessness sector versus that in the criminal justice sector, it's nowhere near proportionate, right? The amount of people involved with the criminal justice settings that have these deep needs that are unaddressed, that really need long-term community supports and services, is vastly outnumbering the effort and the resources that are in place, right? So the overall need we see around criminal justice is about 1.2 million nationally around supportive housing across all the sectors that we look at is about 1.2 million on a given day, right? So that's about the number of housing need that's unmet on any day in our culture, right? When you think about it, there's a quarter of that. So you get about 250,000 people that are falling into that because of their involvement in the criminal justice system or are showing up in the criminal justice system because of those unmet needs. Okay, next slide, please. All right, so, and I'm sorry, I have a bit of a chest cold, so I apologize for coughing at you, but at least you get this nice raspy voice of mine. Dan can tell you I normally have a little bit of a higher timbre, so you get a more pleasant listening experience, maybe minus the coughs. So Fuse, this is one of our strategic initiatives. We call it a signature initiative from CSH. We've been working on it. That's what I first came to work on at CSH 12 years ago, so it's a long-stay program at CSH. And it basically was the first program in the country that tried to use administrative data to look at the overlaps between, at the time, criminal justice and jail in particular, and homeless services and looking at housing instability, find the people that had those matches, right, and help them get into housing with services and see what happened, right? And the postulate was, you know what, if we do this, if we dedicate supportive housing and we go find these folks, we recruit them, get them into housing, it's going to work. And I can tell you from the early days of recruitment, that was not a shared concept, right? So when we went out to many of our tried and true partners to try to recruit providers to work on this stuff, people laughed at us. They closed the door. They said, you know what, this is great, but it's an awful idea. These folks are never going to do well in housing. They don't deserve housing. They don't belong in it, and they're not going to be stable, right? We're going to be wasting public resources. And this is a picture of what one of those people looked like, right? So the purple that you see here is time spent in jail, right? The blue that you see, and this is over a 2-year period, is time spent in shelter. And these gray periods, the little bits that they show up, are we don't know, right? But I can guess, and you could probably guess too, based on your experience with these people, they might be in a detox facility or a residential treatment program. They might be showing up in a hospital. They might be doubled up on somebody's couch or living in an abandoned building. Right? They might be showing up in some other crisis service. They're probably not showing up in a happy, stable home life, right? So this is the person that we went out and we said, you know what, we'd like to focus here. Instead of saying let's avoid dysfunction and try to screen people out of housing, we flipped the script and said let's try to get people into housing that need it the most, that have this greatest sense of dysfunction, of disruption in their lives, and see what happens when we create the stability of services tied with very affordable housing that they can actually afford to be in, which sometimes is almost free, right? So let's flip to the next slide. Basically, supportive housing and Fuse aligns corrections and criminal justice need. It aligns services to support behavioral health, community support services, and it aligns affordable housing. And it brings those together in a case management model that is very tenant-centered, very personalized, and it can include any of the services that you see on this slide, right? So it ranges everywhere from family reunification or employment supports to thinking about how do you connect with treatment, or engaging people about whether or not they would like to be in treatment or what other things they'd like to focus on, right? When Dan talked about that death rate that happens right after jail, right, and it's higher in the 2 years following jail, it's higher still in that 30 days following jail. A lot of that leads to reintroduction of addiction and the severity of drugs that are out there today, right, and the use that happens and the spikes in need and tolerance issues, right? A lot of it relates to just, frankly, exposure, failure to have access to a stable place to be, and the things that follow from that, right? But it's important when you're working with a justice population or with people that are involved in the justice system to say, hey, you know, we don't just have to know how to do housing. We don't just have to know how to address behavioral health needs. We have to understand the criminal justice system. We have to talk to people about what it is that's going to help them stay out of the criminal justice system, meet compliance issues. We have to understand how to interface with their defense attorneys if they might have one, or how to work with them to resolve a stipulation from the court, right? We just have to understand what the triggers that might be happening, and really good criminogenics and risk-need responsivity kind of goals. And I know you've heard about that from smarter people than me today. All right, so next one. Okay, so the amazing thing, though, right, despite all of this concern, and I don't know if this will happen, and we placed the first 100 people in this program, was that it worked, right? Despite those concerns, the people that took a chance and they said, you know what, maybe these folks aren't so different. Maybe housing could make a difference for people that don't have it. Maybe these community-based services could actually turn the curve and break the cycle of incarceration. Right, and so we saw that, in fact, it reduced jail stays, it reduced shelter stays, and we've seen this over and over again in project after project. People get connected to community-based care. They start using primary care services. They can engage in treatment. Some studies show reductions in opioid use, right? So we see just a variety of clinical effects. It doesn't mean that housing alone does that. Just sticking somebody in a housing unit doesn't necessarily make the bridge. Just giving people money doesn't necessarily make it that they're going to be able to maintain an employment position, right? But when you appropriately pair it with effective services that are savvy, that understand someone's need, and that are driven and directed by the tenant, you can see amazing things happen. Say, next slide, please. Okay, so now I'm going to flip through a couple of other projects, right? So that was Fuse, and I'll come back to Fuse at the end again for a moment. But here's one that's called Returning Home Ohio. And this is a project that we manage that's actually done with the Ohio Department of Correction Rehabilitative Services, so ODRC. And this was started, and one of the things that's interesting about it is that it came into existence because the commissioner decided, you know what, we need to invest in housing because I don't want to build another prison. I am brushing right up against the population numbers that I have, and I can barely contain our prison system. So I need to find out some alternatives of how I can get people out of my system, stop them from coming back, and get them out in the community, right? And so using that logic, he diverted funding from a halfway house program that they ran that was not effective and didn't get good results, which, frankly, a lot of times is the case with halfway housing. And they moved it towards supportive housing and services in the community. And so CSH was brought in. We contracted with community-based service providers to go find the housing, help people access it, provide the community supports in the community, right, or the services in the community. And then we worked with the Ohio Department of Corrections to look at risk assessments, think about how do criminal justice risk assessments align with social need and behavioral health need risk assessments in the community, and what it's going to take for somebody to be stable after they leave. And the reality is that we have had tremendous results with this program. It's really targeted heavily towards people with mental illness and severe addictions, a lot of co-occurring disorders, right? And we see a really good reduction in recidivism. We see strong increases in services connection, particularly around addiction issues. All right, next slide, please. Here's another program in Ohio. This is called the Community Transitions Program, and it's run by a group called CareSource. CareSource is a behavioral health managed care company. They're a nonprofit accountable care organization in Ohio, and they have the behavioral health carve-out. So they provide the services on the behalf of the state for people that are poor, indigent, that need access to behavioral health services, primarily. Right, and so what they do then is that they have this set up, and we help to generate this with the state government, but they have this set aside of resources that they use, and they're focusing on housing as a way of addressing their members' needs. So they're taking out of the capitation that they get for their services, and they're pushing housing money out to try and reduce their need. Right? So this program is fascinating because it actually applies a couple of different housing interventions. So it includes permanent housing, supportive housing, right? And then it also has rapid rehousing, which is basically, you can think of it as bridge assistance in helping people adjust to a new access and adjust to a new apartment living, and then pulls away supports. Right? And then the last piece is recovery housing, which is actually not very popular in the model, but Ohio has a very robust recovery housing program, and so that is an accessible resource for people. Right? The way that people get into the different program distinctions is based partly on their needs assessment and how severe their needs show up and how they show up, and then partly on their choice. So people get to say, you know what, I would prefer this model. And then the last piece is availability. So on the day that somebody comes out, they may or may not have access to the resource that is their top choice, so they might have to choose something else, right? The program is now housed over 600 people and has a 4% recidivism rate after 2 years. We're going on 2 years, right? So we're working with some folks around risk needs responsivity in Ohio. We've been training our staff to improve their criminogenic knowledge, and the folks that are contracted under this program. And the folks that are doing the risk needs responsivity have said, you know, this is great. We're so happy to be working with you and building this in. We love it. It's a great response. And they've also said, we also just want to be really careful not to screw this program up because, frankly, you're getting better results than anything else that we're seeing. And so we want to make sure that as we're adding in this layer of risk needs responsivity and effectiveness and really doing it to fidelity, we do it in a way that allows the flexibility that you have in your program to address people's needs and help them maintain their housing and their place in the community. Okay, so let's go ahead to the next slide. Thank you. So this next slide is about family reunification, really. And this was a pilot that was done in New York City Housing Authority. And this is for the folks that come out, and about half of the participants in this group are people that are young, right? And they're coming back, and they can't return to their family because they have an exclusionary bar because they committed a criminal offense. They were removed from housing and arrested, right? And now they can't go back or their family will be evicted. So we worked with NYCHA and a bunch of great providers to say, what would it take to bring these folks back? If we provided, say, 6 months of additional supports and services for the family and for the person that's returning, if the family has a chance to say, yes, we do, or no, we don't want these folks to come back, and they have the right to be safe in their own space, can we work with you to alleviate these restrictions, and then maybe after a year get them re-added to the lease and returned to the normal living situation? So NYCHA said, yeah, we'll do that, and they tried it out. And basically it opens the door for people that otherwise are unable to access housing, right? And you just got to think about that for a minute, right? Because a lot of people live in public affordable housing that has restrictions like this, right? It would be akin to if you and your family at your house got arrested, were taken away, and then your wife or your father or your mother was unable to let you back into the house that you live in because if you came back, they would all be evicted, right? And imagine the disruption that causes just for a minute and think about how impactful an approach like this can be. And I bring it up to think about how can you think about different innovative ways of engaging with housing agencies to do this kind of work. Okay, next slide. All right, the last model I'm going to talk about, and then I'll wrap up with 2 slides from Fuse, is this Denver Pay for Success project. So we're seeing a real increase in impact investing and pay for success or social impact bonds. This is one of the projects that we manage in Denver, and it's placing about 250 people, primarily through scattered site, although through some set-asides in larger affordable housing buildings as well, into supportive housing with services designed to help them maintain their stability. And it's targeted to people that are chronically homeless and jail involved, right? Because that was a real pressing issue in Denver that they're having problems with, right? So you can see on this slide what the measures look like and thinking about it, but the idea here is that it's pay for success, right? So as opposed to saying we'll pay you for what you're doing, that program is required to show results and actually demonstrate that people are in fact reducing their recidivism, people are staying out in the community, people are not returning to shelter, they're staying in the housing that they're supposed to be put in, or that they're being supported into accessing, right? And then those payments that are agreed upon with the city in Denver are issued based on that success, and that's what repays. It also brings in private investment. So in this case, some banks are investing in some foundations into a corpus that's running the project, right? Those funds are used, and then they're replenished when we get these success repayments from the city. And then that returns the money to private investors, and if it's successful beyond expectations, they get a bit of a return as well, right? So it's really tied to the performance of the program. So this project is about to offer its second success payment to investors. It's closing in on its second year. It's exceeding its benchmarks right now. It was a little bit slow starting, but it's running exceptionally well. And it's really the second program in the country that has had success payments of this type, right? So in all of the conversations you hear about social impact, investing in bonds, it's important to know that housing, supportive housing in particular, is one of the first that's really able to show the success that's needed to repay private sector partners. Next page, please. All right. So this was a bunch and sort of drinking from a fire hose run of examples of different ways you could think about engaging with communities and partners. But I also think about Fuse as a process, right? And this is the one that we laid out for that Fuse initiative that we work on. And really just kind of think about how do you engage communities? And we think about planning exercises. We think about pilots or testing or scaling small interventions in the beginning in a jurisdiction to test them out, kick out the kinks in the system, get it working, right? And then we think about moving directly to scaling and start to think about how do you increase investment. And that's where tools like Pay for Success or federal or local legislation come in to advance the work. All right, so this is another thing you can access on our website. It's all up in public as well. Go ahead, next slide, please. All right, and the last thing is just that this is something that needs to happen at a national scale. All right, so going back to that need, there's a little bit over 30 Fuse projects that we've helped launch and know about and we sort of claim as ones that we've been involved with across the country. Right now we have about 27 communities engaged in planning processes around this through a learning collaborative that we're doing nationally. Right, so for you, in thinking about your government role, the programs that you have, new resources that might be coming down the pike from reentry legislation, from opioid planning, we really need to be thinking from a public sector perspective around what can we do to foster these relationships? How can we make these connections happen? How can we support people to bridge data, bring partnerships together to make this work come alive? And I'm here to tell you it can be done. And next slide, if we have one. And that's it. So, Dan, I'll turn it back to you.
Thanks, Ryan. And first, I want to reassure you that your voice timbre was just fine. And I also want to say that we do sequential intercept mapping, and you're right. One of the biggest priorities across communities that we work in is always housing, but very often they're stymied, thinking it's too big of an issue for the people in the room to address. And yet you've shown us a lot of different strategies that break this issue out into smaller pieces that communities can manage. So I hope it stimulates some partnerships and working with public housing authorities and providers in the communities. One of the other keys, though, to accessing housing, I used to oversee reentry from prison in New York State when we implemented a SOAR program. And when the housing providers found out that people were coming out with Social Security benefits in place and they get the check that first full month that they were in the housing program, that reduced a lot of the barriers right away. So Kristen Lupfer from the SOAR Center, SAMHSA SOAR Center, is going to talk about implementing a SOAR program in criminal justice settings. Kristen?
All right, thanks, Dan, and hello, everyone. I'm very excited to speak with you about how SOAR can be a reentry tool for individuals involved in the criminal justice system. I'm going to share with you a little bit about the SOAR program, why it's important, and how it works. And I'll share with you how programs nationwide are implementing SOAR with justice-involved persons. Next slide. So SOAR stands for SSI, SSDI, Outreach, Access, and Recovery. But it's not just about the applications. It's about the role that benefits can play in really transforming lives. So SOAR is a SAMHSA-sponsored program that's really focused on increasing access to Social Security disability benefits for individuals who are experiencing or at risk of homelessness and have a serious mental illness, medical condition, or co-occurring substance use disorder. And that at risk of homelessness absolutely includes individuals who are currently incarcerated, involved in the criminal justice system, and have no place to go upon release. SOAR is active in all 50 states and the District of Columbia, but each state is at a different level of implementation. There is no specific federal funding or grants for SOAR activity, and so the SOAR TA Center works with states and communities to develop plans for implementing the program through technical assistance and training. Next slide. I wish that I could spend a few hours or even days talking with you about SOAR, but they tell me I have 17 minutes. So I'm just going to share a few basics to whet your appetite. Social Security benefits and programs are complex, and there's a lot to learn. So we're going to give you this taste and leave you wanting some more. So the Social Security Administration has two disability benefits programs, Supplemental Security Income, or SSI, and Social Security Disability Insurance, or SSDI. SSI is needs-based, and it's for people who are blind, disabled, or elderly, and who have low income and resources. The federal benefit rate in 2019 is going to be $771 a month, and SSI generally comes with Medicaid. SSDI is an insurance program, and the benefit is based on payments that are made into the Social Security Trust Fund through those FICA contributions from your paycheck. And SSDI generally comes with Medicare after a 2-year waiting period. Next slide. It's very important to understand how SSA defines disability. So the Social Security definition is going to be different than your doctor's definition, your insurance company's definition, and even the VA's definition. SSA is looking for 3 primary components. Do you have a medically determinable physical or mental impairment that's lasted or is expected to last 12 months or more or result in death? And do you have a significant functional impairment that impedes your ability to work? So SSA wants to know if you are able to, despite these impairments, work and earn at a substantial gainful level. And that's measured at earnings of, in 2019, will be $1,220 a month. This is not a short-term or partial disability program, and having a diagnosis is not enough. Having a chronic condition is not enough. The illness or the condition must be impacting the person's ability to work. Next slide. So we talk a lot about income and health insurance, and those benefits are really essential bricks, but only individual bricks in the foundation for stable housing, recovery, and wellness. So SOAR is seeking to end homelessness through increased access to these SSI and SSDI income supports, and that really is essential. And for many persons in recovery, accessing benefits is that first step. But like Ryan mentioned at the beginning of his presentation, the social determinants of health are vitally important. And so SOAR extends beyond that and also encourages employment as a means to increase individual income and promote recovery. And that sounds kind of funny talking about employment when we're talking about disability, but in fact, they can work hand in hand. And so once a person has been approved for disability benefits, you know, that sense of accomplishment and relief, it can make us feel like our work is done, but really it's just the beginning. The income and health insurance that are gained help ensure someone's basic needs are met, but there is so much more to recovery. And so it's a big piece of what we encourage. And we know that helping people stabilize in housing will help decrease incarcerations and hospitalizations, reduce recidivism rates, so it can make a big difference in that stability. Next slide. So when we talk about Social Security benefits for justice-involved persons, it's really important to understand what happens when someone who is receiving benefits is incarcerated and how someone who is incarcerated can access benefits as part of their reentry planning. So because SSI is a needs-based program and SSDI is an insurance program, SSA handles the suspension and termination of each benefit program differently. So the table on this slide gives you a little bit of detail about what happens to SSI benefits. So if you're incarcerated for less than a full calendar month, there's no effect on your benefit. If you are incarcerated for a full calendar month, 1 through 12, your benefit is suspended, and you can be, your benefits can be reinstated upon your release. But if you are incarcerated for 12 calendar months, your benefits are terminated and you have to reapply. And so it's when individuals are in this situation of needing to reapply for benefits because they've been terminated or because they've never received benefits or weren't recently receiving benefits, that they need to do a pre-release application. And the wonderful opportunity that Social Security provides is that you can do a pre-release application before someone is released from custody. The general rule is 30 days prior to their expected release date, but with pre-release agreements, that time can be extended up to 120 days prior to release. So by doing those applications prior to release, we can get someone set up with their benefits, like Dan mentioned, have that first check ready to go once they're officially released in the community, and get those rent payments out and have money available to really help someone have a smooth transition back into the community. Next slide. So for SSDI, you know, another table, it's a little bit different because it's insurance. If you are incarcerated for less than 30 days, there's no effect on your benefit. Your check still comes. And not until you are both convicted and confined of your criminal offense are your benefits suspended. And there is no termination of benefits. So someone who was receiving SSDI benefits, they can get their benefits reinstated upon their release, no matter the length of time with that incarceration. Next slide. So we know that it's important to do pre-release applications for individuals who might be eligible for benefits, but how does SOAR work and how can we actually make a difference in this regular SSI and SSDI application process? So we really focus on case managers actively assisting applicants to get it right the first time. We focus on documenting the disability and forming support systems and processes in communities to really make the efforts more successful. And we do that through serving as the individual's representative, collecting and submitting medical records, writing and submitting a medical summary report, getting that co-signed by their physician, doing a quality review of applications, working in collaboration with Social Security. There's a lot that kind of goes into submitting complete and quality applications that really makes the difference. So we really say those SOAR-trained caseworkers are the heroes in the process. So it seems a little overwhelming, seems like there's a lot that goes into it, and there is, but we don't want you to be overwhelmed because what we've done is set up a really strong support system to support case managers in their efforts. Next slide. So SOAR cannot and does not function in a vacuum. We really rely heavily on our community partners. So first and foremost, the Social Security Administration is really an essential collaborator. They're the federal agency that's administering SSI and SSDI, and because SSA is federal, their eligibility rules are the same in every state. And SSA is the one who's making that non-medical decision on the claim. But it doesn't stop there. So every state has a disability determination services, or DDS. It works in partnership with SSA to make that medical or disability determination. And they're often the unknown player in the process, but with SOAR, they're really absolutely key. Medical and treatment providers are extremely important in terms of access to assessments, evaluations, and the corresponding medical records needed to support the claim. And also we're involved partners from criminal justice organizations, of course, and Veterans Affairs and employment programs and housing providers to really ensure that the individuals that are served by SOAR are receiving comprehensive services and supports. So SOAR programs, we really don't want them operating in a silo. It's not that you're going to this benefits shop, but really you're going and getting someone the benefits and stability that they need to thrive in the community. Next slide. So we kind of created this organizational chart of sorts that you can tell is a pretty flat structure. It includes the SOAR TA Center, all 51 state team leads, hundreds of local leads, and thousands of case managers. And we all have slightly different roles and expectations when it comes to providing training or answering questions, tracking outcomes, doing quality review, and assisting directly with applications. However, we're all kind of ambassadors for the SOAR initiative and are really united in ending homelessness for individuals with disabling conditions. Next slide. So the SOAR TA Center provides support to states and communities both virtually and through on-site support, all supported by SAMHSA. We have liaisons who are responsible for SOAR in multiple states and who build relationships locally to provide a real personalized service. We provide assistance from strategic planning at the state level and developing funding plans and key collaborations with federal partners to helping case managers with Question 25 on the SSI application. If it has something to do with Social Security disability applications, we want to help make the process smoother, more timely, and at a higher quality. So we offer soaring over lunch calls for new and seasoned caseworkers to get their questions answered. We celebrate success stories in our newsletter. We train local and state leaders in our Leadership Academy and maintain a library packed full of tools and resources for use by stakeholders at all levels in the process. Next slide. So it's through all of this community collaboration and partnerships and the hard work of SOAR-trained case managers that we've been able to successfully assist over 39,213 people to get approved for benefits on their initial application. And as you may be aware, the Social Security disability application is pretty complex. So for unassisted applications from people experiencing homelessness, the average approval rate on the initial application is only about 10 to 15%. And the national average for all applicants isn't much higher, only about 28%. Most people are, 29% this year. Most people are denied on their initial application. However, if you go to the next slide, the national SOAR approval rate is over double that at 65%. And SOAR decisions are made in an average of 100 days in 2018. So there's no more waiting 1 and 2 years for an appeal. SOAR is really about getting it right the first time. Next slide. So 65%, that's an incredible number. But what we know is states that are utilizing all of the SOAR critical components can achieve an even higher approval rate. So our top 10 states, which are doing that, have an average 82% approval rate right now on over 14,000 decisions. So they're making a huge impact and doing an incredible job. And not only is SOAR successful at getting applications approved and transforming individual lives through that life-saving income and healthcare, but they're also helping communities and programs by bringing reimbursements and income into communities and providers. So we track Medicaid reimbursements and general assistance reimbursements, the back payments that individuals receive, the other money that's brought into local economies. And it turns out to be millions and millions of dollars and makes a huge difference, which in turn states and communities and local providers have utilized those outcomes to leverage for funding for positions. And so there are 347 full and part-time SOAR positions nationally. Providers have shown that their programs are effective, and they've convinced funders to fund these dedicated SOAR positions. Next slide. So we've been working hard the last few years to really expand our efforts in criminal justice settings and have held technical assistance opportunities for criminal justice providers. And so the two maps you see here are the 6 facilities in 2017 and 6 facilities in 2018 that received our TA award, where we went out and did on-site implementation meetings and prepared local leads and helped get the facilities ready to implement SOAR in their institution or in their program or in their community, and have seen great success from this. Next slide. So just a few of our criminal justice outcomes. So just pulling data from our SOAR online application tracking program, we've been able to see a cumulative total of 319 applications assisted for people who were residing in correctional facilities when their applications were submitted. Their applications were decided in an average of 79 days, which is incredible, and have a 76% approval rate. So we know that we can get applications approved on a pre-release basis for folks who are in facilities. Next slide. So I have a few examples that I want to talk through with the little bit of time we've got left. So this is actually a program that Dan worked with many years ago, but we had a collaboration with Sing Sing Prison and a community services agency in New York City, where they were doing in-reach with the prison. So staff from the community agency would do applications for individuals who were getting ready for release, and so prior to their release to the community. They had an incredible approval rate. 90% of the pre-release applications were approved in less than 2 months. Many were approved prior to release, and the rest were approved within 1 month of their release. So made a big impact in getting people into housing directly from prison. Next slide. Our a great SOAR and jail collaboration in Davidson County, Tennessee, which is in Nashville, or Nashville is in Davidson County, I should say. They've had a great collaboration with their mayor's Office of Innovation and the sheriff's office and their Metro Social Services to implement an initiative with the jail. And their mission is really to assist individuals who were experiencing homelessness and didn't have income, had a serious mental illness, to get them benefits before they were released back to the community. And they've had great success with that, having a dedicated SOAR caseworker in their jail. Next slide. Next slide. I'm not sure if the slide advanced. I got a connection problem notification. Can confirm for me you still have my audio.
Kristen, this is Holly. We're on slide 243, SOAR online courses.
Okay, great. So if you can actually go one back to the Oklahoma slide. Thank you. So we have an incredible collaboration with the Oklahoma Department of Corrections. They have a program that was funded by the Oklahoma Department of Mental Health and Substance Abuse Services. where they have staff who are trained to assist with accessing public benefits, including SSI and SSDI, and they nurtured some really great relationships with state and federal partners. They collaborated on a number of reentry grants, and this program's been going on now for the past 11 years, and their approval rates have been greater than 80%, and it's made a really big difference in their state. It's been a great success. So next slide now, thank you. So the SOAR online course is how you can get started. Some of you may have been familiar with SOAR in the past. It's been around now for over 10 years. And so we used to have a 2-day in-person training that was available. And over the last 4 years, SOAR training's been provided online through the SOAR online course. And it's really made a significant impact in standardizing the training, expanding it to new areas, adding a practice application that's really grounded the learning. So the course has 7 classes that include videos, articles, quizzes, and the practice case. So let's see, we now, since the end of October, we've launched a child curriculum and are training case managers now to assist with child SSI claims. So SOAR has been focused only on adult applications up to this point, and we're really excited about the expansion to include child SSI, which would include youth involved in the juvenile justice system as well. Next slide. So the course, like I said, it's online, it's free, available to take anytime, anywhere. We estimate that it takes about 20 hours to complete, including the practice case component, and successful completion comes with 20 free CEUs from the National Association of Social Workers, and that's both courses individually. So if you complete both courses, it's 40 hours of CEUs. Yes, great, next slide. So we talked about its comprehensive articles and content and this practice case component, which really make a huge difference in kind of confirming that individuals have really learned and taken in the knowledge. Next slide. So I talked a few slides back about the criminal justice technical assistance opportunity that we had the past 2 years. Well, we are currently accepting applications for the 2019 opportunity. So it's a planning and technical assistance opportunity that includes, like I mentioned, an implementation meeting, Leadership Academy participation, and the online course in OAT. It just requires a 3 to 5 page application, which you can access the RFA on the SOARworks website, and applications are due next week, so it's not too late. Next slide. We have a number of SOAR and criminal justice resources on the website, including a really helpful infographic, some sample tools, and an issue brief you can access here. Next slide. So next steps, we encourage you to gather some more information about SOAR, consider incorporating it into your services. And if you visit the SOAR website and go to SOAR in your state, you can find your state team lead and your SOAR TA Center liaison. So we'd love you to check out the website and the course and reach out to us at the SAMHSA SOAR TA Center for any questions you might have, or if you'd like to make a plan for using SOAR. And I think this last slide has my contact. Oh, no, it doesn't. All right. Thanks so much.
Thank you, Kristen. So staying with the benefits theme here, we're going to move to Marguerite Shervis, who'll be talking about the Center for Medicaid Services guidance to states around Medicaid and incarcerated individuals. Again, another really important component in reentry planning. Without Medicaid, some kind of insurance, coming out of jails or prisons, you're denied access to medication and prompt services very often. So this is not as well understood across the country as it needs to be, especially with the Affordable Care Act expanding Medicaid to inmate populations. So Marguerite, lead us through your presentation.
Dan, I thank you very much for your introduction. I have to call back in on a different phone. I apologize. I'll do that promptly.
You want to cue Sean up? Sean, are you ready to move up your presentation?
Sure, Dan.
Okay, well, we'll start with you in the interest of time, and we'll have Marguerite talk at the end. So certainly in talking about reentry and jail diversion, we want to emphasize the importance of the need of veterans, and so we're going to look to you to guide us through that. Sean Clark.
Well, thanks very much, Dan, and thanks to our hosts for the chance to be a part of the discussion this afternoon, and to all of you for your interest in Services for Justice-Involved Veterans. I want to take some time and highlight VA resources that are available to veterans who are engaged with different arms of the criminal justice system, and in particular, talking about two outreach programs here at VA that are designed to facilitate access to those services for veterans in those settings. So as Dan mentioned in the introductions, there are two justice programs here at VA, and I will be talking about both of them. I just want to note at the beginning that our outreach programs, of course, aren't an end in themselves, and the point of them both and of everything that we do in these programs is to go out in the world, find justice-involved veterans who have access to the service, who have barriers to access, to the services that we offer, and help those veterans get connected to the services that are appropriate to them as individuals as quickly as possible. So that's what animates everything that we do in these two programs. And if we could go to the next slide, please. This graphic comes to us from the Department of Justice's Bureau of Justice Statistics, and they are the authoritative source on the overall population of justice-involved veterans in the United States. So we can talk, and I will in a few minutes, about the justice-involved veterans who we have contact with in our programs, but BJS is the gold standard as far as determining the number of veterans who are incarcerated in prisons and jails across the country. This information comes from their most recent report on veterans in prisons and jails. It was published in 2015, and it includes data that was gathered in 2011 and 2012. And the declining curve here kind of tells the story. This is BJS's estimate dating back now close to 30 years of the number of veterans in prison and jail, not of the number, but of veterans' share of the overall U.S. adult resident population and of their share of the U.S. prison and jail populations. And as you see, that has been declining since BJS has been looking at this number starting in the late 1970s. And now, as has been the case since they looked in the late 90s, veterans are underrepresented in the prison and jail populations compared to their prevalence in the overall U.S. adult population. The overall number of veterans in prison and jail as of 2011-2012, according to BJS, is 181,500. So if we move to the next slide, we can get another perspective on that. This is the incarceration rate of veterans and non-veterans over that same period. So a different angle to look at this question through. The incarceration rate for veterans has also been declining since the late 1990s, as you can see here. So taken together, these pieces of information really are good news. Veterans are not overrepresented in the criminal justice system. I think that's a misconception that is still out there to a significant extent. In fact, they're underrepresented relative to their size as a general population, and they're incarcerated at lower rates than their non-veteran adult counterparts. All that said, 181,500 is a huge number, and when you think about it in terms of 181,500 individuals, each of whom faces a unique combination of challenges and barriers to successful functioning when they return to their communities, the task appropriately seems as huge as it really is. And if we can move to the next slide. Picking up on the point that Ryan made earlier in the discussion, a significant part of the reason for that is because of this nexus between incarceration and homelessness. And you see here a few points about that issue, starting with Martha Burton and her colleagues finding that incarceration as an adult male, and of course that's the vast majority of the VA service population, is the single highest risk factor of becoming homeless. I think that it's intuitive when you think about long-term incarceration, so going to state and federal prison, spending a period of years at great distance from family and other social supports. It makes sense that inmates coming out of that situation would face an increased risk of becoming homelessness because all of your social ties and your resources have eroded during a long period of time. I think that's easy to grasp. I think what's often harder for folks to realize is that it doesn't take very long at all for incarceration to really threaten your housing stability for a variety of reasons. Losing a job after not turning up for a couple of days, losing your ability to maintain your housing for non-payment of rent after a very short period of time. And so that's always a point that we try and keep in mind. It's not just long-term incarceration that bears on folks' risk of becoming homeless. It's the fact of incarceration itself. And so looking at it through that lens, justice involvement of any kind is a potential risk factor for incarceration, certainly, and by extension for homelessness. So, as Dan mentioned as well, another good point that's not on the slide but worth making for sure is that the risk, the link between reentry from incarceration and suicide risk is becoming clearer and clearer all the time. These are two of VA's absolute top priorities. Suicide prevention for veterans is VA's very top clinical priority. And homelessness has been the focus of a major national initiative in VA for several years now. So from the VA perspective, justice involvement is an outreach priority because we're trying to connect with veterans who are facing increased risks of catastrophically bad outcomes on a number of fronts. So if we could move to the next slide. Thank you. So taking a step back and looking at our agency, I want to talk for just a moment about what VA is in the very broadest sense. The U.S. Department of Veterans Affairs and many different organizations go by the name VA. There are state departments of Veterans Affairs that also, of course, serve veterans, but usually have a very different array of services and benefits that they have to offer. They work with veterans in a very different way. There are county Veterans Service offices all over the country. There are also veteran service organizations that are separate. But the U.S. Department of Veterans Affairs is made up of these three main components. First is the Veterans Health Administration, which is an integrated national health care system for veterans. It consists of 170 flagship facilities, the VA medical centers, over 800 outpatient clinics that vary significantly in size and capacity. Some of these are very small and offer a limited range of services. Some of them you'd have a very hard time distinguishing from a hospital. And also 370 vet centers, which are storefront operations that are separate from the main VA healthcare facilities. They offer a focus on counseling provided to veterans who've experienced combat more often than not by counselors who are themselves combat veterans. So it's a part of the VA healthcare system, but a very distinct part. And in fact, vet center counseling records are not visible to clinicians in the broader VA healthcare system. So that's an important and again a distinct component of the healthcare system. These services, as I mentioned, it's a national integrated healthcare system. This is a comprehensive array of healthcare services that are available to veterans through the VA. So primary care, mental health, substance use disorder, and a list of services that goes on and is too long to cover in its totality. But the array of services that are available to veterans through the VA healthcare system is very broad. And VA's definition of what constitutes healthcare is itself broad. So VA's homeless programs, for example, are located in its healthcare system, indicating a holistic definition of what makes up healthcare. Second is the Veterans Benefits Administration, and VBA administers benefits that I'm sure many of you are very familiar with. These are primarily financial in nature, but not exclusively. The GI Bill and other education programs, those are administered by the Veterans Benefits Administration. Also, financial programs like disability compensation, pensions, life insurance, the VA Home Loan Program, vocational rehabilitation, and others as well. This is a partial list. But that's a separate administration within the U.S. Department of Veterans Affairs. Last and not least is the National Cemetery Administration, which administers, you see here, over 130 national cemeteries, provides funding for veteran cemeteries that are operated by the states, and also provides some of these services that you see listed for veterans who are buried in any cemetery across the country. So those are the three main components of VA. And if we could go to the next slide. Within the healthcare system are the Veterans Justice Programs, and I won't read our mission and vision statements to you, but I'll just say again that we are a part of the homeless programs in the VA healthcare system, and I'll pull out a few key notes from this slide to give you a sense of what we're about. Our mission leads with the need to identify justice-involved veterans. That is something that has not been done historically in many places in the criminal justice system. Fortunately, that's changing, and it's becoming much more common for local law enforcement departments, for local jails, state and federal prisons to systematically try and identify the veterans who are passing through their systems in order to identify them and potentially determine their need for services and hopefully partner with us to be able to connect veterans to those at the earliest possible point. The second key concept here is outreach. These are both outreach programs. We're not working strictly behind the walls of the VA medical centers. In the communities that we're serving, the staff in these programs are going into criminal justice settings and so to speak, taking VA to veterans where they are and helping them access what they need. Access itself is the next key concept. This is the point of all of our work, connecting justice-involved veterans to the VA services that they've earned as soon as possible. And partnerships are hard to overstate the importance of partnerships. We are entirely partnership dependent in veterans justice programs because the work that our staff do when they go into local jails, state and federal prisons, local courts, we're working in settings where VA has no right of access. We can't demand to get into a state prison, for example. That has to be worked out by building a relationship and maintaining that relationship over time so that our staff can get into these facilities, can make contact with justice-involved veterans and start working on helping them get what they need. Our vision here, as you see, which I won't read to you either, access to services for all justice-involved veterans, avoiding homelessness, and over time, disentangling from the criminal justice system. And if we could go next. A very familiar graphic, or a take on a very familiar graphic, I'm sure, for everyone. I've included this to make the point visually that the VA's justice programs really are intended as an off-ramp into treatment from every intercept point on the famous sequential intercept model. This graphic itself is a creation of Department of Justice's National Institute of Corrections, and although there are some additions to it here, some modifications, its lineage is very clear. It's obviously built on the work of Drs. Munitz and Griffin, and this is a tremendously useful tool to us, in part just to help explain what it is that we do and to show that we're intending these programs as a presence for VA at each stage of a veteran's progress through the criminal justice system. And if we could go next. So here side by side are a few details about these two programs that I've been talking about. And the first thing that you'll see is there are a lot of similarities. We're providing a good way to think about it is one intervention that's being provided along a continuum that has significantly different features. It's very different to work with a veteran who's going through a local treatment court program when compared with working with a veteran who's coming out of a federal prison after serving a 20-year sentence. But broadly speaking, Veterans Justice Outreach is the program that addresses veterans who are at the front end, so to speak, of the criminal justice process. And VJO specialists, again, work with veterans in local courts, local jails, and they also provide outreach and information to local law enforcement agencies as well. We want local law enforcement who are there at the very front of the process to be as informed as possible about the VA services that are available for veterans in their communities, and hopefully to avoid negative consequences where those can be avoided in crisis encounters. Healthcare for Reentry Veterans, or HCRV, is the state and federal prison outreach program that you see detailed here on the right-hand side. Again, the basic function of both of these programs is to conduct outreach in justice settings, assess veterans' needs, and help them connect to those services as soon as possible. There are a couple of key differences here. One is size. The VJO program is considerably larger than Healthcare for Reentry Veterans, and in fact, we're going to be adding another 50 VJO specialists to the program this year. But when you think about it, that makes sense, given the size of these components of the criminal justice system. So there are over 1,000 state and federal prisons across the country, but with more than 3,300 counties across the U.S., VJO specialists are working primarily at the county level. Each one of those counties has a local court system. Most of them have local jail systems as well. So VJO ends up being the much larger program and one that's continuing to grow. So if we could go to the next slide. So what do we know about the veterans that we're serving in these programs and what we can do for them? Is this outreach productive? What's the result of all this? The first thing that we've learned, and an important thing that we've learned, is what a high-need population this is. The levels of mental health and substance use disorder diagnoses among veterans who are served by these programs is more than double the rate that we see in the overall VHA patient population. And particularly striking, I won't rattle all these numbers off to you, but particularly striking to me is the fact that in the VJO program, more than half of the veterans who we serve go on to receive both a mental health and a substance use disorder diagnosis. So our average veteran is dually diagnosed in the VJO population. So this is a group of veterans with a significant level of needs, and they're often a clinically complex population to serve. The news on access is good. The veterans who we serve in these programs are accessing responsive VA treatment at high rates, again, compared to the overall VA patient population, and they're staying engaged with that treatment over time at lower rates, but rates that are still robust. So the short version of all of this is that this outreach is serving the intended purpose, that we're finding the veterans in criminal justice settings who need these services, and we're successfully helping them connect to them and to stay connected to them over time. Next, please.
Sean, I'm afraid I'm going to have to interrupt. We need to move on to our next panelist in the interest of time. Are there any last comments that you'd like to make?
Oh, sure. I will close and just say that my final slide, if we could pull that up, is probably the most important one, because this is contact information for myself, my colleague Jessica Blue-Howells in the HCRV program, and critically, local staff in the two programs at sites across the country. So please feel free to share that with any communities that may be interested in partnering. Thank you.
Thank you, Sean. And again, I apologize for shortening your presentation. Marguerite, are you back on the line?
I'm back, and I thank you, and I apologize. I'll be as quick as I can. I'm Marguerite Servish, and I work for Medicaid in the federal government. And what I'm going to cover today is when can Medicaid pay for health-related services to persons after they are released from incarceration. So first, what is I'll go to the next slide. I will go through the definitions briefly. An inmate is a person living in a public institution. That's not a very helpful definition, but a person could be an adult or somebody under age 21, which we consider a child. Now, the public institution is an institution that is the responsibility of a governmental unit or over which a governmental unit exercises control, and it includes various types of correctional institutions. Next slide. Medicaid cannot pay for care or services provided to inmates of a public institution when they are in that institution. However, next slide, please. There is an exception, and the exception to when Medicaid can pay is if the person is admitted to a hospital, a nursing facility, an intermediate care facility for individuals with intellectual disabilities, or a psychiatric residential treatment facility. Next slide. Now, let's see. The only thing I want to comment on this slide is that there are Medicaid requirements that are going to have to be met. As with any service, there are Medicaid requirements, and these are a few of the ones that would have to be met for somebody to get coverage of services. Next slide. Okay, eligibility and enrollment. I'm not an eligibility expert, but I got a couple of slides from our eligibility staff. Incarceration in and of itself does not disqualify an individual from Medicaid eligibility, and it's our preference that the Medicaid eligible person who's incarcerated is placed in a suspended eligibility status or a suspended coverage status because it's easier to reactivate their Medicaid when they are reentering into the community. Next slide. This is an important slide. This one tells you all the instances when the exclusion no longer applies over and above the admission to a medical institution. Basically, all four of these instances is what they have in common is that the person has been released. They're on parole, they're on probation, they're on home confinement, they're voluntarily residing while other arrangements are being made for them to transfer to a community residence, or they're living in a halfway house. Next slide. The halfway house situation is where the person has freedom of movement and association according to the tenets that are listed there on the slide, and states make this determination on a case-by-case basis. Medicaid and the federal government don't make these determinations. So a halfway house, again, is another time when we will pay for services, Medicaid-covered services that a person may be eligible for in a particular state. Next slide. I only want to mention this Institution for Mental Diseases exclusion because if a person is admitted to a psychiatric facility, they may run into another exclusion where Medicaid could not pay for their services in what we call this Institution for Mental Diseases. Next slide. But there are two exceptions when we will pay. It's when somebody receives psychiatric services and they are under 21 and the facility complies with all the requirements that are listed here on this slide, slide 258, or when the person is 65 or older in an IMD, again, when one of the facilities listed meets our federal requirements. Those are two exceptions when we will pay for someone receiving care and services in what we call an IMD. Next slide. I'm going to go right to the caution on this slide. Even if an inmate is an inpatient admitted to a qualified medical institution, if the facility is an IMD, i.e. if they're not in one of those exceptions, we cannot pay for services provided to that individual in that institution because it's an IMD. Next slide. This just says that Medicaid can help pay for administrative matching when help is needed to help people in prison apply for Medicaid or to reactivate their Medicaid eligibility. Next slide. Here's two resources. Our state health official letter basically goes into much greater detail than I did just now. And then the state survey agency director letter should be read in conjunction with Medicaid state health official letter. Next slide. And I think that's it, and that's my contact information. Thank you all.
Thank you, Marguerite. Just one caution to states, even where what we found is, even where there is legislation that allows for Medicaid suspension, it's important, whether you're a local official or a state official, to follow up on how well that's being implemented. We found very often that there is Medicaid suspension allowed, but it's poorly implemented, so Medicaid is still terminated very often. So it's important to follow through on implementation of a lot of the things that Marguerite addressed in her slides. That concludes the symposium today. I'd like to turn the final session to Dr. Lark Wayne, who's going to do some wrap-up comments. Lark.
Well, I started out today saying good morning. I think I should say good evening, and the microphone. This has been an incredible symposium, and it's actually been kind of like a marathon 7-hour webinar. So I can't thank people enough for sticking with us today. I think we had about 500 plus people with us throughout the day. I want to say kudos to our technology folks. I was very concerned that we would have technology crashes, but other than a clicker that had some synaptic difficulties, we were fine. I want to very much thank our presenters who came on at the right time, speaking on the right subjects. That was also quite a challenge as we were across 3 or 4 time zones. I think this has been an incredible information-packed event. I feel like I've sat through a semester of classes in this one day and thought I knew a lot, but I realized I didn't know so much and learned a lot, both from the community examples, things going on in the states, as well as from our federal partners and the myriad of resources available. And thinking back to where we started with Pete Early's tremendous story of his very tortuous travels with his son through various behavioral health and criminal justice and community support or non-support systems, and listening to what we heard over the 6 panels we had today, I think we have pieces of exemplary programs and resources and work and practitioners in different arenas that if there was some way we could piece it all together, we would actually have the beginnings of a true, perhaps, continuum of care. Our objectives in starting out were to really share information about what's going on at the intersection of criminal juvenile justice and behavioral health. I think we learned a lot about that. But our second 2 objectives, one, looking at innovative and exemplary programs and resources, are really to not just pound into us that we have problems and we have a broken system, but in fact we have programs that work, real innovative programs across the country that we need to learn more about and figure out how we replicate them, modify them for different communities, and scale up. And then certainly the federal resources available from our different agency partners or within HHS and across departments. I think, I don't know if anybody knew about all of those resources available. So I wanted to say that in terms of some of the questions that came in, there was a theme of, can I get more information? And there were quite a number of questions that came in as well. So for those of you who are registered for this symposium, you will get an email from us that's requesting feedback on this day-long symposium. what worked well for you, what didn't work well, what you found helpful, other topics you would like us to do this on, maybe not 7 hours at a time, but other topics that you might want us to focus on and share resources. So please look for that email. And I believe the questions that came in that we couldn't in this format directly address, we will triage them out to our experts and to our PRA experts, to our federal experts to get responses to you as well. In terms of just a few closing themes, other than the fact that people really had stamina to go through this day, what struck me is that in listening to the innovations and even listening to the resources available, we're not talking about needing a vast infusion of new resources. We heard a lot about people redeploying, rescoping, reusing existing resources in their counties or in their states. We heard a lot about the need for political will, that there maybe had been some mandate from the state to reduce jail involvement, particularly of people with SMI, and that gave leverage to people to do things in their counties. We talked to you about 8 principles that SAMHSA has developed with its partners, and probably the principle I heard constantly running throughout was collaboration. Collaboration in different configurations of parties, listening to the collaborations that Ryan Moser talked about through the supportive housing work, listening to the collaborations that Johnson County, Kansas talked about in terms of shared data, listening to the collaborations that are really intended by the CIT program from Ron Bruno. That was a constant theme, and how do we really look at the whole realm of players and different, we all have our own system and we put ourselves at the center of that system and our collaborations, but then that means we have to layer on with other systems that might be centered on housing or centered on school-based programs, and really think, how do we really advance these collaborations? I also heard a lot about refocusing and reinventing our crisis response models, and what does that mean from the perspective of law enforcement? What does it mean from the perspective of health, of behavioral health? We heard a lot about clinical types of work and screening and assessment, but we also heard that that's necessary but maybe not sufficient, that we also have to pay attention to such things as benefits and coverage and clearly social determinants of health. And the one that was running through a lot of the presentations was housing. So I don't want to keep people any longer. I really want to thank our federal partners, thank my SAMHSA colleagues, thank very much our SAMHSA GAIN centers and our colleagues at PRA. PRA, you did a tremendous job, and I know you've had 2 of your staff glued to the computers, making sure everything went smoothly. We want to hear from those of you who participated on it. Maybe you've hung up by now, but any of you are still there. Please send us your feedback so we can know, did this format work for you and what could be future topics. Anybody in the room, anything else that we need to think about, or did I forget any messages or reminders? Okay, so I want to say terrific. We pulled this off, and congratulations, everyone, and thank you all very much for the work that you do. Thank you. Are we off?